Good morning. My name is Dr. Perry Gray, and I'm the Chief Medical Officer for Shared Health Manitoba. It gives me great pleasure to provide introductory comments about Bug Day 2020. Bug Day celebrates its 24th anniversary this year. To be asked to give opening remarks on Bug Day any year is an honor. To be asked in 2020, the middle of the COVID-19 pandemic, is both an honor and very humbling. We are experiencing a once-in-a-century event. The world has seen nothing like this for 102 years, the 1918-1919 flu. Long before COVID arrived, historians wrote about the 1918-19 flu. Well past the year 2000, they were still writing about 1918-1919. One day, historians will write about 2020. What will they say? What will our children say? Our grandchildren? Will they say we came together with appropriate physical distancing, cared and supported each other, followed public health advice, followed best medical evidence with regards to treatment, and therefore, while some lives were tragically lost, the loss was markedly less than it could have been, and we emerged together. For Manitoba, Chapter 1, March to July 2020, I believe historians and our descendants will say we got it right. But what about Chapter 2, October 2020? Will it be like Chapter 1, or will they talk about COVID fatigue, division and doubt, rejection of public health principles, and say how we lost our way? I hope not. I hope chapters 2, 3, and 4 for COVID look like chapter 1. We did well, not perfect, but well. I want us to continue to do well. I hope we do better. Perfection is not realistic, but better is. Bug Day is about doing better. It is about how we move forward, how we improve, and that is why I'm honored and humbled to give opening remarks. This program has received in-kind support from the Max Rady College of Medicine and the CPD Medicine Program, University of Manitoba. On behalf of Shared Health Manitoba, the Health Sciences Centre, the University of Manitoba, and the Bug Day Planning Committee, I would like to welcome you to Bug Day 2020 and wish you a wonderful day of learning. I would now like to turn the program over to Dr. Richard Rusk, Director of Continuing Professional Development, Faculty of Medicine, University of Manitoba. Thank you. Stay safe and well.
Well, good morning, everybody. Thank you very much, Dr. Perry Gray. That's a fantastic introduction. My name is Richard Rusk, and I'll be your moderator for today. So welcome to this Bug Day 2020. Welcome to the 2,300 plus registered attendees joining. So you're joining by YouTube. There's some people joining by the Manitoba telehealth sites. This is just an incredible opportunity for everybody. And with it being on YouTube, this link will actually be available in about a week, so you can watch this again. So if you really enjoy those Netflix binges, you can do a Bug Day binge if you really want to. So that's good for the future, because there's going to be so much information over the next, I believe, 7 hours. So that's really good information, and good to know that we can watch this again. So before we move on, I think it's really important that we do make some acknowledgements. The University of Manitoba campuses are located on the original lands of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So those that were registered online for CPD, so everyone that is actually looking for their credits, it's really, really important that you follow a few steps. And this came out in the email, but I'll go over it again quickly. So you have to go to slido.com, so SLIDO.com, and you enter in hashtag bug2020. And that way you will actually have to go through your register yourself, okay? And there's a slide up there that's showing you what to do, and you register yourself. And that way, at a later stage, you'll be actually able to download your certificate and claim your credits, okay? And unfortunately, because we've got so many people, it'll probably take about 2 weeks for that to all come through. And then the other really important thing today, because we have so many people, this is through Slido. It's a way that we are actually interacting with those out there. So you would first have to go to the welcome poll, you put your demographics in and that sort of stuff. And that's really important for us as our CPD department, because we can then understand who's here, and then we can also then capture your questions. And so that's the point I'm trying to get to. You'll use Slido to enter any questions at the end of or during the speakers' talks. And then what we'll do is and you'll see when you go into Slido, you can actually rank the actual questions. And so we will be asking the questions that people see are the most important. And but between each speaker is going to go for just 15 minutes, but at the end of all 3 speakers throughout the day, we will be having these panel discussions. And that way we'll be able to get to hear different answers, and we want to make sure that we have the best questions coming forward. So I'm honored to be able to introduce our next 4 speakers. So we have Dr. Poliquin, and he would be speaking to us from the Public Health Agency of Canada. And then we have Dr. Rusin, who's speaking to us from Manitoba Health. And then we also have Dr. Van Kessel, who is also from Manitoba Health, but he's our lab director. And then Dr. John Amble, who has been the brains behind Bug Day, and he's coming to us from the Winnipeg Regional Health Authority. We will be we'll be strict on our speakers so that we can get to hear everyone. And I would like to start with Dr. Poliquin, and he'll be talking about the federal approach to how we've been managing COVID-19.
Thank you, Richard. I think that's a very kind introduction. I think, though, John wanted to sort of give us a bit of context. So over to you, John.
Thank you. Now, if you can be so kind as to share my screen, as somehow I've done something to my screen, that would be tremendous.
Oh, we were seeing it before, John.
We were. Thank you. So I'd like to begin by...
So John?
Yes, sir.
Yeah, there we go. Perfect.
Thank you. So the objectives for this session, entitled The COVID-19 Pandemic, Looking Back to Move Forward, 3 very basic objectives: state the positive predictive value of what a test means, state the meaning of the basic reproductive number, and list factors involved in containing a pandemic. What I'd like to do for you is give you context as seen through the eyes of our local newspaper. So last October, we saw how the newspaper planned for Halloween, the costumes that nobody wanted to see, this diabolical costume, cold and flu season, truly awful. Then November, in the Free Press, we see flu shots waiting area, bad flu season predicted. Even the flu bug was coming for a shot. And then in December, dangerous diseases back with a vengeance for 2019. Little did we know what lay ahead. Then early January 2020, we already wanted to return 2020. And then as the year wound on, just a few days later, we hear the words Wuhan, coronavirus, novel coronavirus. Little did we know what really lay ahead. First, there was no human-to-human transmission of the coronavirus. Then there was mass confusion. The World Health Organization is providing guidance. We see that the sun tells us that this is the year of the virus. And that was a prophetic prediction. We now have mass confusion. China extends holidays. We believe that the risk of virus spreading in Canada, and in particular Winnipeg, is low. A meeting is held at the University of Manitoba where local health authorities meet to discuss where we are going with coronavirus. We believe that the risk of catching the virus is low, and certainly low in Manitoba. And then we believe that there's likely a lot of coronavirus pandemonium as opposed to true disease. But as life grumbles along, we see the stock markets crumble. Otto warns us about travel to foreign countries, particularly China. And coronavirus is declared a global emergency by the United Nations. Now the questions about masks and whether they provide protection or not arise. And then we get a dose of reality. A traveler, maybe with coronavirus, shows up at the Winnipeg airport. Now it's real. The cruise ship industry is in peril. Who in their right mind would get on a cruise ship, particularly now? The Olympics are basically put on hold, but we're thinking about what's going to happen. We don't know what's going to happen. The stock markets crash, and medical mask prices in Amazon skyrocket. Canada offers coronavirus aid to China. There's an irony with that, you know. The world really isn't ready for coronavirus, says the WHO. And local travel medicine expert and medical officer of health, Pierre Plord, says disease takes no vacation. In fact, you could catch disease on your vacation. Now, Teresa Tam tells us all about the cruise ship evacuees, how they're being quarantined, and where we're going with this. Well, the students are likely going home, but we don't know that yet. And then it's here. It's on the front page of our papers. Pandemic hits home. It's here. And now we learn new words. Social distancing. This poor fellow in the lower right-hand corner clearly looks shell-shocked from what he's seeing on the news. And this goes on and on and on. And then we realize what happened in March. COVID-19 entered like a lion, and people see toilet paper as a security blanket. Travelers are ordered to quarantine, and this is a serious moment in history. This may be, as Perry Gray mentioned at the beginning, one of the pivotal moments of this century. We're entering uncharted territory, and the virus fight is in the public's hands. And as you can see here, it really is in our hands, and we want to get the virus off our hands. And then in early March, or actually late March, the first Manitoban dies, which makes this absolutely crystal clear that this is not a joke. We now start locking down schools, healthcare facilities, and the Russians, the British, the Canadians, and the Americans send all their workers home. And for the spring, the wardrobe is basically a hazmat suit, and it becomes hockey night in quarantine. The Olympics are suspended, and we realize that virus is spreading in our community. Even the Taliban realize that this is bad, and a ceasefire is planned. And we develop cabin fever. The other thing we develop is awful haircuts. We realize that coronavirus is stealing our freedom. And we also realize the importance that teachers play in schooling of our children, because we can't do it, or certainly not do it effectively. The Easter Bunny brings us toilet paper, and our pets are on strike from being walked so frequently. May brings the Victoria Day long weekend, and a weekend like no other. Even poor Queen Victoria has to wear a mask. Our graduates realize that there's a graduation, but there really isn't a graduation. And other countries realize that the virus is reappearing once restrictions are eased. June brings the end of a most unusual school year. And in Canada, we finally achieve unity from province to province. And that unity is keeping the border between Canada and the US closed. And then summer fashions, the bikini for men, the two-piece bathing suit, and of course, the trikini for females. And you can only imagine how ridiculous these tan lines are. But when we look at the economy, this is what's driving everything that we're doing, other than trying to keep our community healthy. We realize what deficit spending means, and it's nothing good. People are distanced from their paychecks. And of course, not dissimilar to Pac-Man, coronavirus gobbles up our markets, our trade, travel, tourism, every kind of social and sporting event, and of course, freedom. Industry realizes that their profits aren't going to be what they predicted. Wall Street is crashing, the TSX is on Skid Row, and of course, what lies ahead is only going to get worse. There is great anxiety as coronavirus is going to have a lasting impact on what lies ahead for our economy. Malls face catastrophic hits, and famous retailers, JCPenney, Chuck E. Cheese, are in trouble. They're filing for bankruptcy, and Air Canada gets a massive hit. Our incoming president of the University of Manitoba discussed post-pandemic prognostications, which there's nothing good in that prognostication. And Tony Roma's disappears. There's a wave of bankruptcies anticipated. Fashion retailers are hit hard because everyone's now at home in comfy clothes doing work from home. Brooks Brothers files for bankruptcy, as does Lord & Taylor. This is scary business. However, in Manitoba, we have a mask that was designed here to protect our healthcare workers. And there's a company producing swabs for COVID testing. What's happening is local businesses aren't having any foot traffic, while Amazon continues to deliver stuff to people's homes because people are afraid to go to the shops. Everyone's at home, and the home renovation industry takes off. Home Depot can't get enough lumber or paint. Manufacturers shift gears from making cars and regular apparel to gowns and masks. Stanfields stops making underwear and starts making masks. Same thing with Canada Goose. And Bauer stops making hockey equipment and starts making face shields. Local manufacturers, pub owners and the like, start making hand sanitizer. And of course, treatment. And Ryan Zarachansky is going to talk to us about the facts and fiction. There was much hope placed on hydroxychloroquine, which ended up being complete witchcraft. And of course, one of the world's leaders made a comment about using disinfectant injected to help save our sick coronavirus sufferers. But unfortunately, this would seem to be a little bit misguided. And unfortunately, poor Dr. Fauci was ignored. Then the question of a vaccine arises. And there's great hope placed on the vaccine, and countries are working hard to develop this vaccine. And all of a sudden, there's a hack of vaccine production agencies. And several days later, the Russians report that they have a vaccine. There's something very fishy with that. The President of the United States develops coronavirus, gets experimental treatment, but unfortunately downplays the impact of the virus. While everyone is home, cannabis sales go through the roof, and alcohol consumption skyrockets. Now, we thought that faith would, organized religion would be affected, but our religious leaders switch gears. This priest in the north end of Winnipeg does drive-through baptisms and confessions. Funerals take on a whole different means, and attendees at a strip club in Toronto are exposed to coronavirus. Now, the Sturgis motorcycle rally goes on as planned, and believe it or not, 250,000 people are infected from that rally, either directly or indirectly. And closer to home, Hutterite colonies and some First Nations communities are affected by coronavirus. And of course, our chief medical officer, Teresa Tam, suggests that we should go solo in relationships. I'm not sure what she means, but I'm going to leave that to your imagination. And then virus fuels predators. Not only is there child exploitation online, but also financial scams. And then we meet some of the most hazardous materials and items in the world. Leaky radioactive waste, ticking time bombs, rabid bulldogs, and of course the COVIDiot, someone who doesn't follow accepted convention and practices. People go to work from home, and look, this boy finds his mother in the boardroom. And then of course, the Zoom conference isn't sacred, it can be hacked. Life as we know it changes. There's a new etiquette for riding elevators, and buffets disappear. People start cooking from home and making bread. Activities that we've taken for granted. Folklorama is canceled. Carpooling is deemed risky, and the teddy bear picnic goes viral. Sorry, not viral, goes virtual. While the world is preparing for what lies ahead, people line up outside gun shops in the United States, and a lady is arrested for coughing on a shop clerk. We have grave concerns about how people are handling this. We're concerned for our First Nations people. We're concerned that young people are attending bars and parties. Divorces are believed to flourish because people are now together at home and realizing who they live with. And the flip side, births are anticipated to skyrocket in December because people are at home and not having much to do. We're afraid that we might spread COVID to our pets and certainly the elderly. And we're concerned about bar hopping. And thankfully, Dr. Roussin, with the help of public health, has suspended bars. The cruise ship industry is sunk for the time being. And we realize that holidays at home aren't that bad. And they're probably pretty safe. Famous celebrities, Prince Charles and all of the world's leaders, come down with COVID. John Prine, a phenomenal and famous folk singer, perishes. Though even The Rock succumbs to this. Boris Johnson ends up in the ICU, and the Prime Minister and his wife develop COVID, as does the President of the United States. Fatalities. Now, we really don't know what the true number of deaths were in China, but it's suspected that it's far higher than reported. Behavior. Everyone's accountable for their behavior. And we've seen some truly questionable behavior. And hopefully in Manitoba, we will adhere to the norms and appropriate behavior. However, some of our leaders have shown some missteps with how they've handled coronavirus. The first case of coronavirus was 6 months prior to September, and it was quite a ride, as Dr. Gray indicated. And masks. We all believe that masks are of benefit, but the mask became a political statement. We now meet who designed and created the first N95 mask. The mask becomes a fashion statement, and we realize that, in April, people wearing masks were weirdos, but as life went on, those not wearing masks were truly the weirdos. And concern was raised about the availability of masks and whether healthcare workers had masks, but we have gone out of our way in this province to ensure that our healthcare workers have appropriate personal protective equipment. And Dr. Roussin announces in September that it's time for Manitoba, and particularly Winnipeg, to mask up. Magda Yunus, a famous Manitoban scientist and physician, created a ventilator that is now in production. Professional sports take a hit, and somehow the NHL pulled it off. And Peter McDonald's going to talk to us about how they did it. Tokyo may not have a vaccine, and kids go back to school. Thankfully, transmission in schools has been very, very low. Children have had disease in school, but acquired in the community. And of course, here is the wardrobe for back to school this year. Mental health is a significant issue with social isolation. And we'll hear about that a little later on, particularly for university students who are now at home doing online learning. A Thanksgiving like no other. What family of four could demolish a 25-pound turkey? Not possible. Some parting words before I turn things over to Brent Roussin. We have no idea what lies ahead for wave 2. We're certainly preparing, and our facilities, healthcare facilities in particular, are preparing and hopefully prepared, but we don't know what's coming. We have to have faith in our medical experts. And one of the dilemmas that we're going to be faced with is your runny nose and sore throat the flu, coronavirus, or just a cold? Our medical officers of health become rock stars. Teresa Tam and Bonnie Henry have T-shirts designed after them. And thankfully, we've had Brent Roussin and Lynette Saragosa as our voices of calm, and hopefully they'll continue to guide us into the future. We realize who our new superheroes are, and we know that life will not return to normal for a long time. And as life has evolved, we've realized that humans should have evolved 6 feet apart. And our healthcare workers, some have not been adhering to optimal hand hygiene practices. We hope to keep the borders closed and keep coronavirus out. And I agree with this pharmacist, it is imperative that everyone goes out and gets their flu shot so we don't have a twindemic. Hopefully we can hit the reset button soon on 2020, and hopefully the labs will continue to serve us and serve us well. Halloween, and I'm not sure why Halloween hasn't been canceled, but this is the costumes that will be coming to people's doors. Vampires, witches, and Frankenstein, all in hazmat suits. And our biggest challenge right now is going to be how we handle ourselves in the face of COVID. and hopefully we will all exercise good judgment and excellent behavior. Brent, the floor is yours.
Okay, thanks, John. Just share my screen. Hopefully that's coming across. So, morning, everyone. Thanks for joining us, and it's great to be here in Treaty 1 territory presenting. And so we are, 9 months into this pandemic, and it's changed all our lives and the way we interact. And moving forward, we're still dealing with uncertainty. We went through some of these objectives, and myself and co-presenters will be touching on all of these as we go on. I'll certainly be touching on our non-pharmaceutical interventions, as well as some public health law and ethics, since the Public Health Act has really got a workout during this pandemic, and it's been used probably never like this in the past. So just taking us through, I'm going to talk about just our current epidemiology, take a look at where we stand right now, and then go right back to the beginning and take a look at some of the information we're receiving quite early on, the assumptions that we were forced to make in a way to develop a plan to an emerging virus, and talk about some more familiar topics now, the R value, the basic reproductive rate or number, and some people refer it to R naught, and as public health gets more mainstream, it's a popular term. And talk about other popular terms like herd immunity, and get a crystal ball going and trying to look for the future. So we can see 9 months in, a lot has changed. We're just over 3,000 reported cases, and we're well within this second wave right now. Our test positivity rate has been climbing, although our disease severity has stayed on par, but we know that can change over time. If we look at our total cases that we see, very likely, just like any other respiratory virus, the actual cases are much greater than those that are reported for various reasons. But even if we look at actual cases multiple fold times higher than what our measured is, we're looking at Manitobans still greater than 99% of them susceptible. So we're not approaching anywhere near what we would talk about or call herd immunity, which we can delve a bit further into. We look at our epi curve. You can see it's very clear that we're into our second wave. We can see that first wave where, because of a lot of uncertainty of a virus, we had very severe shutdowns. Very severe travel restrictions, and in Manitoba, based on a number of factors, including just the timing of our spring break, we were able to get through that first wave with relatively few cases. But we can see our summer, which was again a light time as far as case counts, but we can see that clear transition into the second wave. And our second wave is fairly unique. We see it bimodal there. It's clear to see where we saw that peak in August in the Prairie Mountain Health region, where we activated our pandemic response system, put restrictions into Prairie Mountain Health, and saw that decline in cases. But just at that time, we started seeing the increase in the Winnipeg metropolitan region, and now added those restrictions in that area, and expecting much the same trend now that those restrictions are in place. So we look at the very beginnings of this, when we started hearing of clusters of pneumonia in Wuhan and what this would look like. There was a lot of uncertainty early on. And so I remember in January, early January, in our war room that we set up here on the whiteboard, trying to plot out any information we could get our hands on. And so very early on, even just basic descriptive data was very hard to get your hands on. We would have case counts from Wuhan, but very little that we could plot our own epi curve on, which meant that it's very difficult to understand things like what the incubation period would be, what the infectious period would be. And so even getting our hands on data, just a person, place, and time, very basic descriptive epi was very challenging. At that time, we struck our special advisory committee with the Council of Chief Medical Officers of Health, with great collaboration with the Public Health Agency of Canada, and in a very, very challenging time, a very difficult time to put information together, to collect information. The Public Health Agency of Canada really stepped in to provide the Special Advisory Committee with whatever information we could base some of these assumptions on. Later struck a technical advisory committee, and these are still working hard now to constantly review new evidence as it comes. So, but things change. In mid-December, we still had written on our board whether there was actual person-to-person spread or whether it was quite limited. And so it wasn't until things continued to develop that we saw this was clearly transmitted person-to-person. We didn't know for sure the mechanism of that, and later determined it to be a largely droplet spread, and made a number of assumptions regarding early on that incubation period, that infectious period. What are the risk factors? We know now that one of the biggest risk factors is age, those over 65, those with underlying medical conditions. But we have to learn that over time, as well as the infectious period. And this is something that we've changed over time, the infectious period. We made the assumption of 14 days. Certainly for something like that, you want to err on the side of caution. But we learned that for most people, it's less than 14 days. Usually it's somewhere around 8 to 10 days. And so we have changed over time based on that evidence.
Hi, Brent.
Yes.
Just to let you know, there's just a little less than 5 minutes to go.
Sure. The basic reproductive rate is something that we've heard over time. And really, this is the abstraction, a theoretical number of the amount of cases that would be spread by an infectious person to an entirely susceptible population. And so this is not just an inherent value of a virus. It has many modifiable variables. And in fact, in a response to a pandemic, much of everything we do is try to decrease this number below 1. And we can see the beta there as the risk of transmission or the probability of transmission with coronavirus. This is where we get the contact and droplet precautions. This is where physical distancing came from. This is where masks came from, sanitization, and kappa is a number of contacts. And so this is the concept behind isolation. This is the concept behind physical distancing and many of our public health restrictions is to reduce the amount of contacts a case may have. The duration of infectiousness certainly is an inherent quality to the virus. And so we can't do much about the duration of infectiveness. We could say that isolation, essentially the effective duration of infectiousness is decreased, but this D becomes important in other factor in other diseases, say like our outbreak in syphilis right now. The sooner we're diagnosed and the sooner they're treated, we decrease that duration of infectiousness. So it becomes much more valuable in those type of conditions. So you saw our pandemic response system, this targeted approach to disease transmission. We know that our public health restrictions have been effective, but we know they come at great cost as well. So we wanted to have a very targeted approach to restrictions as we move forward. And we've seen that displayed in Prairie Mountain Health. We're now seeing it displayed in Winnipeg, and we'll continue to use our public health measures to to guide us forward, to try to limit the severity, limit the morbidity and mortality of this. So these are our non-pharmaceutical interventions. Because we had no vaccine, because we had no effective treatment, we had to rely on these non-pharmaceutical interventions. We started with messaging of physical distancing, messaging of staying home when ill. But over time, we had to become more stringent with these messages, and took actions through public health orders, but brings in a lot of our ethics. We think of the harm principle. We don't affect behaviors unless there's harm to others. We definitely want to use the least restrictive means. We have to do it in a transparent manner. We publish all of our public health orders, who they apply to, how they apply to, and then reciprocity is that challenging one, where if we're limiting businesses, if we're having people stay home from work, we have to find ways to ease that burden on them. The Public Health Act is used like it's never been used before, and just a few examples of the major sections that we used. And you see Section 3 here really just codifies that least restrictive means are necessary. So that's a codified public health ethics right there. We've used Section 33, Emergency Health Hazard Order, to close a premises that didn't follow public health orders after repeated recommendations. 43 is the communicable disease order. So these are infectious individuals who are refusing to self-isolate. And we can and have issued these communicable disease orders to mandate that they self-isolate during their infectious period. Certainly rare, but certainly has been used. And 67.1 there you see is the public health emergency. And I don't believe this section had ever been used before. And this is where we had our travel restrictions, our capacity restrictions, the closure of certain businesses, all under Section 61 or 67.1. Most of these very stringent ones can't be done simply by the chief. There has to be ministerial assent on all those. And 78.1, and really this is an information gathering power, where the chief can require anyone to provide information that he or she feels necessary to limit the impact of the pandemic. And we use this to gather information to institute the one site rule for PCHs. So the Public Health Act certainly had quite the workout. We talk about herd immunity, a lot of discussion about this. Herd immunity, the value of immunity that we require to decrease the R value below 1, and hence diminish the impact of the transmission. We calculate 1 minus the inverse of R naught, and R naught is thought to be around 2.5, which would mean we'd need about 60% immunity. We know right now we probably have less than 1% immunity in Manitoba, and to put that into perspective, to get that naturally, we would need 600 infections per day for 3 years in Manitoba to reach that 60%. So without a virus, we're certainly not going to achieve that herd immunity. Vaccine, there's talks on this, but we're certainly preparing ourselves for a vaccine as soon as one is approved. It's very likely that these are going to be limited, that we're going to only have very small population coverage at first, at least. So we'll have a very targeted approach to those most at risk. But we need to be prepared to see this vaccine in the upcoming calendar year. And we've worked on our guidelines for who would receive, who's most at risk, how we would roll that out over time. But we're still likely well over a year before we're going to have the population coverage that we require to say we're anywhere near done with this virus. Comparing a bit of COVID and influenza, you can see that every year we see a pandemic, an influenza pandemic. Last year we saw 40 ICU admissions, 29 deaths, again with influenza. These are vastly underreported numbers. We don't test for influenza nearly as much as we do for COVID-19. So these are often vastly reported numbers, but you can see that influenza strains our healthcare system each and every year. And so this year, if we're looking at the co-circulation events, that flu shot becomes quite important. Of course, a lot of our public health interventions are going to protect against influenza as well. So we need to ensure we're not overwhelming our healthcare system. And last slide here, the future. What does the future look like? It's very likely we're going to see just like what our second wave looks like, multiple peaks and valleys. Those are going to be happening. We're going to be increasing our case numbers where other jurisdictions' numbers might be decreasing and vice versa. We might have rotating type of restrictions over time. So we're definitely going to see these cases. We know that these type of viruses, we cannot eradicate them. That's not our plan. It's to decrease significant morbidity, mortality, and the strain on the healthcare system while minimizing the impact on other aspects of our other health, including the economy. But it's very likely we're going to see these peaks and valleys over time. And when we say we truly have to find ways to live with the virus, this is exactly what we're talking about with this. So thanks again. Hopefully I didn't go too far over, and I'll pass it off to my next presenters.
Well, thank you very much, Dr. Rusin. So Dr. Poliquin is going to be speaking to us from the Public Health Agency of Canada.
Okay, good morning, everyone. Thank you for having me. I think, oh, Brent, can you stop sharing your screen? Perfect. Yep. Good. So I'm just getting my slides up here. Okay. So good morning, everyone. It's a pleasure and an honor to be here. We acknowledge we're on Treaty 1 territories, but as the Public Health Agency, our mandate is national. So we'd like to acknowledge we operate on the traditional homelands of the First Nations, Métis, and Inuit peoples of Canada. And my job today is to encapsulate the federal lens. Brent was kind enough to really give us a good snapshot of what's happening in Manitoba, but what does that look like at the national level, and how do we negotiate that moving forward? Probably a tall order to do in 10 minutes. I think that exceeds my quota of crisis a minute to go over. So I think what I tried to do today is to maybe pull back the curtain a little bit around a bit, so that we can see what that looks like in practical terms. How do we approach it, and what do we see coming forward? So, as Dr. Emble pointed out, I don't think Dr. Tam or Minister Haidu ever had an inkling of how much they would become recognizable figures in December of 2019 as we embarked on this journey. And they have been tireless representatives of the agency's work and the resolve that's been needed to get us through this. There's obviously a lot of work that goes on behind the scenes to support them. The announcements that they make, the policy decisions that they present, are all informed through a number of factors. But one of the things that has struck me certainly is the careful attention to science as we move through these difficult times. People won't know this very broadly, but Dr. Tam has a journal club every week with a number of different individuals within the agency to go over the latest and the greatest in terms of science. That's also an important place where we discuss some of the deliberations of the Special Advisory Committee or the Technical Advisory Committee, as Dr. Rusin mentioned, to figure out well, what are the outstanding scientific questions and how do we tackle them? I can attest personally to the fact that Minister Haidu has the same appreciation for scientific enterprise, and that is a comfort in these difficult times. One of the key federal roles is to act as convener. As Dr. Roussin alluded to, the timing of the pandemic is not the same from coast to coast to coast. And that's is both a source of strength in Canada, but also of challenge. As you can imagine, by having so many different versions of the pandemic at any one time, landing on a common policy approach doesn't really make sense. We have to have the flexibility that's needed to allow jurisdictions to be able to do the work that they need to respond to the crisis at hand. You'll remember with great pride, I'm sure, that we were down to a single active case in the summer in Manitoba, while there was active transmission ongoing in Quebec, Alberta, and Ontario. So how do we reconcile that? Well, that's one of the key federal roles, is to bring together everyone at the table through the various mechanisms we've had, including the Special Advisory Committee as a good example, so that we can exchange knowledge, exchange practices, and land on a path forward so that we have a common understanding of what is before us, but also have some comfort that we can sort of do what is right for what is happening.
Hi, Guillaume.
Yep.
Sorry, 5 minutes.
Yeah, for sure. I'm with you, Richard.
Okay.
So then what we need to, this slide is busy, but that's a bit of the point, actually. So the other key role for us as a federal lens is to organize a number of initiatives that are otherwise difficult to manage at the provincial or local level when you are already clearly, you're in active response mode. So some of the background work needs to happen still, and the federal framework puts us in a good position for that. So, for example, on the top left corner of the screen, you will see that NML has been supporting provinces through the development of high throughput testing, bringing online robotic capabilities, and doing a lot of scientific work to validate and understand and develop new tests. As the technologies are vetted, then it makes it easier to roll it out into other jurisdictions. Moving to the top right corner of the screen, you'll see we've been actively working in terms of developing guidance documents on a number of fronts, not just infection prevention and control, but testing, and there's even some guidance around a safe Halloween that's been put together. So it's a broad range of activities, and those get routed through. On the bottom right corner, we're also looking ahead to what's next. You'll see here wastewater surveillance, something that's been in the news quite a bit recently. And how do we support that? Well, we've had to ask career bacteriology scientists, Chan Mangat and Mike Mulvey, to sort of completely change their tune and delve into a whole new area of technology and development. And peppered through all of this is a keen focus on scientific endeavor. One often cited publication on length of infectivity was developed in collaboration actually with CADM and NML, looking at length of infection in samples, showing that how long you could culture virus out of samples. And that's a really good example of public health need and question feeding into science, and then science feeding back into recommendations, and all done in our very own backyard. So a couple quick anecdotes before passing it on to Paul. One key aspect also is preparation. The Public Health Agency of Canada was born by SARS-1, and we are being tested like never before through SARS-2. But we had learned some lessons from SARS-1. And one of them was to be prepared to develop diagnostic tests for new coronaviruses should they occur. And with that preparation in mind, I'm proud to say that NML was able to go from the publication of the first coronavirus genome on the weekend of January 10th from China to a functional first generation test 5 days later on January 15th. And that was because of preparation and foresight by our respiratory viral group. I'm a bit of a nerd myself, so I couldn't go without some form of Trekkie reference, but we've also had to take on new roles at the federal level. Dr. McCoy famously said, "I'm a doctor, not a bricklayer," in one of the original Star Trek episodes. But in the COVID world, the doctors are also the bricklayers. And what do I mean by that? Well, early on, there were reagent shortages that was quite widely publicized. And when we couldn't buy anything, the question was, well, can we make it? And how hard can it be? Well, it turns out it's a bit harder than you'd think, but we were able to pull on the expertise that we had here. We actually pulled someone out of retirement, our local MacGyver, who came back from the West Coast and used his experience making extraction buffers out of vodka in the Congolese jungle to develop a functional set of extraction reagents from scratch. And so within 6 weeks, we had our own production reagents ready to go. But then, once you have a recipe, you have to go get the ingredients. And how do you do that? Well, it turns out Amazon Prime does have its limits. And we were in need of something called guanidinium isothiocyanate, which is easier written than it is said. And we needed a lot of it, to the tune of 30 metric tons to support what we anticipated was needed in Canada. And so as a whole of government approach, we were able to send out Transport Canada, Global Affairs, laid the way for us to send a dedicated plane to be able to pick it up. And I don't think Transport Canada has ever felt like the heroes that they were on that day when they managed to bring us back to facilitate everything that had to happen afterwards. And then finally, I know this, Dr. Tam was presenting at the Canadian Public Health Association last week as the keynote address, and managed to put the term Swabageddon into the public domain. And what does that refer to? Well, on Easter Sunday, we were very close in Canada running out of swabs, and from coast to coast. And one of the tasks that was given to us at the agency was to solve that problem. Now, Easter Sunday is not a great day to go shopping for anything, including hundreds of thousands of swabs. But again, rising together across a number of departments and with some high-level phone calls from Deputy Prime Minister Freeland, doors were opened and contracts were signed. It's a funny little anecdote, but one of the suppliers was very keen to give us everything that they had, and also sent in some proctology swabs. And for those of you who've seen them, they're about the size of a quarter in dimension at the head of the bulb. And as keen as we were to receive them, there are mechanical limitations to the use of those swabs. But learning from that and building on those experiences, there's been a tremendous effort put together to develop made in Canada solutions for swabs, reagents, face shields, you name it, ventilators, as John mentioned earlier. And those efforts and investments are yielding fruit now. So in closing, we've all had to learn new things. We've all had to take on new roles. And we're continuing to learn. But ultimately, what will get us through this is collaboration, science, a little bit of luck, and a lot of determination. And a lot of that comes from everyone, all everyday Canadians who listen to Public Health Message and kind of follow the path set forward for us while all this stuff happens in the background. So stay well, everyone. We're in this together. And with that, I'll turn it over to you, Paul.
Well, thanks very much, Guillaume. That's very encouraging. Appreciate that. And it's always great to hear the big picture and some of those things that you don't hear from behind the scenes. So, okay, so we're going to go over to Dr. Paul Van Kessel now. He's a medical microbiologist, and he's also the director of Chatham Provincial Lab, who's managing all those swabs, hopefully none of them being proctology swabs any further. Okay, Paul.
Thanks very much. No, we haven't found any proctology swabs yet, but I'll send them right to you when we do, Richard. Trying to figure out how to get my slides to change. So hello, everybody. Paul Van Kessel, Medical Director of Chatham Lab. It feels like I've been in my office here for about 20 years this year. I'd like to start by acknowledging that we're on Treaty 1 land, that I have no particular conflicts of interest to declare, except that I've really lost my like for this virus. It's proving to be a greater challenge than any other virus I've really had to deal with before. I hope that we can talk a little bit about the steps to a coordinated lab response for both emerging pathogens and pandemics, which are a little bit different but very interrelated, and some probable directions we might be going with this virus. So there is a lab response to emerging pathogen. We actually have at the Canadian Public Health Lab Network what we call an emerging pathogen checklist. And we'd just finalized our work on this 40-page document just a year or two before COVID hit. And so no surprise, I pulled out the 40-page document and started looking through everything that we were going to have to do once this strange pneumonia started popping up in China. One of the first things you have to do, of course, is to assess the likelihood that it'll actually come to Canada. And then you've got some very basic lab things to do in addition to a host of other things. But as Brent was indicating earlier, not only do you have to know about the epidemiology and several characteristics of the microbe and the disease that it causes, but then you have to start figuring out the indications for testing. What will be the best specimen? What is the best timing of collection? And maybe there may be multiple times of collection that you have to consider, and maybe there might have to be multiple specimens one might have to consider as well. For us in the lab world, there's also transport conditions and specimen collection devices that we have to pay close attention to. And then the test itself, maybe it won't be just one test, maybe it'll be different tests, such as a screen test and a confirmatory test, that all have to be developed, and maybe one even needs to develop a gold standard that is used only in the rarest of circumstances as well. And all of that is fine to develop that, but then you really must be able to determine and communicate what its performance characteristics are. And that for most people, we've heard the terms sensitivity and specificity and positive predictive value and negative predictive value a great deal. Positive predictive value has been, and negative predictive value have in particular been relevant to COVID. Positive predictive value is the probability that a positive represents a true positive, and that's a function of not only the specificity of the test, but of the prevalence of the disease or of the condition in the community as well. negative predictive value is somewhat similar in that respect. Then there's responding to a pandemic. So it's always it's almost always going to be an emerging pathogen response as well. But now we know that there's widespread transmission and widespread morbidity at the very least. And so now we have to figure out what our response aim is going to be. And that very much depends on all of that descriptive epidemiology information that Brent was referring to, and whether or not it's feasible to eradicate, to eliminate, perhaps just to control. Perhaps we don't necessarily need to do any of those right away, but we'll need to do surveillance because we understand that it has great risk of doing something worse. Let it ride is not something we usually talk about in pandemic terms, but if you can imagine a new common cold that appeared on the scene, we would probably just keep an eye on it and perhaps do very limited surveillance at the most. Chances are it's a combination of a few of these things. Then one needs to determine how long you're going to be at this particular sort of effort, the resources that'll be needed, and that includes not only public health resources, but clinical resources as well, and what data will be needed on a daily or ongoing basis. And communication cannot be stressed enough. We must constantly be communicating not only with each other, but with the public as well. And at the end of the day, you must realize that a pandemic is going to be a marathon, or perhaps even many subsequent marathons. Harkening back to what Brent was saying, you have to know what you're dealing with. To start with, we didn't even know exactly what this infectious agent was. That's critical to knowing exactly how to respond. Sometimes large outbreaks are not caused by microbes. They might be caused by a chemical or a contaminant of some other sort. You need to know the incubation period, of course, which is the time between exposure and onset of symptoms, the period of communicability, the attack rate or the reproductive number that Brent was telling us about, and any predictive epidemiology or symptoms that you can use to help focus your efforts. So, of course, our global approach was the flatten the curve approach. This is adapted from the CDC, and if you take a look at this, I'm sure it's not lost on most of you that sure, we've lowered the peak of the curve, but we've also broadened the base of the curve. So instead of having a short duration but intense time with this virus, we're looking at a long period with this virus, but hopefully much less intense. So what was going on?
There's less than 5 minutes, sorry.
Gotcha. So here's a brief synopsis of what was going on at CATM, and I mean brief. So yes, lots of testing, but a pile of research and development, a pile of searching for new ways to do things, a pile of ways to find new supplies, take care of ourselves, take care of our families, and to take care of just about every last niche that exists in both the health systems and in the related systems here in Manitoba. And boy, did we do a lot of science. I tried to put together a timeline of how much science we did, and I ran out of room is what it came down to. So it comes down to, here at the lab, we felt that we'd crammed so much science into the first months of the year that we'd done more science than we'd typically do in a 1 to 2 year period, just on COVID alone. Some of that had to be retrospective science, looking at whether or not COVID had been in Manitoba before. We took a look at 18 respiratory samples from ICU patients with an unknown pathogen, and fortunately there was no evidence that SARS-CoV-2 had been in those folks. I look back 11 years ago, the last time I was giving grand rounds about a pandemic, and this is what influenza looked like back then when we were looking at what we expected from influenza. And this is what pandemic influenza had looked like then. I mean, that is what a pandemic curve looks like. And when we looked at our workload, we looked at our 10-year maximum from the 10 years prior, and you could see how the number of specimens coming in was much different. So let's compare it this time. This is what the 5 years prior to 2019, 2020 looked like in terms of our weekly respiratory test volumes, peaking at around 1,100 to 1,200 in a week. And here's what our current test volumes are looking like with our modified 10-year maximum. 10 times as much respiratory specimen volume, unprecedented amount of testing. And just to give you a sense of how much testing that is approximately equal to the number of complete blood counts completed on a daily basis at all Winnipeg hospitals. Here's just a quick look at what COVID looks like compared to influenza A in terms of detections. This is only going until the end of September, mind you, so that peak just keeps going up at the end. But that's not the end of what we've been up to in terms of testing. We've been trying to conduct some seroprevalence studies. So here's a quick look at some seroprevalence from very early on in the epidemic, and it shows that our adjusted seroprevalence was looking like 0.06%. About a month later, CBS, Canadian Blood Services, did a seroprevalence study, and they got about 0.5%.
So is this the lady with the hip?
The hip lady's gone to orthopedics.
Sorry, I'm
Hi, John.
talking in the background.
John, could you please mute? Thank you.
We'll have another seroprevalence study coming up looking at this fall. We've also been doing genotyping, look at the various strains of SARS coronavirus. It was very clear early on that we had a varied number of unrelated strains coming in mostly from travel, but then we did see some tight clusters associated with colony and Brandon outbreaks. And we'll continue to watch what's going on with SARS-CoV-2 genetic fingerprints. We also tried to see what we thought might happen with coronavirus, looking at the other coronaviruses that occur in Canada. So Phil Lagasse-Weens at St. Boniface and those of us at CADM looked at the seasonalities of different viruses. So the endemic coronaviruses that we've been seeing for many years, flu, RSV, and human metapneumovirus, and they all have overlapping seasons. So if you take a look at coronavirus over the last 10 years, not including SARS-CoV-2, you do see that it's got a very particular seasonality. And we anticipate that eventually SARS-CoV-2 will fit into this sort of seasonality that we're seeing with the other coronaviruses, which is a midwinter peak. With all this physical distancing, we saw that a dramatic drop in influenza cases in the spring. But taking a look at Western Australia with their physical distancing, their anticipated influenza and RSV seasons practically disappeared. The black line being their anticipated RSV and influenza curves, but it looks like it's possible we may see very little of influenza and RSV this year. Let's hope. Finally, there was a little bit of talk about maybe tuberculosis would pick up. So I did some look into some more ancient data, if you like. And this was a paper from Switzerland, which didn't really show that tuberculosis really picked up that much. But what I did take away from this paper is in non-immune populations where there's no vaccine and no antivirals, you can definitely anticipate additional waves of the respiratory virus. So I'd like to thank everybody who's been part of the COVID response. I mean, let's face it, we've all been part of the response. But I'd like to express my particular thanks and favoritism towards the staff at CPL CADM Lab here, who've been champions since January. Stay well, everyone.
Thanks very much, Paul. Lots of information, but it's good to see those graphs. Get some perspective here. So, okay, well, I really want to thank all the speakers. We really appreciate that. We will actually, I know there are some questions here. I'll keep an eye on these questions and see if we can pull them in to some of the later question periods. But I don't want to fall behind. We have got a really, really full day. And so I'd actually like to move straight on to our next person. And so our next person is Dr. Jared Bullard, and he's also from CADM, but he's also a pediatrician and a specialist in infectious diseases, which actually Dr. Paul Van Kessel is as well. And So I'll just move straight on to Jared.
Thank you, Richard. Yeah, this has been an interesting time. And of course, the topic that I've been given is sometimes boring, but I'll try to make it as entertaining as I can. First, I have no conflicts of interest to disclose. I will be talking about specific testing platforms, but it's more a matter of convenience. It's actually not that I'm suggesting this is the one and only option that's available. So the main objectives really are to talk about the specimens that you're going to need to diagnose someone with SARS-CoV-2 and COVID-19. We're also going to talk a lot about the different tests that are available and what advantages you have with each one, as well as some of the challenges that you would expect. We're also going to talk about some of the indications for serology, which has been something of interest, particularly as we go forward in this pandemic. So when you think of COVID-19 testing, what comes to mind? I would say that for the vast majority of Manitobans, they think about this. So if you've had the misfortune of being in a line waiting to get a swab and you've gone through the 5 stages of grief, you realize that there's many challenges, and as Paul alluded to, the volumes alone make it such, right? But there is some other things that you can consider too, of course. You think about that swab, and in particular, there's a number of people who don't care for it. They said it's like sampling the brain. At the lab, we have sampled all sorts of swabs that are comfortable and downright uncomfortable. If I could give any piece of advice for you, you have this healthcare worker doing a swab on that young lady. She is in full PPE, which is important, but notably she's standing right in front. So if you want to reduce your risk even further, just stand to the side. And that way you'll be able to, if she happens to cough and or sneeze, you're not as likely to get hit with any of those respiratory secretions. So this beautiful glass structure is actually SARS-CoV, and I love this particular thing. And when this is all over, this is a gift I would like to get so that I can smash it with a baseball bat. But in essence, what is important to draw your attention to is actual components of the virus, because this is how we're actually doing a lot of the testing that we're doing. So we have specific targets. So this is pretty straightforward and simple. There's the spike protein that you can see there, nucleocapsid, the envelope, as well as single-stranded RNA. And in essence, if you understand those principles and those components, that'll help guide you in terms of the testing that we're doing at the lab. When we're talking about spike and nucleocapsid, in essence, that's the serological tests that we're doing for antibodies to those viral components. And when we're doing PCR or RT-PCR, we're in essence looking for envelope and nucleocapsid sometimes as well. So those are the main targets. When we're talking about PCR, it's a little bit complicated to explain. So remember that in essence, we're taking a small amount of signal and we're duplicating it. And we continue to duplicate that for 40 cycles. And so once you have a small amount of sample or a small amount of RNA from the SARS-CoV-2 virus, we keep doubling it. And eventually we increase that signal to the point where we can see it. Now, if you have more of that RNA to start with, and i.e. more virus, it is likely that you'll actually amplify it quicker. And if there's not much, it will take longer to do, which really leads us into some basic principles that Dr. Van Kessel was alluding to as well. So sensitivity and specificity are important performance characteristics of a testing, of any testing that you're going to run into. And this is something that kept coming up when we were talking about the early stages of testing. And the main thing was that we really didn't know how sensitive and how specific this test was. We thought it was quite good based on our experience with other respiratory viruses. And it was probably upwards of 99% for both of these. But think of sensitivity in essence as the ability of the test to find SARS-CoV-2 in someone who has COVID-19. Whereas specificity is making sure that when we detect a virus from someone, that it in fact represents that pathogen. So in this case, it would be that SARS-CoV-2. So what is a good sample? For those of you in the front lines, you've been doing this for a long time. So you've had a sense to you've done a lot of nasopharyngeal swabs. Some other things that also work quite well are nasopharyngeal aspirates, bronchial alveolar lavage or BAL, as well as endotracheal tube aspirates. And so each one of those, when we're talking about PCR testing for COVID, are all very sensitive. They're all over 90%. In fact, they're closer to the 99%, which is quite good until you start to do it, of course, at a population level. But even then, it works out quite well. specificity stays the same. It's very unlikely that we're going to see a detection of some other virus causing a disease that's compatible with COVID-19. Keep in mind that when you do an NPA, that there is a small risk that this will be an aerosol generating medical procedure. And so typically we don't advise doing that. A throat swab is also an option, but keep in mind you're going to lose a little bit of sensitivity when we go down that route. What samples aren't quite as good? Well, we know that serum and blood are certainly helpful, and we do have serology available to us at the lab. And in essence, we're looking at two different targets, as I mentioned before, the spike and the nucleocapsid. But keep in mind that the utility of an acute diagnosis really isn't there, right? So people that typically are in their first 7 days of illness will have a very poor sensitivity. And it's usually once we get well beyond the 14-day mark of symptoms that maybe that serum is useful. So from an acute setting perspective, it's not very useful. It's also really questionable about, does that actually tell you if you're immune to COVID-19 long-term? And we don't know that yet. I think that's something that's going to be coming. Likewise, feces is actually a sample where we have detected SARS-CoV-2 by PCR. Now, it's hard to say if it's representing gastrointestinal infection versus people tend to swallow their snot. That's just the way it is, kids in particular. And so I think what we're seeing is residual respiratory secretions swallowed, and we're seeing some of the virus that's being detected there. So feces is probably not an optimal specimen and not quite as sensitive. What might be coming down the pipe? Well, doing all of these swabs, in particular when we know we might run out, might not be the best option overall. So we've looked at some other alternatives, and we're actively pursuing them. So saliva is pretty easy. You can have someone spit into a sterile urine container, and we can take a look at it. This isn't available widely yet. I'll say that now, so this is all investigational. But overall, it's looking like this might perform fairly well, with the possible issue that it's pretty viscous. Saliva is thick. It tends to clog instruments and is hard to work with. So what's being done right now in BC and Nova Scotia is that they're promoting the use of gargle and spit. So these alternatives are great, especially when you have kids who don't like to have a nasopharyngeal swab. And so the gargle and spit method is where normal saline is used basically to rinse the mouth, gargled, and then spit into a container. And PCR is performed on it like anything else. And so both of these may perform close to as well, but we still have some work that we need to do to verify that this is in fact is a good method. Likewise, we've been sticking this into your posterior nasopharynx, and that's basically what we've been saying. But maybe we can actually do shallow nasal swab, so an insertion to maybe the mid-turbinates instead, and that way we're trying to figure out if that will work equally as well. So what are the indications for serology for COVID-19? So a lot of you are familiar with this multi-inflammatory syndrome in children. And so this is an inflammatory disease that we're seeing in older children than we would expect for something like Kawasaki's disease, and has some other important features, and it's in the setting of COVID-19. So if that is the case, then we will perform serology. We're also, as you saw some of the data earlier, doing seroprevalence studies. So we're trying to figure out, well, how much of the community has had this particular infection, and we have to somehow get to this 60% at some point, which will take a long time, but it's important to make these measurements as we proceed through the pandemic. And of course, there's people who've had their infections back in February, and they're really saying that was a terrible cold that I had. And even though they didn't get their flu vaccine and influenza B was the most likely thing, they want to know if they had COVID-19. If you know me, I'm a pretty sarcastic person. This is in fact not an indication at all. It is not for your curiosity to know if you've had COVID-19, and any test that gets sent in that regard would be rejected. So this is
Jared.
a picture. Yes.
5 minutes.
5 minutes.
Yep.
This is a picture of Dr. Carrie Dust, and so she is known as the Queen of COVID at CADM Lab. She's also the brains behind a lot of the PCR establishment at the lab, as well as assisting the other labs, including Dynacare and as well as Shared Health. And so I am using as an example of our lab developed test. Why that's important is that we have certain availabilities to us too, such as these two instruments. So this is the Cobus and the Panther. So these were available in CADM, and they're very high throughput, meaning that we can do lots of testing on them. And we had them at the lab because we needed to do HIV viral loads and look for gonorrhea and chlamydia as well. So volume, we can do lots of tests with these. but sometimes you want a result faster. And so this is the Gene Expert instrument that's available both at CADM as well as some of the shared health labs. This is where you can get a result in usually under an hour, and it doesn't require quite as much technical know-how when it comes down to it, but it does tend to be more expensive. Possible contenders. So Donald Trump loved to use the ID Now. And so this is a rapid test that comes out in under 15 minutes. We know the sensitivity might not be as good. If it's going to be optimal for anything, it's probably going to be in the very acute setting of maybe 2 to 7 days of symptoms. This great paperweight is a Spartan. So we were excited about it, but we found that overall its sensitivity was lacking. And it's a Canadian product, so hopefully it will come back on the market and be fixed. And finally, we also have this, the PanBio. And so this is an antigen-based test. So it's a little bit different. We're not amplifying any signal. And we're trying to figure out exactly how to use this in this pandemic. So anytime, of course, you get instructions from these vendors, they try to tell you that the sensitivity and specificity is fantastic. For all of those who've gone through the 5 stages of grief, putting together IKEA furniture, know that the instructions don't necessarily tell the whole truth. And so this is something that we've been quite good at doing in terms of research and saying that, you know what, all of these different assays, when we compare them to the gold standard lab developed test, how do they perform? They perform quite well. They're really quite accurate when it comes down to it. So this is a quick slide looking at all the different instruments in terms of what's more sensitive and less sensitive. The take home point from this slide is that Dr. Dust's assay is fantastic. And that if you send us a leaky specimen, in all likelihood, it's the least sensitive of all, simply because we won't process it. So I encourage you to make sure that those lids are on tightly. So what I'll end on is a part of research that kind of shows the public health collaboration and response between the national and provincial level. And so this relates to when we were talking about when to release people from isolation when they had COVID. At first, there was discussion that for hospitalized patients, this would involve a repeat test. And we knew that at the lab that was nonsensical. And by that, I mean that we know that virus can be found for a very long period of time. And it doesn't necessarily mean that that virus is infectious. And so when you look at this, this is basically a host of Manitoba talent that came together to talk about just that question, how infectious and can you predict infectiousness from diagnostic samples for COVID-19? And so when we're looking through this, and I won't bore you too much, a couple of things come to light. So you can see that overall, the number of cycles, so if we have less cycles overall, you're more likely to be able to grow it. And likewise, if you have symptoms for less time, so under usually 7 to 8 days, we're more likely to be able to grow virus in a cell culture system. And this shows that that's not enough, mind you. You can have samples with a pretty low CT, and you can have symptoms for under that 7 to 8 days, but it tightly correlates with those particular values. And so you can see here as well that the probability overall of having a positive culture decreases quite a bit once you get above a certain cycle threshold, and likewise when your symptoms have been around for a certain amount of time, specifically under that 7 to 8 days. So the take-home points are, one, that culture is less sensitive overall than PCR at about 30%, and that makes sense. It also is a lot more labor intensive and requires specialized labs. But people may be less infectious when their symptoms are greater than 8 days, and the further they get from those 8 days, the less infectious they are. And likewise, when a CT value is greater than 24 on a respiratory sample, that also implies that you probably are less infectious. And again, the further away you get from that 24, the less infectious you become. And true enough, I guess removal of isolation based on RT-PCR results wouldn't have made a lot of sense, because we've seen people who are positive outside of 2 or 3 months. So this did get a lot of international attention and was published in Clinical Infectious Diseases, the Journal for Infectious Disease Society of America. It broke the top 20 at one point, and that was primarily the medical community as well as lay people. And what you can see here is that it's actually number 5. And why I like this particular slide is, one, it's Canadian content, but not just Canadian content, it's Manitoba content. It's not Toronto and not Montreal, it's not Vancouver, it's right here. And in addition, it's also the only microbiology paper on this list. So there's been some good attention. So the World Health Organization, the CDC, and the United Kingdom all use the data from this to produce and say when someone could be removed from isolation. But there were some bad features as well. So the lay public got a hold of it kind of during the summer and was saying that CT values that go greater than 25 may be false positive. And so that's not true at all. But it was interesting to see the interpretation and the departure from the intent of the research. And so I'll end with this, that overall, I mean, we've been working really hard together, I think, as a whole. And in particular, I'm very proud of the people at CADM Lab for all the work that they've been doing, in particular that virus section. And so with that, I had the questions from the self-assessment, which I would be happy to go over, but I will leave it to the question and answer session that's coming a little bit later.
So I want to move over to Yoav, and he's going to be talking about COVID-19 immunity and the vaccine and fact or wishful thinking. So over to you, Yoav.
Thank you. Can you allow me to share the screen?
Yes, you have a little green.
For the introduction, Richard, and I will try to talk a bit about COVID-19, the prospects, and the pipeline for vaccine. I would like to start by acknowledging that we're on Treaty 1 land and territory of the Cree, Oji-Cree, Anishinaabe, and Dene people and homeland of the Métis Nation. In terms of conflict of interest, I don't have any conflict of interest to disclose, and I have picked examples of vaccines, but I have by no means any preference to any of the vaccine formulations that are currently under study. I'll try to talk about the process towards vaccine licensing, what it takes to get a vaccine out, and how COVID vaccine is different compared to regular vaccine that we have for use for over the years, and what are the prospects and some of the caveats towards COVID vaccine. So a tremendous amount of work has been done in a very short period of time, from the first understanding of the emergence of this virus that you saw in Dr. Poliquin's talk, and understanding of the immune response to SARS-CoV. And it's a balance between the burden of virus that can cause severe disease with initiation of inflammatory response that leads to dysfunction, causing lung injury or organ dysfunction, coagulopathy, and that can be defined as the inadequate immune response. But then there is a good immune response, and what constitutes that immune response, what leads to maintenance of a low titer of virus, and results in a limited inflammatory response and ability to mount a good adaptive response that leads to recovery and then protection from a subsequent response. So we know some of the components, and we know that individuals that have comorbidities or advanced age are unable to mount a good immune response and suffer from severe disease. What are some of the correlates of severe disease? Is that older individuals with impairment of T cells and B cell function can have a blunted response to vaccination, and that those are the same individuals that we want to protect, because those carry the brunt of mortality and severe morbidity from COVID-19. Impaired B cell response leads to inability or less ability to mount a neutralizing antibody response, but also impaired T cell, we're not sure the role they play, but in other viruses, they are contributing to control of the disease severity, as we can see from influenza. So T cells do play a role, and they are more difficult to measure. In terms of the normal development of vaccine, this is a process that takes time. It takes an estimated 5 to 10 years that start with vaccine design, and then the prospective vaccines are tested in animal studies and then produced before they can enter into human studies that undergo through 3 phases. The first phase is an early phase that looks at small number of individuals to try to identify the dose that is safe to administer. The second phase continues to measure safety, but in a larger group of individuals, trying to measure some markers of response to the vaccine. And in the third phase, it's a much larger study that involves more participants, and the idea there is to try to identify, again, safety issues and to identify that the vaccine is effective in achieving the desired prevention. And after that, there's a process of submission of the information for licensure and then upscaling of the production. So those are some of the things that need to happen for a vaccine. What has happened in the industry of SARS-CoV vaccine? Obviously, you don't have the time frame of 5 to 10 years to come up with a vaccine, and therefore the timeline is truncated, and an estimated development pipeline of 6 to 12 months. And that means that some of the processes need to happen in parallel. So vaccine design and animal studies at the same time, and then production of the vaccine and phase 1. While phase 1 is started, phase 2 is already ongoing, and then phase 2 and phase 3 are overlapping with the attempt to shorten this time. So we've seen unprecedented investment in those vaccines, and this non-linear trial progression with compressed time scale allows to achieve near market development very soon, but it has some limitations because we are seeing only the short-term effects in terms of immunogenicity data and some of the safety data. In terms of the vaccine, there's incredible pipeline of vaccines within a short time period, and those are based on several platforms. One of them is the RNA, so using RNA within a lipid nanoparticle. That's like the Moderna vaccine that has been in the news. Then there are protein-based vaccines. And the other vaccine platforms are viral vectors that could be either a non-replicating vector or a replicating vector, as well as an inactivated virus. And here in this schematic circle, you can see that the products that are currently in development belong to all of those groups. Each one has advantages and disadvantages in terms of known platforms, safety, as well as in terms of the ability to induce antibody response, as well as T-cell response that I mentioned in my earlier slides. These are some of the leading candidates that are currently in phase 3. So we can see that the first two vaccines are based on different adenovirus models. So viral particles with COVID inserted into those. There's the Sinovac that is an inactivated vaccine that is currently in phase 3. Another adenovirus from Johnson & Johnson, and then the mRNA 1273, an mRNA-based vaccine from Moderna that is in phase 3. And then the other one from Pfizer that is also an mRNA-based vaccine. So if we looked at the numbers that are currently in all of the stages, there are over 140 compounds or vaccines that are being studied in the various stages, with one vaccine that is currently close to the phase where the manufacturers are anticipating within the next few weeks application for regulatory approval in the US. And this is compared to the target discovery and validation of 3 to 8 years on a traditional vaccine trajectory, as well as 2 to 10 years for phase 1, 2, and 3. So all of that has happened in 6 months. And the regulatory review as well is anticipated to be expedited.
Hi, Yoav. Just to let you know, there's less than 5 minutes.
Okay. The mRNA vaccine against SARS-CoV has been tested in phase 1, and this vaccine has been, at least in the phase 1, predominantly in Caucasian population, and that has been changed in the next phases, where they're looking at over 40% are Hispanic and Latin, and 20% are African American. So the idea there is to broaden the coverage of the vaccine to populations that represent the burden of illness. And the good news is this mRNA vaccine with the middle dose of 100 micrograms has been able to mount an antibody response that is detectable after the 2 doses. And more promising, and also illustrating the fact that the processes happen in parallel. This is a paper just published looking at the vaccine in macaque model, so in monkeys that received the vaccine and then had a challenge with COVID-19 virus. After 2 days, the virus is eliminated from respiratory tract. There is neutralizing antibody present in the bronchoalveolar secretion, and the animals survived. So this just illustrates the truncated time that animal studies are occurring in parallel with human studies. There are many issues related to dose and age considerations. So many phase 3 studies in the past have failed because of the dose was not the correct dose, and that the fact that immune function declines with age, and particularly in the case of COVID-19, we know that older adults suffer from the brunt of severe disease, and then ensuring that individuals enrolled in the studies that are of older age groups and comorbidities are represented in phase 3 studies. So while the studies are promising, at least in the short term, so far, safety seems to be reasonable. The idea, several things have happened with the studies that are encouraging. Many of the endpoints of the studies are shared, and there are documents from the WHO and from the FDA requiring sharing of some of the endpoints so we can compare the performance of those vaccines. We don't know yet how long the immunogenicity or the protection will last, and the studies need to be continued beyond the registration and approval of the vaccines, and ensure that there is a full representation of diverse ethnic backgrounds as well as age groups and comorbidities, as those are the people that are suffering for most of the consequences of COVID. The FDA has indicated that they will accept for review a median of 2-month follow-up after the vaccine for emergency use authorization. So that means that at least half of the study population should have 2 months of follow-up, because that is based on the 6 weeks where most of the adverse events will have occurred by. And the protective effect can be short-lived, but waning immunity can sometimes be detected in the second month of a vaccine trial. So that's the reason behind the requirement for 2 months, which takes us into November for the Pfizer vaccine that is currently the one that is closer or closest to completion, with the estimated 44,000 enrolled. The WHO is more conservative, requiring 3 months of follow-up for the COVID-19 vaccines for emergency use. The point I want to make here, those are emergency use authorization, and they mean that there needs to be ongoing assessment of the safety of the vaccines beyond that time period. That will allow for initial release of the vaccines, but requires additional follow-up to ensure that those are safe. And a successful vaccine needs to be defined, and the WHO defines it as a 50% reduction in disease. And the WHO has also proposed the Solidarity vaccine platform, and the advantage there is that you can test multiple vaccines at the same time without re-enrolling individuals. At least the control group can be shared by multiple vaccine trials. Just to put this in perspective, in comparison to a very effective vaccine that we have, the Shingrix shingle vaccine, that required a follow-up of 3.1 to 3.9 years. So beyond the time of emergency use authorization that we anticipate this fall, we will need to continue to monitor for the protection and the side effects associated with the vaccine. And with that, I think I've according to my time, I have a minute and a half that Richard tried to deprive me of, but I still have.
Thanks, Yoav, for coming in on time. I really appreciate that. Yes, there are lots of questions, and so that's essentially what I'd like to open up to now. So I'm going to go straight to our first question, and it came up under Jared's questions, but anyone can jump in. So the first question, some employers are wanting repeat tests showing that the client is negative for COVID-19. So what education should we be sending to employers?
Yeah, that's something that I think has come up a fair amount, specifically the use of testing for asymptomatic individuals. And so serial testing of asymptomatic individuals actually has ridiculously low sensitivity. And it's something we've been trying to impress upon them, saying that, I mean, yeah, that would be nice if we could truly exclude that this person doesn't have COVID, but I don't think we can do that with that particular test, right? The best way truly is waiting till they're symptomatic, or sometimes we can pick it up in an asymptomatic individual who's more accurately pre-symptomatic. So overall, what I say to businesses that doing serial testing of asymptomatic individuals is going to cost you a lot of money and has very low yield in protecting your workers, is what it comes down to. You can pursue that if you want, but I wouldn't do it. It's a poor use of resources for everybody involved.
Right. And as we heard from Paul's talk earlier on, that's something we really have to be thinking about. Okay. So just moving straight on, and this actually would probably be a question for more than just for Nick. It came up on Nick's questions. So if a vaccine doesn't pan out as expected, what would be the next best approach for dealing with this virus? And so that's kind of from the prediction side, but I mean, I think Yoav, you would also be able to add in there. So Nick?
Yeah, it is clearly it's a very hot topic at the moment of the possibility, can you get out of this by herd immunity? And at the end of the day, if the vaccines are ineffective, then that is our only exit, and that's our only way out of the situation. And so we're going to have to think of strategies around that, and we are thinking of strategies around that as very much a second kind of a kind of a last resort. But it is possible. Clearly, that will be easier were we to have better therapeutics. At the moment, we don't have much in the therapeutics box, unless that's my understanding. But certainly, there have been a number of modelling studies that we've been looking at to look at, to what extent, what proportion of the population does have to become infected in order for herd immunity to be kicking in and bringing the epidemic under control. And there's a lot of variability around that according to different circumstances. It is the only way that could happen without excessive kind of hospitalization, morbidity, mortality, is with some very intense control of infections in people, and probably people above 50, because everyone thinks that it's only people kind of in their 70s who are going to die from that. But no, it starts to go from low levels from kind of 50. It starts to accelerate. 60 plus really is the age groups that are most affected. But younger people do end up with severe infections, and if you get a lot of younger people infected, you'll get a lot of younger people in hospital, in our ICU, in hospitals for long times. It'll be a huge burden. So it's not an easy option.
I would like to weigh in, and in terms of the herd immunity, we've seen from places that have barely dealt with the burden of illness and ICU that despite having high numbers, still the immunity on community level is insufficient for herd immunity. So I think a vaccine would be really a key stage here. and hopefully a vaccine that decreases it by more than 50%. But we hope and can certainly hope. At the time being, in terms of other treatment modalities, we don't have those that can shorten significantly the time of stay in hospital. That also will alleviate some of the burden. But you'll hear Ryan Zerchansky talking about the prospects of clinical trials. At the moment, we don't have solutions. So it will be a combination, hopefully, of several modalities, but the vaccine has to play a significant role here.
Okay. Well, thanks. And Yoav, there's a bit of a technical, or a little bit more of a technical question on the vaccine, which you may know about. So do we have any idea how long the vaccine will give immunity? And like, would we have a yearly dosing, or would be there alternative dosing, or any science on that?
That's $1 million question. That the short answer, I have no answer, is, but the longer answer is from other SARS virus immune response. The immunity lasts for a month to short year or two. So from my understanding, what I can envision is a vaccine that needs to be re-administered at some interval. What that interval, what the optimal time is, I cannot tell you at the moment. And we don't have any experience with duration of protection from an mRNA vaccine. So that one is even more speculative at the moment.
Okay, all right. So I'm looking back at, and I see Brent and Paul are still around on the call. This question came up for the first panel, and it says the risk of transmission is 8 to 10 days. And so is that from the onset of symptoms or from the predicted date of infection? So maybe Paul or Brent, there we go.
Yeah, Brent's here, and I think, I mean, a lot of this came from Jared and colleagues' work on this. And so for the typical patient, we look at 10 days after the onset of symptoms. We require that person to be afebrile with improving symptoms, not necessarily asymptomatic, but that's largely based on the work that Jared and colleagues did.
I suppose the only other thing to add is that there's some thought that they're infectious for 24 to 48 hours before onset.
Okay. There's a question for Jared about serology, which you had kind of touched on. So in terms of that serology testing, just to know if I had it, would it be legitimate in the context of investigating, say, a long-term sequelae with some of those fatigue symptoms that people are talking about, things like that?
So that's one of the things I think we're going to learn as we go forward. We talk about this multi-inflammatory syndrome in children. We're now starting to see some cases that might show that it can impact adults. And then in terms of, you're saying like a longer term, other post-infectious related symptoms that might be found in adults too. I mean, we're probably going to see that to some degree, is what it comes down to. And you'll see that with any number of different infections. It's not exclusive to this. And in particular, I think you might see a little bit more only because this is the first time a population is being exposed to this virus. So there'll be a very strong immune response, most likely. Is there a role for serology in that setting? I don't know what that would change. And so that's me as a clinician saying that if someone came to me and said, I have these symptoms, particularly fatigue, I have sore joints, etc. I don't know that I'd pursue that. I think I would pursue a lot of alternative diagnoses before I would go down the road of a post-infectious COVID sort of phenomenon.
Yeah, and I think that's going to be something that as frontline clinicians, we're going to have to grapple with going forward for sure. Okay, there's a good question here for Nick. I don't know if you can answer it from some of the data that you know. So how many COVID-19 asymptomatic carriers do we have in our population, and that have remained asymptomatic or maybe have caused infection to others since March? I don't know if you were able to track that sort of data. That's pretty tricky data to tease out.
Yes, it is. It is tricky, Rita, because it's a good question. Because there are many studies which have looked at whether people were asymptomatic at the time of testing, and as Jared pointed out, I think that people are capable of transmitting the infection before they're symptomatic. So the latent period is actually shorter than the incubation period. But there are certainly a relatively high proportion of the population that remain that are asymptomatic all the way through, or toward, as far as we're aware. Asymptomatic might be that's as far as the person is concerned. Certainly some studies have identified people who are who declare themselves as asymptomatic, yet there are sort of radiological signs. But to all intents and purposes, we're running our models on the basis of in the order of 30% of people are asymptomatic.
Wow, that's fairly high, yeah.
Although interestingly, there is, to what extent are they involved in the transmission, and which is another issue. Not that they are incapable of producing virus in aerosols and so on when they speak and talk and so on, but they're not coughing and sneezing, and so they're not actually producing large amounts of droplets wherever they go. So maybe their contribution to transmission is less than those who are actually symptomatic.
Yeah. So obviously lots more science to do to try and tease that all out. Okay, so I know we are over by a minute. However, I would like to give Yoav the final word, because this is actually quite a good question here, a technical question. So do participants overlap with phase 1, 2, and 3, or is it a completely new group of participants in each phase?
It is a different group in each phase, but the follow-up on the earlier phases continues to look at the antibody responses and when do they wane. And the distribution has been completely fixed, at least in the Pfizer and the Moderna studies, based on criticism or on request from FDA to shift away from predominantly Caucasian to represent other ethnicities in the US at least, and elsewhere as well. So we learned different things from each of the phases, and the key here would be the continued evaluation beyond the time that the pharmaceutical companies submit that for registration and licensing, because as I mentioned, this will be only an emergency use approval, and we hope that the vaccines are safe and successful, but we need to keep monitoring for the appearance of the rare side effects over time.
Right, especially if we're going to administer well over 1 billion, 1 in a million side effects are going to be completely valid.
Right, and the studies, if you want to look at the silver lining here, the Pfizer study is 44,000 people enrolled in a couple of months. It's an incredible achievement, and the Moderna study enrolled 29,500 by Friday. So really an unprecedented, no vaccine has ever enrolled that many individuals in such a short time. So and the pipeline is rich with multiple other candidates. So I hope that we will have something to help Nick model how it protects.
Excellent. Well, I really appreciate all the speakers that have put their time into these excellent talks. And thank you for your participation. and hope that you will continue on for the rest of the day. We're going to take a 15, well, it's actually now less than a 15 minute. It'll be a 11-minute bathroom break for everyone. We will start again at 10:15 sharp, and we're going to start with Ronan Seagrave, and he'll be talking about incident command. So we're going to shift a little bit more here. So all those that had joined a little bit late, you have to go onto Slido, and you have to go to Bug 2020, and so it's slido.com, and we have definitely got good participation. And then all those that are on there already, I remind you, please go into the polls for each of those speakers and go through that portion so that you can actually just give feedback to each speaker. So once again, thanks to all the speakers. Well, welcome back, everybody. Hopefully you managed to stretch a little bit. At least when we're Zooming, you can be doing this on your phone and walking around. But I would like to thank everyone for participating here today. We're going to move straight on. We've got another 3 speakers coming up. We're going to be switching gears a little bit. And so I'll move straight on to our first speaker. So Ronan Seagrave, he's here he works at Shared Health, but he is the Chief Operating Officer for Health Sciences Center here in Winnipeg. So he's back office guy, but he's keeping things running. And so he's going to talk about actually staying on track and this incident command at the time of healthcare crisis. Over to you, Ronan.
Thank you very much indeed, Richard, and good morning, everybody. And it's a pleasure to be with you all today. I'm going to talk about our experience, and really, I think the experience of not just hospitals in Manitoba, but hospitals in Canada, indeed across the world, of incident command, and particularly in the context of responding to the COVID-19 pandemic. And one phrase that I always had to mind at the start of the pandemic is a quote from Charles Darwin, the originator of the theory of evolution. It's not the strongest of the species that survives, but rather that which is most adaptable to change. And as we all know, the COVID-19 pandemic has placed enormous demands, both in terms of our health system, society, our economy, and indeed ourselves as individuals in relation to adapting to very, very significant change. I'm not going to dwell too long on this. This is not related to Manitoba. This is a very generic kind of global slide that describes the various phases of a pandemic. You know, what happens before a pandemic, i.e. you know it's coming, during the pandemic, and then after the pandemic. And our experience here and in HSC in Manitoba, we've gone through all of the phases in relation to monitoring the health environment in terms of, back in sort of January, February, monitoring for COVID-19 cases, a lot of preparatory work in responding to the pandemic then arising, and extensive efforts to minimize the impact and the spread of outbreaks, ensuring a coordinated government response, minimizing obviously pandemic and compressing transmission in cases in terms of impact and spread, managing COVID-19 cases, which hospitals across Canada, including HSC, are continuing to do as of today, managing excess deaths. That's not been mercifully and thankfully a challenge for Manitoba, but you will all be familiar with the images from Italy, northern Italy and New York in relation to, unfortunately, the challenges they had in that first wave during the spring. Upholding our vital infrastructure in terms of our critical assets to manage the pandemic. And then after the pandemic, you know, the requirement to restore vital services, and potentially in some jurisdictions, potential inquiry in terms of sort of lessons learned and preparations for any future pandemic. In relation to sort of healthcare and my business and running a hospital, this is again a very generic slide. It looks at kind of like a health footprint of a pandemic, and I've put 2022 is perhaps the best estimate as anyone can tell, including experts, as to how long the COVID-19 pandemic may last, and a similar timeline to the Spanish flu pandemic of the last century. And you'll see on the slide that a pandemic involves subsequent successive waves of both transmission of the virus and other impacts. And in this first wave that we had in the spring, clearly responding to the immediate threat in relation to patient mortality and morbidity, and an enormous amount of change in that orange box that I'll talk through in more detail, standing up screening and testing in hospitals and acute care facilities, looking at our bed map to ensure that we had capacity for COVID-19 patients, looking at equipment such as ventilators, that we had sufficient numbers to deal with any additional patients, PPE, personal protective equipment, looking at staffing in relation to additional capacity, a real switch to virtual care that I will talk about, the increasing need to have what I call increased visual bed management, hospitals understanding and having tools to understand which patients are in which bed in every minute of every day, preparing for future outbreaks and waves. And clearly, as we're in now and going into respiratory season and a second wave. But the other impacts of a pandemic on a healthcare system are really significant. We know that COVID-19 patients can have quite long lengths of stay. We know there have been impacts which we're working through in relation to postponement of elective surgery and diagnostic procedures. We know as well that there can be significant impacts, unfortunately, in relation to mental health from things like lockdowns or restrictions having impact. And then also something we did note where emergency department activity decreased during the first wave of the pandemic, but then subsequently increased quite rapidly. And the bottom line is really important. The objective is obviously to keep patients, staff, and safe, but also from my perspective, the COVID-19 pandemic is also an opportunity to transform and develop more resilient healthcare, which I will also talk about in a little bit. So today I'm going to talk about what happened in Manitoba in early spring in relation to a decision at a system level to trigger a provincial incident command structure, and then an incident command structure in hospitals such as Health Sciences Centre, which started in the end of February and in Health Sciences Centre remains in place today. And why did we do those things? We knew we needed very agile and rapid decision making and excellence in execution based on guidance from provincial experts such as Dr. Brent Rusin. So from a hospital such as Health Sciences Centre, it required absolutely fundamental changes in relation to many of our core operations, such as rolling out virtual care clinic visits. So instead of patients coming into the hospital, switching those visits safely to phone and increasingly video technology such as Zoom, imposing sort of a lockdown on the hospital in terms of really rapid reduction in terms of the numbers of entries and exits, so to enable the implementation of screening for people who may have been exposed or at risk to COVID-19. I'm going to talk about the need for having absolutely the right governance in place and the team in place that you need to make very rapid decisions, and ensuring alignment of those decisions with provincial leadership and direction. And perhaps it'll give you a little insight on what I call what it was like to be at the eye of the storm, and in terms of making these very, very rapid changes, how it's benefiting us now in a second wave of COVID-19, and how I actually really believe that many of these changes are going to endure much longer after the pandemic, and perhaps a new resilient reality in healthcare. When we talk about incident command, you have to have guiding principles. What are you trying to achieve by setting this up? Number one, you want to keep patients and staff safe in a public health crisis, which COVID-19 is, and the biggest since Spanish flu. That we can continue to discharge the hospital mandate, that we keep our core functions as effectively as possible, running and providing care for patients who are ill for other reasons other than COVID-19. For COVID-19 patients, of course, providing the best compassionate care that we can, notwithstanding the limitations we currently have as a planet in relation to therapeutic treatments, and also playing our part in terms of the wider provincial response as a good corporate citizen. We're all Manitobans, we're all Canadians. No matter where we work and what we do, we have a role to play in terms of that collective response. So what is incident command? It provides a focused, structured management structure set up on a temporary basis in response to an unforeseen major incident or event, and in this case, the COVID-19 pandemic. It's temporary. It provides a temporary enhancement to existing internal management structures to enable, as I say, very rapid day-to-day planning and implementation of changes in responses to the COVID-19 pandemic. So the only issues that Incident Command is dealing with relate to COVID-19. Other management issues go through the normal management structures and processes. It does require our management staff to take on additional temporary roles in addition to the regular roles. And in terms of how often it meets, certainly in the first and now second wave, generally one call, 8 a.m. usually in the morning, 7 days a week. It's a bit hard to see, but this is the incident command structure at HSC. There's me on top as the incident commander. This is a very, very typical model. It's not exclusive to HSC that you will see in many hospitals all across the world. And you note there's very specific roles there in terms of medical officer, deputy incident commanders. And I'm going to talk about some of these specific functions such as operations, planning, and logistics just now. So incident command must have a very, very clear chain of command with the incident commander at the apex as the person ultimately making the decisions. And some of the key functions include planning. And by this, I mean very, very rapid planning of operational changes required. So we get direction provincially that we need to make changes in relation to PPE. We need to plan those changes very, very rapidly. And some of the things that we needed to plan very rapidly with things like screening, in terms of front door entry screening, testing in relation to testing of patients or staff at a hospital, changes to our bed map, PPE framework in relation to PPE required for patients who are either COVID suspect or positive, switching to virtual care, looking at staffing requirements. And then your operations table and your operations chief is making the very rapid, again, implementation of all the required changes. Once planning is done, it's worked very rapidly. Operations is there, executing those changes, and I mean really, really quickly, in some cases within a day or two. And then supporting both of those tables is logistics. So if we're making changes to a bed map, we need to ensure that we have the right equipment, the space is prepared for patients, liaison with digital in terms of digital and ICT requirements, and obviously a major role for communications, ensuring site-wide or system-wide communications on planned and operational change. What were the challenges? There were many.
5 minutes.
Very long hours, 7 days a week, risk of burnout, so we tried to address that by rotating staff. Our data systems were, not surprisingly, not configured to immediate COVID-19 requirements, so we got some consultancy support to make that alignment with the kind of information that we now needed on a very daily basis, such as staff absences due to COVID-19. And we were required to respond to often multiple policy and process changes determined provincially. So it really was all hands on deck. This slide really just summarizes some of the things that we were doing in the first wave and now second wave, standing up screening, testing, creating extra capacity through a bed map, expanding digital channels operationally such as Zoom and Teams, switching to virtual care, the analytics piece in terms of having information on COVID impacts around patients and staffing, unfortunately restrictions on visitors, equipment, the PPE framework, ensuring compliance with social distancing, looking at the financial impact of COVID-19, remote working. So a heck of a lot of work done very, very quickly. In terms of, I think, what all this means going forward, I call it the new resilient reality. And COVID-19 will mean, obviously, changes in relation to new care models. We are now delivering regular care within restrictions and different ways to comply with things like social distancing and PPE. We're managing care backlogs, such as the surgery backlog, and managing that successfully. And we're again continuously planning for improving our effectiveness for any future waves, including the situation we're in now. A huge switch to digital delivery in terms of new virtual care models and our workflows. Having a more agile workforce in relation to supporting our magnificent frontline workers, adapting to new ways of working and how we utilize our workforce. And clearly the financial position in terms of recovery and monitoring the financial impacts of COVID-19. My final words, and a thank you from me to everybody, not just in my hospital, who was and is supporting Incident Command, but also all the folk who are doing that in all hospitals and health systems in Manitoba, across Canada, and throughout the world. And I'm going to finish with a couple of my favorite sayings. One is management guru, some of you may be familiar with, called Peter Drucker. He says, management is doing things right, leadership is doing the right things. And that's exactly what we were trying to do in Incident Command. And then finally, a quote from John F. Kennedy, and I'm putting this in the context of how we may exit the COVID-19 pandemic with work on vaccines and other things. And I'm always reminded by his speech in relation to going to the moon and sending men to the moon and returning to Earth safely, which we did, not just in 1969, but several times. And as Kennedy said, we did those things not because they were easy, because they're hard, but also because goals like that help organize and measure the best of our energies and skills. And that is exactly the case in relation to Incident Command. It's exactly the case in relation to the tremendous work happening across the world in relation to vaccines and therapeutics. And that's why I'm a real optimist on a vaccine. In my view, if we successfully sent people to the moon and returned them to Earth safely, human ingenuity can definitely develop a vaccine here rapidly, and indeed better therapeutics. Again, a sincere thank you for joining me today. I wish you a very successful rest of Bug Day. Thank you, Richard.
Thanks, Ronan. And I see there's already questions for you, so that's great. Okay, so I'm going to move straight on. So our next speaker, no stranger to a lot of people, Dr. Ryan Zachansky. He is an associate professor. He's a hematologist. He's a critical care physician. He's a phenomenal researcher, and has been very involved with research on COVID-19, mostly on the clinical trials here in Manitoba. And he leads several international clinical trials that are evaluating potential therapies within COVID-19 and within sepsis. And so I think this is really pertinent, because that's obviously going to link closely to how things roll out in hospital. And so Ryan, without further ado, over to you. You got to turn you on mute. There we go.
All right, thank you very much for the introduction. Sorry for the technical delay here. I'm going to talk about therapies in COVID-19. These are disclosures related to grants studying mostly anticoagulation in COVID-19. I'm going to talk about Manitoba's clinical trial response in the face of a condition with not a lot of known treatments, provide an update of where we stand with regard to therapeutics, and highlight some of the roles Manitoba is playing locally and internationally. And so if one considers COVID therapeutics, we could talk about the virus and preventing it from binding, fusing, replicating in the host, or we could talk about the host response to the virus, which is really centered largely around coagulation and inflammation at the moment, and the immune response. And earlier on in the viral infection, it's more appealing to maybe think about things that will prevent the virus from attaching and replicating. And then later on, when people are really sick, therapies around that may influence host inflammatory response to an infection may be more appropriate. So just sort of conceptualizing the whole spectrum of therapies with regard to the spectrum of illness. Most people are mild and require different therapies than some people who are really sick and may require other targeted therapies. And so keeping this in mind, we developed locally a framework, as there was a framework to look after the health system. As you just heard, we had a framework to understand knowledge generation in an infection where no specific therapies existed. And so we looked at the spectrum of disease and looked at areas where we could prevent virus exposure, prevent infection with virus exposure, or maybe give some preemptive therapy for people who were exposed without proper PPE. But if you got into hospital, we launched a suite of trials with regard to people on the ward and a suite of trials with regard to those in the ICU. And REMAP actually is a suite of trials in its own right. Our strategy locally was to embed trials into clinical care. If you don't know what works, you're never going to find out unless you have an organized way to collect data and feedback that data to the world or to the system, so you can understand how a certain therapy or intervention worked, and then should you apply it to others or abandon it. We also prioritized international trials, or really large trials that are collaborative, because if it was like a local trial, despite our best intentions, if we just had a therapy or a trial that we wanted to do locally, our wave could come and go, and the first wave was really small. We wouldn't have been able to do anything. And likewise in Canada, waves come and go, and around the world. And so we wanted to be able to finish a trial strongly and start it strongly and finish a trial strongly. And then the idea was we're going to study something just until we knew it worked, and if it did, adopt it, and then that would become our new standard of care for something to be compared to. And if it didn't work, then abandon it. And the concept was really like a learning health system. And so we had there's lots of different drugs here that people are interested in with regard to COVID. I'm going to talk about most of these in turn as an update now about what works, what doesn't, and where are we going. Okay, so hydroxychloroquine. This was our sort of first really interesting potential agent. There was some in vitro, that means laboratory data, that it could reduce viral replication. It was really inexpensive, widely available. And we wanted to see if we could flatten the curve by participating in a trial, bringing one to Canada very, very quickly, for which we could reduce the severity of symptoms in people with new infections or prevent transmission to household contacts. We also want to see if we can protect healthcare workers with hydroxychloroquine. And so these are our questions, exactly. And so we brought a trial from the United States to Canada, led the Canadian arm of a double-blind placebo controlled trial, randomized controlled trial, that's RCT, where we compared hydroxychloroquine to placebo for 5 days. And we were doing really well. And we started a trial within just a week of finalizing the protocol and submitting it to Health Canada. Patients could log on to a website and randomize themselves in a sense by learning about the trial, seeing if they're eligible and consenting. And it was a phenomenal success in the sense that we were the first ones to start an interventional trial in Canada, first to finish. And we're in a drug where we thought we had a lot of hope. We published in a very high impact journal, the whole team that there was no difference. There was no difference in rates of new infection, hospitalization, and no safety issues. The trial came up against immense challenges because people, thought this could work. Their emotions really played in. And there was a mix of politics in here as well. And so there was a lot of feelings, and it's easy to poke maybe attention to a world leader south of us, but we did the same thing locally. We had emergency physicians and healthcare workers taking the drug on a feeling, on a hope, and it really didn't work out in our favor. And so where did hydroxychloroquine end up? Well, we had several outpatient trials. One of ours is there, in fact, 2 of them there. It didn't prevent transmission, didn't protect healthcare workers. It's subsequently been abandoned. In the inpatient setting, it also didn't work to reduce mortality, length of stay. It just didn't work. And there was the signals of harm in some populations as well, but it wasn't overwhelming harm. Then the Calitra was studied quickly. This was an antiviral that was developed in the early HIV days. And we thought this could work. Some people locally adopted it as what they would do and how they would treat their patients. And these are infectious disease doctors without any data in COVID. And subsequent data was published where it didn't work. It didn't reduce mortality. It didn't do anything. And so it was abandoned after large trials were published. Remdesivir is a drug that was developed for Ebola. It didn't work well in Ebola. People thought, well, they could repurpose it for COVID. Repurposing drugs early in the phase of a pandemic makes a lot of sense. But again, there was a feeling that this could work. A trial from the United States was published, pre-published early with a message that this drug, remdesivir, an antiviral medication, can reduce the time to symptoms. And it did reduce the time to symptoms in patients on oxygen, but it didn't really do much in people that were really sick. So earlier in the course, it seemed to reduce time to symptoms and hospital length of stay. But there was a huge trial that was just published about a week ago on in the preprint servers and widely distributed all the data. 5,000 patients with remdesivir, no difference in mortality. There wasn't any suggestion that it reduced people from getting intubated or would change their hospital stay even. It was collected a bit differently. And so we're not sure where this fits in at all. If it works at all, it's really, really minor. Maybe there's a 1.5% difference in mortality, maybe, but we can't exclude a little bit of harm even. Like we just don't know in people that aren't very sick. But in people who are more sick, it seems to do harm. And so we've stopped randomizing people or stopped trialing in people who are very sick on a ventilator. And we still have the trials open for people on oxygen to try to understand if there's any effect of this drug at all. But it's not standard of care, despite whatever the United States has done. The rest of the world has not adopted this. Corticosteroids, though, is a success story. And so in 7 trials now, there's a consistent results that steroids seems to work. And again, where remdesivir may work, may not, in viral illnesses early because it's an antiviral, corticosteroids affect the immune response and it may have a benefit more later. And that's what we saw. In people who are really sick, there was like a 12% reduction in absolute mortality. So, from really high in 30s to 40s to like 10% lower than that, or so, actually 12% in critical care. But in people on oxygen, it seemed to benefit. But if you weren't sick, you weren't on oxygen, it didn't have a benefit. And in fact, there may have been harm associated with giving steroids in people where oxygen wasn't required. And so there's a very consistent result. It seems to improve survival in people on oxygen or sicker. And many formulations exist, and there's now, this is the standard of care for people on oxygen. There seems to be thrombosis seems to be a prominent feature. There's clots in COVID-19, and inflammation is tied with clots, and clots is tied with inflammation. And so Manitoba is actually leading a study around the world in like over 12 countries now of studying therapeutic anticoagulation to reduce mortality, thrombosis, and inflammation in people with COVID-19. So it's Manitoba developed, led around the world.
3 minutes. 3 minutes.
Yeah. We're studying also convalescent plasma, and Manitoba's taking a leadership role in this. So plasma might confer passive immunity. We're not sure if this works, and trials are ongoing. There's another drug called interferon that modulates the immune system that we have been studied. It seems to worsen survival or have more mortality. And so that has largely been abandoned. But there is a trial in the States still ongoing. And then you might hear about other things like tocilizumab, which is an immune modulator, had disappointing results in phase 3 trials, seemed to reduce hospital length of stay, but not mortality. Azithromycin doesn't work. There's no evidence for zinc, and there's no evidence for any other drugs. You'll hear more about monoclonal antibody cocktails that President Trump took when he had COVID. And again, we're not sure if this works at all. It's being trialed right now. It seems to reduce viral infections in monkeys and hamsters. And there's an exciting investor announcement, but we just don't know how it works. And human trials are underway. And regardless of what you hear, testimonials are not a replacement for responsible science in clinical trials. One of the antibody cocktail trials was already stopped for safety concerns, but that's okay because they have to take their time and figure out what the concern was. And so in summary, steroids is the go-to drug that is standard of care now for people on oxygen or sicker. Remdesivir is a role that's totally uncertain and will continue clinical trials in moderately ill patients, but we're just not sure if this has a role at all. All other trials are ongoing. And the quickest way to find answers here is to enroll patients in clinical trials as part of care and as part of a learning health system where the results get incorporated into care. If all our patients in Manitoba and Canada and around the world were already part of a clinical trial, we'd have all these answers for the questions still outstanding. The testimonials are not the replacement. Enrolling these people into trials, investing them is what we can do to get an answer as quickly as possible for the world. Again, these are the trials we have going on in Winnipeg. And this is the trial team. Some of them, there's many actually missing, who are actioning all these trials at St. Boniface Hospital, Health Sciences Center, and the Grace General Hospital. So thank you very much for listening and for the opportunity to talk to you about state-of-the-art therapeutics in COVID-19.
Thanks, Ryan. Please stick around for sure. There's going to be lots of questions for you. Okay, so moving right along, I want to welcome Craig Dirksen. He's our resident engineer here at Shared Health, and he's the Divisional Director of Facility Management for Shared Health, and he's leading maintenance, engineering, the energy, the security, and housekeeping services. So another really, really important kind of back office guy, and keeps the whole system running. So he's going to talk about protective environments in the healthcare setting. Okay, Craig, over to you.
All right. Thank you, Richard. Well, I'm thankful that Dr. Emble gave me an animated title for this session to help keep you engaged during the next 3 hours as I talk about protecting people from aerosols, airborne transmission, as there's a huge amount of material to cover. We'll start the 3 hours talking about fomite, droplet, and aerosol content. Am I not on for 3 hours? Oh, I've only got 15 minutes, right?
Yeah.
Oh, 15 minutes. Okay, well, we're going to have to move it along then. And I'm going to touch on a number of areas, and including droplets, droplet nuclei, how airborne environments are protected. We'll talk about the equations and modeling that's going on. But here, let me start off with a couple of visuals. It's the Swiss, not the Swedes, who have actually got things figured out. There's two versions of the Swiss model here. It's actually a Swiss cheese model, and I think the Bug Day 2020 has every one of these topics covered. But regardless of the model, it's key to understand that while each layer of the Swiss cheese model has holes or gaps, together we can effectively and safely manage all transmission modes. So we have fomite, droplet, and aerosols as our three possible transmission routes that we constantly consider, and I've been asked to talk about the airborne element. So what's the challenge and what's our approach with this? Well, see, this is the problem. As you can see on the screen, we have people who are talking, who are coughing, who are sneezing. These people may have influenza A, measles, chickenpox, or as we're talking about today so much, SARS-CoV-2 virus. They may even have the tuberculosis bacterium. And it comes out as both droplets and aerosols. And droplets are usually something that's in the 20 microns to 100 micron size. But as the expelled aerosols, they get down to about 1 micron in size, some of them up to 10 microns. Now for size relevance, one speck of drywall dust is about 3 microns. Now within these particles are the viruses. In the SARS-CoV virus ranges from 0.06 to about 0.18 microns, very, very small. But the viruses and bacterium are all expelled, attached to fluids, mucus, water, and hence we have larger particles of aerosol as well as droplet. But then something unique happens, and it's actually unfortunately unique because with both droplets and aerosols, as they expel, they immediately get smaller. They drop in size from 2 to 3 times their normal diameter within a half a second after they leave the body. See, they desiccate and dry in the air. So what does that mean for us? Well, when a particle doesn't have as much surface area or mass, they become buoyant and they can take much longer to fall, and they get caught up into the air streams, and they get caught as people move in and out and around these people. With less moisture, these particles, according to the Stokes law, they can travel 20 times longer than a wet droplet. Well, wait, we've been worried about droplets within a 2-meter zone. But now remember, we have potentially, and I do want to emphasize potentially, viable viral aerosols moving through our airstreams. I touched on the word droplet nuclei just earlier. Humidity has been proven to be a big factor in airborne movement and in the human body's acceptance of airborne viruses. Given our dry winters that we have in Manitoba and in our northern region, and the correspondingly low indoor humidity levels, now more than ever, we need to look to keep our humidity levels up between 40 and 60%. Now in Manitoba, in a dead cold January winter, striving for 30% internal humidity will be a challenge, but everything helps. There's plenty of work going on looking at various laws and applying those laws and trying to determine what is the model that determines what we have for aerosols and infectious aerosols. But so far, I've just talked about the normal conditions of speaking, coughing, and sneezing. But in particular, we're concerned about situations where we're knowingly generating aerosols. We call them AGMPs, aerosol generating medical procedures. So while we have a defined list of AGMPs, which include dental procedures, aerosol generating dental procedures, those, we know those and we can manage those. And we're going to focus on how do we create a protective environment when these AGMPs occur. Now we need to quickly look at a hierarchy of control. This principle needs to be understood clearly. There are 4 and sometimes 5 levels of control that are most familiar to us. The term that's become so common language amongst everybody now is PPE. But as you look at that triangle, you realize PPE is at the bottom, the least effective. So when we consider how can we eliminate and control the effects of aerosolized viral particles, the best control is elimination or substitution. But unless we can defer our care, we can't eliminate. So then we get to the engineering controls, the adjusting the workplace, as that slide says. And we'll talk about that in a minute. Moving down the scale, we have administrative controls. That includes limiting people in the space where an AGMP is performed, putting signage, communicating the hazard. And the final control is PPE. Not to say that these are not effective, but they are single defense mechanisms. But coupled together, the hazard controls become highly effective. Going back to that Swiss model, it's the layers that count. So protective environments are those which will both move and remove the particles from the air, viral, bacterial particles from the air. And coupled together with administrative controls and signage, and then PPE, these controllers are highly effective. So let's look at engineering control, the protective air movement. Commonly in our hospital settings, we know these as airborne infectious isolation rooms, or AIIs. So what we call an airborne infectious isolation room, we usually see the new installations, as the image on the top shows, where we have an anteroom included. But when we retrofit existing spaces, often we don't have that luxury of the space and we don't have the anteroom. These rooms purposely exhaust more air than that which is provided into the space. And that negative airflow into the room is done so that we move air away from the public spaces where people are not protected by PPE. You can see the arrows pointing inward on those images. We ideally place the exhaust grill near the patient's head so that as they're expelling particles, they are captured quickly. Remember, we want to rely on engineering controls first and above those PPE and administrative controls. We want to make sure that the holes on our Swiss cheese don't line up. So how do you know that these systems work? Firstly, a properly built sealed room, which is commissioned, will ensure the proper airflow. But that's not enough. Secondly, we need ongoing monitoring and thirdly, ongoing calibration and maintenance. We could just set the air volumes and say we're good and trust that it's good. We can hang tissue paper at the door to ensure that the airflow is drawing into the space. But we're really not able to measure airflow that well. So instead, we measure air pressure. Now, let me say this very clearly and carefully. The key is it's the airflow that is protecting the people, drawing air into the space. We use pressure measured either in pascals or inches of water column, but it's really the airflow that we're desiring to have, that we need to ensure that we have safety in place. We look at pressures in the range of 5 pascals, maybe 7.5 pascals. Some try for 15 pascals of pressure. But remember, these are a marker that we have effective airflow. But routine and regular inspection of the airflow control system, calibration, controls, looking at the door seals, confirmation of the air volumes are critical. So what is it that we're trying to do? Well, we're trying to contain airflow within the room. Where we have concern that we have aerosols containing viral or bacterial particles. So now these next two videos from a world-leading Canadian engineering firm, RWDI, from Guelph, Ontario, helps you understand how easily aerosols move with people, and also gives you an indication of why an anteroom is so critical. The first video shows two sides of the door, the particles moving and mixing. We have the red side and the blue side, and as those particles mix together, we see the new colors. And you see how much is entrained from one person to another. The second video here shows an overhead view as the door opens inward, and as the person begins to exit, we see on the left an actual smoke model. On the right, we see a computer-generated model using computational flow dynamics. Pretty accurately reflects what is going on. So when we say that people are performing an AGMP, you need to work in that airborne infectious isolation room. You need to keep the doors closed. You need to minimize the in and out of the room. I think those videos drive that home. But those rooms aren't always available. What about AGMPs in our resuscitation room? When we have to bag a cardiac patient in an open dialysis unit or a regular patient room? What about intubations in our ORs? For rooms where we can have accidental or unplanned AGMPs, we need to decide how ahead of time what we're going to do. What I have up here is the Center for Disease Control table that shows what is the air clearance time for a room, depending on the air changes per hour. Now, I know everybody wants to use the shorter time, the 99% column, but I know that from the people who've done these calculations, these are based on theoretical models where complete mixing of the air occurs and exhaust systems are drawing contaminants from everywhere in the room, which doesn't happen. So I always push that we use the 99.9%. What you need to do is to work with your facility management people to understand in our dialysis unit, in all of these areas, what is our airflow. Most people think that if I've got more air is better. And all of a sudden we get this massive air moving and things begin to feel so much better in my space. There is a point where we can have too much airflow, too much air pressure, like a hurricane coming through. We can get so much turbulence, we don't get proper directional airflow. And without that proper directional airflow, we're going to actually cause problems with the air. We also have locations where we're likely to have aerosol generating procedures, but we don't have an AII room, such as resus bays in our emergency departments. I'm going to move along in this one really quickly, but what we've had to do in the interim in a number of locations across Winnipeg and across Manitoba is, because we can't construct solid walls in these spaces, we've used heavy plastic curtains to cordon off the space, and we've installed, as the picture on the right-hand side shows, a HEPA air scrubber that actually wipes the air within that room to give a lower clearance time and to make our staff safer. Operating theaters is another area where here in Manitoba, we have kind of gone and been the Canadian rebels. We have turned our air pressures in our operating rooms in a number of locations into negative, so that when we're doing procedures in rooms where we may be releasing viral particles, we're bringing that, we're keeping that air within. And it's a balance between that and surgical site infections. We've been running negative ORs at Health Sciences Center in 2 locations for tuberculosis for over 7 years with no reported challenges. So I have a couple of capstone comments that I don't have time to go deep into. Wherever you have potential for a known or a continuous aerosol generating medical procedure, you want to be achieving 12 air changes per hour up to 20. You want to exhaust that air ideally, but that's not always possible. Know your air changes. I had in the previous slide there the calculation showing you how to calculate that air change per hour. Very simple. And as a last resort, you can look at HEPA air filters. as scrubbers. Don't have time to talk about it, but we could also talk about, well, how much is a viral load in the air is going to be contaminated. I want to close off by saying it's a partnership, working together with the clinical teams, infection prevention, control, and facility management, your engineering group. Together, we can be the wind beneath the wings that will lift us up to solve problems and conquer COVID-19. Thank you very much.
Thanks, Greg. Excellent. I like the choice of music there. All right. So, I see we've got actually lots of questions, so that'll be good. Nice interactive discussion. If any of the other speakers have comments to a question, please jump in. And for those that are online, just a reminder, go to slido.com. I know pretty much everyone is actually on, so that's really good. And then remember to rate the questions up or down with a thumbs up or thumbs down so that we get the most pertinent questions. So first question, and this goes back to Ronan. So how possible would it be to also create a COVID center location? So basically a place for patients and staff specifically dealing with COVID-related issues until that vaccine. I mean, I know we've got COVID ward, but maybe something a little bit bigger than this. Ronan? Oh, he's not there. Okay. Craig, any idea? Or Ryan?
Well, I know we have here at Health Sciences Center, we've certainly created COVID positive areas, red areas. We have also been looking at clinical support spaces. You know, as we go for the long term here, very solid question, because we want to isolate those patients, those people coming in both as an outpatient for a clinic visit as well as diagnostic testing, so that we can manage our personal protective equipment and manage the people around them. So, you know, whether these be standalone clinics could be the argument that we keep them away from the rest of the people at the hospital, in the hospital setting, and have standalone, or that we have it almost as a front door service. So keeping that isolation, I think, is key. Lots of planning, lots of that needs to be looked at that. I think very good question for us to look at as a health system.
Yeah, there's always new ideas that come up, but yeah, obviously we need to be thinking carefully. We can't just rush into things, as Ryan has noted in his talk. So over to Ryan quickly. So is there a process by which the rural hospitals are supposed to be enrolling our COVID positive inpatients into trials? Because sometimes there's that stuff happens here in the city or in HSC, but not necessarily rurally.
Yeah, no, that's a great question. We've done all we can to get the trials going at 3 hospitals, the major hospitals within the WRHA and Shared Health, with very little resources. The government of Manitoba has helped us get these going. I think it's really important that we've developed systems of care and you know, pandemic plans, including zones and areas and procedures. But what we haven't done, like none of this, you know, the leadership of the province has really talked to us about how we could then incorporate trials or delivery of the actual care, whether we know or not know of the, you know, with regard to drugs and devices, etc. What is our plan for that? And so we haven't had any conversations around that. I mean, these kind of trials require trained personnel, for sure, to be available at each hospital. Experience with trials. Is it impossible to get them going in somewhere like Brandon? Absolutely not, or other hospitals. But we'd have to have a lot of conversations and resources around that. And right now, that is off the radar, other than the small trials group. And so, I'd love to push that conversation up through the incident command chain, as it may be.
Okay, good. Well, although I know, like right in the beginning, when you were trying to get people going for the hydroxychloroquine study, you had a online thing. Was that for wider group, or it just ended up?
That's a good point, Richard. Yeah, thanks for reminding me of that. Like that answer had a lens of inpatients for sure. And is there and should there be opportunities to study outpatients? Absolutely. And hydroxychloroquine was a bust in outpatients, but it doesn't mean inhaled steroids or other therapies. Outpatients, including hyperimmune products like immune modulators or monoclonal antibodies, couldn't be studied as outpatients under those types of trial designs that don't involve the hospital setting. Yeah.
All right. So I'm going to go over. Oh, hang on. There we go. I'm going to go back to Craig, but yeah, I see John's around, and actually Paul Vankis might still be around because Craig, this could be a tough question. So, how infectious are the smaller, drier droplets?
Well, I've not read so many research papers in my life as I have in the last 3 weeks. And in particular, getting a lot of focus has been on that topic. For SARS, there is basically no research on that. Even on influenza, common influenza, and measles and chickenpox, those numbers are not known very well. Tuberculosis is very low number, and but we are talking in the ranges of that there's 1,000 particles, viral particles expelled every second by a person breathing, and once we exercise, it triples. And the like. So unfortunately, there's not a solid answer to that yet. I also don't want to be the fear monger. In the engineering field, there's two sides to this. There's the group that doesn't want to talk about it, and then there's the group that is running around and, I'm sorry to say, but selling product. They're selling ionization, they're selling ultraviolet, they're selling HEPA filters, and those are all good things, and they're all good products applied in the right location. And I think that answer that statement may help on some of the other questions there as I try to answer those online or whatever it is we can do here to help people. There is proper application of engineering controls, but there are places where it's not going to make much of a difference. The back of the ambulance question is a good one. I'm not too sure how we provide engineering controls in a moving vehicle.
Yeah, right. So
I could add a little bit to that too.
Yeah, please, Paul.
It's true that there really is no data out there, but Manitoba and the NML are actually doing some nifty work on trying to assess what the aerosolized particles might infectiousness with some air filter studies. We're looking forward to that information, but we don't have any answers.
Okay. Well, thanks, Paul. All right. So I've actually got a question that came up under Ronan's questions, but I have a sneaky suspicion John may be able to answer this. Sorry, John, I'm going to put you on the spot. But so given the larger number of active cases as well as hospital outbreaks, will we see strict hospital visitor restrictions again, like that no visitor policy that we had in the first go around?
Well, this, of course, is an impossible question to answer, but intuitively, if the situation deteriorates with large number of cases in the community, the vision would be to enact strict visitor restrictions so as to prevent transmission of virus within the healthcare facility. As you know, the more people in the facility, the more likely that they'll introduce germs and transmit those germs within the facility. So at this point, impossible to know, but if the numbers worsen, the answer is yes.
Okay, good. All right, going back to Ryan, and this is a great clinical question. So if a patient is now discharged on new supplemental oxygen, so had not been on that prior to admission, should we continue dexamethasone on discharge to complete that full 10 days, or should we just stop it? I mean, what's the discussion around in-hospital versus community use of that dex? You're still on mute. Sorry, Ryan.
Sorry. That's a bit of a niche question, but my personal opinion as a pragmatic sense was if they weren't on supplemental oxygen at baseline and now still require it, then the course would be appropriate until it's finished as per the trial. So the location, I think that what we need to do is a larger sense is get away from locations. ICU, ward, and home should be replaced by severe, moderate, and mild disease. And so our terminology for therapies are around severe, mild, and moderate, not about where you are, because in a pandemic, an ICU could look totally different when you're overwhelmed and could go to the ward. And likewise, oxygenation could be given in other places. And so if a person still requires oxygen and so still has moderate disease, then the therapy that was shown to be beneficial in that condition likely still applies. So yes, continue it. Richard, now you're on mute. Just want to give you that.
Thanks. Technical things. Okay, going back to Craig.
Like CBC and dead air.
Yeah, totally.
Yeah.
Oh, wow. All right. So this question does need to be asked because it's bouncing between the top two. So are we recommending portable HEPA filters in general hospital settings? I mean, you had kind of thrown that out there, and so obviously people picked up on that.
Yeah, I will say no, not in general hospital settings. In unique settings where we are generating aerosols and we don't have ventilation that is sufficient. So my ventilation being sufficient would be 6 air changes per hour would be my bottom end. 12 air changes per hour would be what I'm looking for. So I talked briefly about the resuscitation room. The resuscitation rooms I think that we have at Health Sciences Center are at 15 air changes per hour. Great air change. Problem is that we have 4 rooms that are shared. So by isolating them, we needed to do something to manage that viral load within that space. So we added the HEPA. So if you had a unique setting, doing some bronchial procedures, endoscopies, and the like, that's where you need to start. That's where you then can start considering. But just sticking one into your common waiting room, I'm not the fan of that. I'm not strongly supportive of that. If you're building a red zone, i.e., this is where I am moving my COVID suspect truly symptomatic patients who are coughing and the like, well, now we're talking a different scenario. We are generating aerosols there. We know these people are symptomatic and sick. So again, I'll encourage, and I talk regularly with the facility management folks across Manitoba, and I keep telling them, you need to be giving answers to your clinical people. And if you don't know who to give you answers, they know to call me and we'll help walk people through. It's great use of an engineering control as a HEPA filter, but a little one sitting in the corner of a massive waiting room, you might as well put incense sticks in there for about as good as it's going to do.
Okay. Good. So now we're all going to use incense. I like that idea. Okay. All right. So we've got 1 more minute. So I'm actually going to give poor old Ryan the impossible question. So there is one about Dex and Pred, but I mean, we've kind of touched on that. So how do you prevent transmission in a pre-symptomatic population? I mean, Wouldn't we all love to know that one? Sorry, it came up under your question.
Well, I have a great testimonial for everyone. No, just kidding.
Okay.
This is what we don't need. You know, whether there's a lot of things on the internet that could prevent this, by the way, but it's a great question. How do we protect healthcare workers? Because that is the obvious extension. How do we prevent infection? And we don't have anything that prevents infection at the moment, a vaccine. And so we're hoping that that will be the target use of something like that. And we wait with bated breath. But right now, there's no agent that could prevent infection and expose people. PPE, hand washing, social distancing, masks should not be forgotten. I think that it's been really well said throughout the speakers that these are fundamentals that we should not abandon. And there's no silver bullet that will prevent the infection as asked.
Yeah, no, excellent answer. And I mean, that is such a fantastic segue into our next speaker. So firstly, I'd like to thank our speakers for the last hour. As usual, lots of information, great discussion there. And then the segue is we're going to actually be talking about flattening the curve and public health ethics applied to pandemics. And so I'd like to introduce Dr. Sandor Demeter. So he is a public health as well as a nuclear medicine specialist, and he works here at HSC. And he's also an associate professor in community health science. And actually, I'll just put in a quick plug for him because on Friday, he's expanding this 15-minute talk to essentially give grand rounds for community health science under the bold ideas. And so look that up on the University of Manitoba Health, the Community Health Sciences website, and you can work out how to watch his full hour talk. So let's hear how you managed to condense the ethics of this into 15 minutes.
Okay, I'll start. This image here is actually from the Art Gallery of Southern Australia in Adelaide, and some of us may be feeling the discomfort of this particular piece of work. So I have no conflicts of interest. The goals and objectives are as per the program. We're going to discuss traditional medical ethics compared to public health ethics, the philosophical underpinnings, and how these apply to COVID control. And I think a big part of my talk is to remind people that when people make policy decisions, the evidence they use to make the decisions is more than these lenses that most of us are used to: epidemiology, efficacy, and effectiveness, and some of us economics. But the ethics, legals, public opinion, politics, and other factors shape their decisions. So it's just not this part which we're comfortable with, it's this part which we might not be that comfortable with. And we're going to focus on ethics. So there is a body of literature dealing with public health ethics. This is one of the resources that I'll refer to later. And there is a psychological thought experiment that looks at the consequences of our actions or inactions. So we make a decision to do something that has adverse effects on other people. So we save one to harm so many. This will become important later in our talk here. So this is the big picture of clinical ethics. This is what most of us in hospitals and medical ethics are used to. We deal with individuals, doctor-patient relationship. Public health deals with populations. We have bedside decision-making with teams. We have populations with routine preventive measures, vaccines, resource allocation, pandemics. Medical ethics deals with do good, do no harm, the autonomy of the patient, and issues of justice and equity. This is the standard medical ethics. But in public health, we deal with collective goods, so the utilitarian approach, efficiency, stewardship, justice. So it's a very different model. In medical ethics, we treat and cure individuals with existing conditions. With public health, we prevent and promote health, and we do surveillance and tracking. And the tools here are just shared decision-making in a clinical sense, and here it's guidelines, environment, policy, law. So there's a big difference between medical ethics and public health ethics. And this is the philosophical underpinning that sort of drives what I'll be talking about. This is normative ethics, figuring out what is the right thing and what is right and what is wrong behavior. And so we have consequentialism, and in this sense, utilitarian. We maximize the benefit or utility for all the individuals, so the ends justify the means. We do something to populations, we put fluoride in their water, and the ends justify the means because we have reduced carries. Whereas another branch of ethics is deontological, or a duty, that the means justify the ends. You can't just use the ends to justify whatever you do. You have to make sure that the duty to do those things upfront is appropriate or correct. And then there's a branch of ethics that are called virtue ethics, which just means that you do the right thing because it's the right thing to do, and not based on the means or the ends. So but this is more public health, and this is more clinical medicine. And we sort of strive to sort of conflict between these. And in that textbook, there's a fellow named Upshur, who's a professor and public health physician at the Dalai Lama School of Public Health in Toronto. This is his principles for public health. So Mills harm principle, which we talked about earlier, Dr. Roussin talked about, least restrictive or commercial methods, reciprocity and transparency. We'll go through these here. So the only purpose for which a power can be rightfully exercised over any member of our civilized community against their will is to prevent harm to others. So their own good, or physical or moral, is not a sufficient warrant. So I like this quote that you have: the right to swing your fist ends where my nose begins. So if we're looking at these measures to individuals, you quarantine them to protect others, you isolate to protect others. There's these emerging things in the media about vaccine passports that'll create stigma issues, mandatory use of COVID app, which the city of Winnipeg got tagged on, mandatory vaccination, which is a polarized and controversial issue, and what is acceptable risk at the individual or population level. So this is the harm principle and some of the controversial issues that we're dealing with. And this is sort of where the rubber hits the mat here. We got strategic harm reduction, and we got blanket harm reduction. At the extremes, you have laissez-faire, do nothing, let everyone get sick, and let things unfold as they would naturally. And at the extreme here, we have a total lockdown with people with curfews and not going out at all. And we're trying to find that balance in between where we still respect personal freedoms or reduce the amount of adverse effects versus the complete lockdown. So this is this unenviable task of finding that middle ground. And the media is full of stories about finding that middle ground. Can Quebec find a balance between the lockdown and freedom? This is, Quebec's gone to the point of having telewarrants available so that if they think you're having a party with more than X people, they can, call a judge and, have a warrant to enter your premises. So it's really pushing the envelope. And there's been a lot of discussion about the elderly, and this was a National Post article recently, October 16th, that the author said, as a society, hysteria seems to overtake our rational powers. Somewhere, someone decided that our goal with respect to COVID-19 should have zero tolerance to death. And I have to say that the tolerance for adverse events is not a scientific, quantifiable entity. It's a societal judgment. We accept that it costs so much to gain an additional year of life saved, and that threshold is not scientific. That threshold is what society will accept. So this is in the same sense of what we're doing with regards to social isolation and where we draw that line. So this is a controversial but polarized issue. And beyond flattening the curve, so we look at these preventive measures which we look at flattening the curve, but these are all the other consequences of flattening that curve when regards to reducing individual freedom. So we talk about social isolation on seniors. So for some, and some have told me that their loved ones tell me that the social isolation they're going through is a worse state than death for some. There's lockdown, sort of institutionalization, end of life scenarios, and who can be with the loved one. Impact on mental health, domestic abuse, homelessness, drug use and overdoses, unemployment and economic sequelae, child and family services, elective care services, preventive health care services. These are all sequelae or adverse events that are related to some of the procedures we do to flatten the curve. And we'll talk about that at the end here. Reciprocity means if you're going to do something to somebody that reduces their freedoms, you have to give them the resources to do that. And I just have to remind individuals that we're focused on the acute care sector, flatten the curve to reduce the impact in the acute care sector, but no one's really talked in the press about the impact on the public health sector. And the public health sector in Manitoba gets about 7% of the total provincial health budget. So part of, hopefully, this scenario is to reduce the impact on public health as well. Transparency, this is really important. All stakeholders should be involved, all should have equal input. In essence, you have to tell people what you're doing and why you're doing it. And the common thing I hear in the news is that we will release information if needed for public safety. But transparency goes beyond that. You have to, if you want to engage and have buy-in by a society for these restrictive measures, you need their trust and you need their confidence. And to do that, that's another reason for transparency beyond for public safety. And this came to play with the Public Health Agency of Canada had a 2008 Auditor General review. This was after it was formed, largely due to SARS, which is the catalyst. And they said that the agency has not made satisfactory progress in those related to strategic direction, data quality, results measurement, and information sharing. So, and I'm really curious to see what the next Auditor General report for this will be, because this could all be resolved by now. But if you look at the Public Health Agency of Canada and its tangled network of all the agencies and committees and task force and that it has to interact with, you can imagine the communication challenges for trying to keep all this, never mind the fact that the federal government has jurisdiction for health in very, very limited capacity versus the provinces, which have the primary responsibility. So this is probably to say that's really challenging for PHAC. There are some other issues that I think are important. And as some of those lenses I talked about, policymakers will be looking at more than just the epidemiology, efficacy, effectiveness, and economics. And the Canadian Civil Liberties Association has a very active website that looks specifically at COVID-related updates. And they look at the issues of privacy, mobility rights, policing enforcement, and due process. And they have essays on all of those, which are other aspects of the consequences of COVID preventive measures. For example, the policing and enforcement component looked at police forces, especially in Ontario, who were actively seeking information from COVID databases before attending to calls. And so they were having access to private health information. And there was challenges to that, and the practice has stopped because it's not really a practice you do normally, that you see what the health status of the individual you're attending to is before you attend them. So this is an interesting other perspective on the impact of COVID-related enforcement measures, and it's some of those other lenses. And
3 minutes, Sandor.
Sure. So this is fascinating because there is a group with the initial signatures were prominent scientists and physicians, the Great Barrington Declaration, which looked at a more focused approach when I had that spectrum from blanket to strategic, a more focused approach to COVID control. And as of a couple of days ago, they had 10,000 scientists, 27,000 medical practitioners, and almost 500,000 concerned citizens. And they're a little, it's a bit of a polarized look at the focus control end of that spectrum. But you look at policymakers, they would look at this kind of information as a reflection of an interest group that might be impacting their decision making. So this is my last slide, and I think it's the most important slide. As we make decisions, and I agree, we do have to make decisions that are strategic to reduce the consequences of the train going down this track and hurting all these people due to COVID-related morbidity and mortality. So we throw the switch and we put in control measures, but those control measures have impacts on all those other issues: mental health, preventive care, elective services. And I've sort of blurred this person out because they're the unknown person, because they're harder to define, they're harder to identify. The causal link is not as there. So I think as a system and as a state and as a government, if you're going to impose COVID-related restrictive measures, you have to be aware of these adverse events. You have to monitor them. You have to mitigate them to the extent possible. You can't fix everything, and you have to communicate. And I think we should have a dashboard for things like police calls, suicides, drug use, those things should be front and center as much as flattening the curve, to show that the government is aware, is monitoring, and is trying to mitigate it as best as possible. I think this is the trolley experiment. We're sort of forgetting about this side of it from a systematic point of view. And that's my talk.
Excellent. Oh, thanks. And I'm assuming on your Friday talk, it's obviously going to go into way more detail there. So.
Yes.
Yeah. So thanks. And yeah, we're moving into these really, really tough areas. I mean, the next discussion is what to do with that last ventilator. So really going to one of those polarizing parts of what you were talking about. So our next speaker is Dr. Adrian Robertson, here from the U of M. And Adrian is an emergency physician and an intensivist, and has clearly a keen interest in medical ethics. So, and we have a slide. Fantastic. Over to you.
Good morning. Thank you for everyone for joining. Very special thank you for all the Winnipeggers or other people from outside the medical community that are joining us today. Certainly makes these presentations more interesting. So I've got the privilege of presenting what to do with our last ventilator, which, as it's an ethics talk, just be aware that the title is in fact a trap. So I have no conflicts of interest to declare, but I would like to point out that we ration healthcare all the time in certain scarce resources. Organ donation would be an excellent one. So if anybody is concerned about access to limited resources, they can take a look at the other things that we battle with every day and ask themselves, are they participating as fully as they can? The objectives, we're going to talk about distribution and use of limited resources in a time of crisis. We're going to talk about some of the ethics of that distribution of resources, and we're going to talk about how the distribution of those resources change as the crisis changes. I'm also going to add that my personal objective in everything related to COVID is to have people acting more thoughtfully, more responsibly, and with less fear. I think that a lot of the fear that we have is driving just entirely too much. So it would be imprecise to jump into rationing without realizing that really our first duty is to avoid rationing in the first place. And we can avoid rationing really by doing two things. The first thing is let's avoid the situation where we reach the point that we exceed our ICU theoretical maximum threshold, which I'll discuss in greater detail later on. And this is a part where we really all have a place we all have responsibility. Everybody in society has their role in terms of participating with the greater mixing and social distancing, hand washing, mask wearing. I just share my own personal observation that as mask wearing has become more commonplace, my observation has been that hand washing has been reduced, and I would encourage people to continue hand washing. The second part of it is to expand our resources such that we can handle more if necessary. And that's really in part what this talk is about. So to increase our resources, we can add more ventilators to the system. But is it really as easy as just buying a limitless supply of ventilators? Honestly, I wish it was. The truth of the matter is this is not about ventilators. There have definitely been situations, and for those of us that have had the opportunity to work in faraway places where you're in a hospital that literally only has 1 or 2 ventilators, and the normal course of events means deciding who gets that ventilator. Or maybe in the very, very early days of this crisis where there were local areas that might have had their total number of ventilators overwhelmed. That is not the situation that we're facing here. If the genie popped out of the air or the fairy and came to you and said, what would you wish for? And if somebody wished for, I wish that everybody could have a ventilator, that would be a terrible use of your wish. A ventilator by itself does nothing. I think it's high time that we all stop believing in the power of inanimate objects. I will add that ventilators do have the capacity to move if you plug them in and dial the instruments correctly, but by themselves, they do nothing. The fantasy of X number of ventilators is going to save us or going to avoid any of the problems that we might face in the future is a complete falsehood. And it was very interesting, especially in the first wave of lockdowns, watching TV and listening to different people describing how they had ordered some 10,000 ventilators or were moving 20,000 ventilators from one area to another area. And honestly, that is in and by itself largely meaningless. So it's not the number of ventilators. The beautiful truth is that our intensive care units and our emergency departments, for that matter, are staffed by teams of dedicated people that work together in a highly structured environment. And each of those people bring unique expertise to the team. I've listed some of the people here, but I will obviously have missed some. And I've largely left out physicians on purpose so that we are the group that's left out, as well as the many others that will be left out of this. And it's this team working together under its usual restraints that provides best care. As we stretch this team, as we ask people to do more, that's when we start to erode our ability to save lives. And along with this team comes some equipment. The equipment is the relatively easy part to get more of. What's difficult is actually to get more people. So it's these teams that save lives, not the machines. So the critical care threshold maximum is really defined by how far can you stretch the people that you have. So we can always turn more beds into critical care beds, and there's lots of plans to make more critical care beds. You can always buy more ventilators. We've got more ventilators than I think we can theoretically use. You can ask staff to work more frequently, to work longer shifts. Retired staff can return that have critical care skills. We can second critical care staff that have moved on to other areas and bring them back. We can stretch further than I think we have even imagined so far. But at some point, that stretching reaches the point that stretching further results in no additional lives saved, that the reduction in the level of care in stretching further results in the same number of deaths. So rationing in ethics, or ethics of rationing. So the first thing is to understand that in order for society to accept this and for it to be fair, no group should be excluded. And so that essentially includes every group you can think of. So no one group should be excluded at the onset. The second is justice, in which everyone should have an equal chance to be considered. That doesn't mean that everybody gets an equal chance at the end of consideration. It means that everybody gets an equal chance to be considered. And the consideration process needs to be based on some principles that we can accept. For the most part, this is where there's lots of room for controversy, and in 15 minutes, there's just no way that I can enter into that controversy. So I'm just going to sort of speak about what there is the most support for. So the most support for is the idea that with limited resources, we should help the most number of people possible. And for that, we should be picking those people who are most likely to survive should they receive the resources over those who are less likely to survive. Maximizing the number of years saved is an important consideration, but it's a delicate balancing act between how much homage you pay to any one of these principles. And then there's always the dissatisfying yet commonplace question of who gets in line first, and should the first come first serve be a method of allocation. It's largely dissatisfying. New England Journal put out a paper in May suggesting that this be avoided, and they suggested alternative methods. So if there are two people that have equal claim and only one resource, that some other method should be used, whether it's a lottery or some other method. And you can think about this in a broader scope than just ventilators. What about people with an equal claim, say, for a vaccine? How should we distribute the vaccine? Is it first come, first serve, or is it again a lottery? And if it's first come, first serve, does that put people that live further away from the hospital or further out of town at a disadvantage to people that live, say, in town? And I think these are the points of what we're trying to do. Further, the rationing should be dynamic. So as you've heard throughout the day, especially this morning, there is so much that we are learning about this specific disease, and it's changing all the time. One of the interesting parts about being part of the medical response to this is we would sometimes have protocols for just a simple patient care or simple patient movements change multiple times in a day, never mind multiple times in a week. And so as the medical evidence improves, we need to be able to react to that evidence and make sure we're using the most up-to-date and reasonable evidence in the case of any rationing should it occur. We need to avoid the application of broad policies applied blindly. And there is a big push to have different locations publish their policies about how they're going to handle any one kind of restriction. The problem with this is that those policies cannot possibly keep up with the information of the day, nor can we necessarily predict the questions that we're going to be asked. And so those policies are going to have to be vastly different. So on a ventilator, somebody who is, say, 20 years old and otherwise completely healthy versus somebody who's 40 years old and has lots of comorbid conditions might have completely different ranking for who gets a ventilator versus who gets a vaccine. In fact, they should be reversed. So not having a single policy that's applied too broadly is very important. Transparency is critically important, and protocols and policies as they're developed have to be made public. And
Adrian, sorry, 3 minutes left.
Thank you. And if any rationing that does occur needs to be reported and kept record of. I just want to talk briefly about the rationing with a change in the severity of the crisis. So the phase one is going to be stretching of the system. And I'll tell you, stretching of the system is in fact a kind of rationing, in that the kind of care that you get in a stretched system is going to be less than you get in an unstretched system. The second would be rationing based on the likelihood of survival or survival of years. And this would happen as we become to reach the extreme ends of stretching. Third is limiting what we provide. So it might not just be that we've run out of ventilators, it might be that we can't offer dialysis, or that we put limits based on, say, your response on a ventilator over a number of days, depending on what the disease is telling us about your ability to get better. The fourth is when the system's truly being overrun. And in that case, we may prioritize people that allow us to continue the fight, in the sense that if you don't prioritize those people, then there's nobody left to continue the fight. And then finally, in the nightmare scenario, which, and by the way, I have no thoughts that we'll ever get to phase 4 and phase 5 in this pandemic, but in future ones we might, is one where only a small percentage of people survive, and we literally pick people based on who's left to seed the next society. So quickly mentioning transparency, when guidelines are produced, they should be made public. There are no guidelines in Manitoba at the moment involving rationing, and it's my opinion that that's the appropriate place to be at. We don't know enough about this disease or the questions that we will be asked to answer around a specific shortage. As those evolve, we'll have to make those policies and then make them public. Rationing should not happen behind closed doors, and there should be disclosure. Healthcare in Canada is a resource we all own, pay for, and benefit from. It is a gift we give ourselves. And then finally, who should decide? It's important to understand that the medical teams can't escape their proximity and their expertise in answering these questions. However, the decision should not be left to medicine alone. The weight is too great, and we're not the only ones solely responsible. Senior leadership, politicians, societal leaders, and each and every one of us have our own piece in the healthcare system that we have to own. And each of us have made decisions that impact the day when we get there, including our social responsibility that we're each participating in today, every day. Ideally, resources allowing, there's a rationing team that assesses the case with rigorous standards and consistent application of the best science of the day that holds up to scrutiny in the future. I'd like to thank you, just to remind you that there are more beautiful places in the world and places we can travel to. This is LaConner, Washington, during their Tulip Festival.
Thanks very much, Adrian. Very, very thought-provoking. And I truly trust that we are not going to ever get to those last two stages that you mentioned. So anyway, so let's move on to Dr. Mark Loeb. He's beaming in from McMaster today, and he's a medical microbiologist and ID specialist at McMaster. And he's conducted randomized control trials in the area of respiratory protection. So he's probably our best guy to be talking about PPE for respiratory pathogens. Over to you, Mark.
Thank you very much. Thank you very much for the kind introduction and for the invitation to speak about personal protective equipment for respiratory pathogens. So as the theme of the day is on COVID-19, I'm going to be focusing on COVID. And the objectives will be to understand the differences between N95 respirators and surgical masks, and to describe the evidence comparing the relative protection of surgical masks versus N95 respirators for COVID-19, because that's a very controversial area these days. And in so doing, I'll try to assess the strengths and limitations of data on the transmission mode of COVID-19. So I'll just get to the nitty-gritty, which is what really is the most appropriate respiratory protective equipment for COVID-19 for healthcare workers? Is it the surgical mask, or otherwise known as the medical mask, or is it the N95 respirator? And the controversy is not for aerosol generating procedures, but it's for non-aerosol generating procedures. And this slide just summarizes a lot of the controversy. You can see that the World Health Organization recommends a medical mask for non-aerosol generating procedures, whereas the CDC, the US CDC, recommends an N95 respirator, as does the European CDC, whereas the Public Health Agency of Canada recommends a medical mask. So the controversy, you could see, is within the non-aerosol generating procedure category. All organizations recommend N95 respirators or their equivalent for aerosol generating procedures. And when we talk about medical masks or N95 respirators, it's interesting to do a sort of a compare and contrast. A medical mask is really meant to protect the wearer from large droplets, splashes, sprays, and sometimes it'll protect patients, let's say, who are immunocompromised. In contrast, the N95 respirator, it was meant to reduce exposure to particles, small particles, including small aerosols. The medical mask is relatively loose fitting, whereas the N95 respirator tends to be tighter fitting. Formal fit testing, as most of you are aware, is required for the N95 respirator, which isn't required for the medical mask. A user seal check is supposed to be done with use of the N95 respirator, not so with the medical mask. Filtration, depending on what study you look at for medical or surgical masks, are quite variable, whereas the standard is filtration at 0.03 microns at 85 liters per minute at a level of 95% for the N95 respirator. So leakage, at least ideally, is supposed to be minimal for the N95 respirator, whereas there is leakage around the edge for the medical mask. And in terms of regulatory standards, the medical mask has standards about fluid resistance. So depending on the type, the level of fluid resistance might increase, and that might be done in the context of differential pressure. Whereas the N95 respirators, although there's a degree of fluid resistance, they're also categorized based on their resistance to oil, and the N95 is not resistant to oil. And I mentioned that the controversy is around non-aerosol generating procedures. For aerosol generating procedures, there seems to be widespread agreement that the N95 respirator is the way to go. So this is a systematic review and meta-analysis of different procedures done by Tran and colleagues. John Conley was the senior author. So you can see that procedures like intubation, tracheotomy, non-invasive ventilation, manual ventilation, all pose a high risk, from a 3-fold to almost a 7-fold risk based on observational studies. Procedures like nebulizer or high flow nasal oxygenation, based on the data, the risk isn't that substantial, but they're considered aerosol generating procedures. So N95 respirators are standard for those procedures. Now, just to sort of step back a bit, it's good to just think about things more broadly in terms of what are the multiple possible paths for transmission. And as you can see, there's large droplet and aerosol. So large droplet is this sort of splashing. It's meant for liquids that are affecting the upper pharynx, whereas aerosols are just small aerosols, small particles that actually are breathed into the lungs, right? And depending on the size, the distance that they travel distally will increase. And then there's direct contact, which isn't really part of the major controversy. There seems to be less evidence for COVID transmission with direct contact, and that could be either direct or through fomites. And it's sort of interesting is that there's been a traditional distinction between droplet and airborne transmission, which by our aerosol biology colleagues is being aggressively challenged. So this cutoff of 5 microns, so the traditional thinking is that droplets or particles that are larger than 5 microns basically are droplet spread. Basically, they fall to the ground within 2 meters of the index case, whereas airborne particles referred to as droplet nuclei or aerosols are smaller, less than 5 microns, and can stay suspended. But interestingly, the evidence seems to be relatively dubious for this level, this cutoff of 5 micron. No one seems to be able to find what the evidence for it, and the aerosol biologists are telling us that the actual threshold is probably more like 50 or 60 microns. So I think it's fair to say that based on experimental evidence, that it's really a continuum, that when someone is talking or singing or coughing, that there's an array of droplet sizes or particle sizes, and when we call them droplets or airborne just means it stays in the air, means that there could be transmission under short distance with smaller sized particles. And the fact is that the length of traveling is of the droplet is dependent on physical characteristics of the droplet itself, of the environment, for example, the temperature, humidity, etc. But regardless, we still have to make decisions in healthcare, and we still have recommendations on so-called droplet where we're using medical masks versus what we think is airborne, N95 respirators. And it's important to look at the evidence for that. And in terms of what's being presented in medical journals, this is a summary review from JAMA about transmission of SARS-CoV-2. The authors make the argument that based on a reproductive number of 2 to 3, a relatively low secondary attack rate, higher risk to household members, relatively low infection rates in healthcare workers who are wearing face masks, that the transmission is so-called droplet, short distance. But I think it's fair to say that there are multiple routes of transmission possible at shorter distances, and there is uncertainty. And it's very interesting that people will look at the same data and come to, diametrically opposed conclusion. This is a paper from Nature that looked at the aerodynamic analysis of SARS-CoV-2 in two hospitals that were affected by COVID. Essentially, the authors took filters and found traces of virus based on nucleic acid amplification in various areas where people were taking off their protective equipment, etc. And a lot of us who look at this, myself included, would say, well, this just means that when you do this sort of study, you will find pieces of RNA about. It doesn't necessarily mean that there's aerosol or airborne transmission. And there's another paper that's done the same thing. This time, they've shown that it's a viral, that it's a virus that can actually replicate, but it's the same sort of thing. Transmission has never been documented, and it's difficult to do. And again, part of the debate is that people will look at the same sort of data. This is the famous outbreak in choir practice in Washington, where there was an index case who was confirmed positive for COVID, who exposed an entire choir and at their practice. And you could see it's almost like a point source outbreak. And if you're an aerosol biologist, you'll say, yes, this is a super spreading event. This is definitely aerosol transmission. If you're a clinical epidemiologist, you can say, well, if you look a little bit closer, there was a lot of mixing going on. People were sharing, well, not necessarily sharing drinks, but getting at breaks, they were getting food together. So there could have been another form of transmission. So I think it's very hard to say, and like anything in medicine, you can never say it's always or never. It really depends on the situation.
Mark, there's 3 minutes.
Okay. But I think what's really important is that when we're looking at healthcare interventions, we want to look at evidence-based practice, and we want to use randomized controlled trials. So we will not use cell culture data to make decisions on vaccines. We do phase 1, phase 2, and phase 3 studies, and it's the same thing, in my opinion, with these personal protective equipment. And if we look at the data, this is a systematic review and meta-analysis done by Jessica Bartowska, who's a PhD student at McMaster. She looked at the pooled evidence for randomized controlled trials for respiratory viral infection, and the effect size was 1.06 with relatively wide confidence intervals. When Jessica looked at lab-confirmed influenza, and in fact, one of the studies was ours here, again, an odds ratio of 0.94. So again, it's really not a massive difference between the two interventions. In fact, one of the studies was a randomized controlled trial that we were doing, where we randomized 450 nurses to either the surgical mask or the N95 respirator and followed them up. We were looking for influenza, and we found no difference between the two groups. But interestingly, we used multiplex PCR, and we looked at coronavirus, and we found actually that the attack rate was a bit higher in those nurses who were wearing the N95 respirator, an attack rate of 5.7% versus 4.3% in the surgical mask group. That's not statistically significant, but as far as I know, it's about the only individual level randomized controlled trial data on coronavirus and personal protection. And there have been observational studies. This is a study by Derek Chu showing about a 70% risk reduction with any type of face mask. And also studies looking at, this is again Derek's study, looking at risk reduction with N95 respirators or surgical masks, again showing a little bit of better effect of N95 respirators, but very poor studies. Anyway, there's a lot of issues with those studies, making it very, very difficult to interpret. So the bottom line is we really need a randomized controlled trial of medical masks versus N95 respirators to prevent COVID-19 in healthcare workers. And this is what we're doing. So we're doing a non-inferiority study where we're randomizing nurses, physicians, respiratory therapists, and personal support workers in hospitals or long-term care facilities who've been exposed with COVID, excluding individuals who have not had a fit test in the past 2 years or are in a high-risk category. We randomize them either to the medical mask or the N95 respirator and do a 10-week follow-up using automatic text messages. So a very simple design. If they get symptoms, they get tested for COVID, and we do serology. So we're enrolling now from various cities in 3 provinces. So if anybody is interested in being an investigator, please just send me an email. So I'll wrap this up by concluding that there's certainly uncertainty as to the transmission mode, but it appears to be in the main at short distances. There's observational data to show risk reduction with face masks. Randomized control trial data on non-COVID-19 viruses suggests little differences, but the confidence intervals are wide. And we really need to complete this RCT to figure out and compare medical masks to N95 respirators for COVID-19. Thank you very much.
Oh, thanks, Mark. Just out of quick interest, like how long are you expecting to have to run that trial? And like when would we even get an answer for that?
Well, it was slow over the summer, but as could be expected, it's picking up. We've enrolled about 20% of participants, and I assume that before Christmas we'll be at maybe 50% or more. So I think in the spring, early spring, I would say. Excellent.
All right. Yeah, and there'll still be plenty of virus around there, so we want that answer. Okay, so thanks to the 3 speakers. Very thought-provoking. So let's get back to we've got 15 minutes of questions, and if they carry on coming in, I don't mind going a little longer, but I do appreciate people need breaks. So let's start with Sandor. So first question, love the idea of having a dashboard to measure the adverse effects of some of our public health measures. Yeah, very, very good idea. I do agree. But how likely is it that we can achieve this? And I'll put in my own little twist to that. I mean, especially considering, as you had quoted, we're only using 7% of total budget, healthcare budget. And does that make it that those sort of dashboards and those ideas, is that possible even?
Thank you for the question, and if I forgot, thank you for the privilege of presenting it to this seminar. So I think the first, from a public trust point of view, I think the public would like to hear that this is being looked into. Someone is monitoring this. Someone is aware of these, and at a really crude level, you could look at really simple metrics like year-to-year net differences as a starting point at the hypothesis generator, whether the net differences in suicide rates, in mental health calls, in domestic, you could look at that as a starting point and then refine that down to where you need to be to create a dashboard. And the resource thing is, I think this is as essential to resource as all the resources we're putting into flattening the curve. Because if you flatten the curve and don't know the adverse consequences of what flattening the curve is, it sort of defeats the purpose of the public health ethics of minimizing the impact of your control measures. So the resource question is a political question, priority question, but I think you could start really at a crude level about looking at impacts based on net differences between years, and some of the testimonials of individuals who are especially institutionalized and vulnerable.
Yeah, and then potentially have a much better educated societal discussion about this, because I have to agree, the polarization in the media often centers exactly around some of these things you talk about. Yeah. Okay, good. All right. So moving on to Adrian. Great question here that picks up on one of your points. So what are your thoughts about training staff from other specialties now? So for instance, surgery, family medicine, for preparation for that possible system overload?
So I think it's an excellent question. So the good news is that we actually have a system where we have a significant number of people that actually work with us in the ICU that are primarily based in other specialties, but that learn to work with us, that become natural extenders. In terms of actually, producing more critical care nursing staff or producing more respiratory therapists or more intensive care doctors, unfortunately, there's a huge lag in those of over 6 months to multiple years. So that's more challenging, but we do have in our system a wonderful group of family physicians who work very, very closely with us and pick up the skills that would become a natural part of an extension.
Okay, good. So the building in capacity, that's super important. So,
always important.
Oh, yeah. Okay, over to Mark. Yeah, and you knew this was going to come up. So, how effective are face shields? I mean, so you see people wearing them instead of masks because they say they can't breathe, but so they use face shields. Is that of any use?
Well, I think it's of some use. I'm not, again, I'm an epidemiologist, so I go on epidemiologic data. I'm not aware of any comparative data. I mean, I haven't searched the topic. I know the aerosol biology group is, still has concerns because of the potential for transmission of aerosols, but I haven't seen any data, any comparative data, face shields, no face shields in real healthcare workers that have actually tracked COVID to comment on that specifically.
Okay. Yeah, and yet we still use them, hey? Okay, all right. So going back to Sandor, yeah, tough question. I'm not sure if you've got some additional insight. I mean, so this links kind of to what Brent talked about at the beginning of the day with that green and yellow and red. So if we often hear, if things get worse, we will do X. So how are we currently determining when things are worse enough to start more restrictions? And so you might have some insight on that.
Yeah, I don't know the science behind the metrics of 4% positivity rate leading to certain thresholds. I have to say I don't know the science behind that. I do think one of the transparency issues is, as a society, we can't kid ourselves that we are going to go through this pattern of up and down until we get a vaccine. So we're gonna flatten the curve, and we're gonna slowly reduce the restrictive measures, and it's going to come up. So I think as a society we should expect to go through this undulating pattern. And I don't have an answer for you as to where the threshold should be to set, when we stamp it down again, and how far we let it go up before we stamp it down again. So I don't have an answer to that question, but I think we should be transparent and expect that this is the model that we're going to be going through until we get a vaccine. Things aren't going to change. If we remove restrictions, we'll increase transmission. And we accept to live that way. That's fine. And society will decide through COVID fatigue and ability to tolerate the restrictions. I think there's going to be a lot of to and fro between society and individuals and the public health measures. And that's I think that's going to drive, just like the decision that was made overnight that bars that are linked to hotels, or restaurants that are linked to hotels can still open. So they made a change on the fly, and there was probably a significant amount of lobbying in the back room for that change. So that's a societal judgment, not a scientific decision. So that's sort of what's going to happen, I think.
Mm-hmm. Yeah, I mean, I do have a little bit of additional insight in that within public health, they do have this kind of dashboard of multiple indicators, but as you say, having some transparency would really help society to kind of accept that fluctuation that's going to linger for the tail of the flattening the curve. Okay. All right. So, well, Sorry, Adrian, but you knew this was going to come. So, are there written guidelines in Manitoba to address dialysis for the 95-year-old with family wanting everything? And I mean, as acute care clinicians, we come across that all the time, especially in Emerge. So, have you found an answer for that?
So the answer is easily no. There isn't, and nor would I want there to be one. So a 95-year-old is not necessarily a 95-year-old, just like a 30 or 32-year-old is not necessarily a 32-year-old. And I think it's imperative that we take a look at every case and take a look at our ability to interact with that case and reach the goals that the person actually desires. And so when resources are less limited, we've got more that we can offer. And if we get into a scenario where we are very, very limited, then there's going to be less than we can offer. But it's important that's sort of an equal share of that, and it's an equal share of that. But I don't think. So we don't have a policy. But even if we did have a policy, I would never want age, for example, to be a criteria.
Mm-hmm. It essentially it requires that individual discussion, case by case, and the decision between family and clinician.
I absolutely. There's also just some understanding of individual patient variability that would need to be looked at the time. So, when people ask me in my organ donation role, am I too old to donate? I tell people that the oldest liver donated was 93 and the oldest lungs that were donated were 88. And a lot of people have an assumption that if they're over 60 or over 65, pick a number, that they can't donate. And if the owner of that liver had a good liver, what else was great about that owner, right? And so everybody's a bit different, and we need to take a look at who we can help at the moment, not with an arbitrary thing like age.
Right. Great. Okay. So, Mark, this is a highly ranked question. So, when making or buying these homemade masks for day-to-day use, what's the best material to use for maximum protection and comfort? Not sure. Hopefully, you can shed some light.
I'll be honest with you. That's not it's not all my area. So I can't say in terms of in terms of what material is clearly more protective than the other. Again, as an epidemiologist, if I'm looking at data, there is none. There's meta-analysis that actually have looked at masks in the community, and it's mainly these were surgical masks and some other variety, but there's not really good epidemiologic data. So I don't know. My best advice would be consistent and wear your mask. I mean, if you look at the randomized controlled trial evidence of, it's suggestive of, at least over and above other, other precautions, about a 10 to 15% benefit. Not always statistically significant, but a benefit there. So I think the more important thing is to be consistent and to use physical distancing and the mask is both as well. But I can't with any sense of authority say this or that type of material will be better for sure.
Sure. Okay. Well, there is another question on your site, but I think all three of you would probably have some good insight here. So, because it's not only scientific question, it's ethical. So why are patients not mandated to wear masks? I mean, shouldn't the patients be wearing the mask? And if the mask wearer is mostly protecting others and not themselves? So I'll throw that out to you. There may be some specific science, but I'd be very interested to hear the opinions of the others.
So Richard, it's Mark. So is that question just related to a known positive COVID individual sort of early on as source control? Is that? I think that's the question.
Well, and it's a vague question. So I mean, obviously, if they're positive, that's a clearer scenario. So let's start there. Yeah.
Yeah. Well, I think in certain circumstances, it might make sense in emergency departments in areas where that a person is being transported or something like that. But as most of you are aware, that once a person is positive, they can be positive. Their viral load can be positive sometimes for weeks. So I would say that in certain circumstances, it might make sense. Why it's not an overall policy, I'm not sure. But if we look at the statistics of the attack rates in healthcare workers, overall they're extremely low. If you look at this, it's in Canada in the healthcare setting. 1% or even less, using the precautions that we're using. So it doesn't appear to be very much higher than even the general population. So that's one thing. And the other thing is, I guess there's sometimes some of the transmission is in people who aren't even suspected of having COVID to begin with. So, if you want to extend that and say, well, do we ask everybody to wear, a mask and would that be helpful? I'm not sure that that would be, and I don't think that would be an appropriate use of resources.
Yeah, good. Sandor, have you got any comments on that whole mandatory word?
Yeah, I think, one of the realities that I've seen with this debate about focus versus blanket is the masks become sort of a flashpoint for a larger philosophical discussion. And the mask thing in itself is a fairly small little component. And I think that, it's not unreasonable to ask people to wear masks. And healthcare workers are wearing masks. But the issue for the very small, and in our department, we had one individual at the whole COVID thing that I remember that didn't want to wear a mask. And you got to pick and choose your battles and figure out what you want to do with that. So one of the approaches is that we expect healthcare workers to protect themselves from potential unknown exposures, whether they have COVID or not. We put PPE on, we wear gloves, we wear gowns, whatever. And so to that extent, I don't know if it's worth the effort at the individual level of a patient unless they're known to be infectious. That's a different scenario. But if they're just you go through, why aren't you wearing a mask? Can we provide you a mask? You go through all that. At the end of the day, do you want to call security and force a mask or deny care to someone? Or do you protect yourself from them, right? So I'm very pragmatic that I wouldn't force people to wear masks in that scenario, knowing it's going to be a fairly small, once you dig down to the reasons why they don't want to wear it. And at the end of the day, the people who aren't going to wear a mask is going to be a very small number. And that's not really a battle that I want to choose to pick. There's bigger issues to deal with.
Yeah, completely. Good. Adrian, not to leave you out, any last comments?
I would just add that I think there are times that we ask patients to wear masks. There has to be a balance between the burden of wearing the mask. You're in the hospital 24/7 for several days in a row to ask them to wear that mask for 24 hours a day. I think is burdensome, but we certainly ask people to wear masks during certain periods, especially when they're up and out of bed. I don't think that's unreasonable.
Well, I'd like to thank the three of you. Very much appreciated for your time and your preparation. Some really good discussion there, new insights and research knowledge. Fantastic. And so for everyone, please remember to go to Slido and do the speaker evaluations. You can go through each person. And then also make sure you have actually registered so that you can get your credits for today. I appreciate that we are a little bit over, but I hate to cut off good discussion. So we will have slightly shorter break. So we'll still end up starting at 12:45 sharp. And so now we're going to move on to completely different area of discussion around sports and kids and schools. So just excellent lineup coming after lunch. So enjoy the break, and we'll see you at 12:45. And just FYI, this Zoom will continue just running continuously for the whole day. So if you do log off, make sure you find that original for the second 3 hours of educational seminar for the Bug Day 2020. Just to let everyone know, this is a massive event. Actually, it's turning out to be one of John Amble's masterminds. It's apparently we've got well over 2,000 people signed in. Sorry, Peter, you have to turn off your volume. You turn off your mic. We've got over 2,000 people onto Slido, and we've had well over 3,000 views on YouTube. So that's fantastic. We're really getting the message out there. So I'd like to introduce our next speaker. Very well known here in Winnipeg and Manitoba, Dr. Peter MacDonald. He's a orthopedic surgeon, but he is also the professor and head of a section of orthopedics here at the U of M. And probably more importantly, he is the team doctor for the Winnipeg Jets. And so completely apt that his topic is going to be on restarting professional sports in a pandemic. And so lessons learned from the NHL. And we look forward to hearing what you have to say, Peter. Over to you.
Congratulations on the organizing such a wonderful conference, and thank you very much for having me. It's odd to have an orthopedic surgeon on an infectious disease agenda, but because we usually cause more problems than we solve for ID. But this is a different perspective, and we live in a different world. Organizing such a wonderful conference, and thank you very much. And return to play that we were dealing with, and the 4-phase protocol that the NHL came up with, and the challenges that lie ahead and lessons learned. So why do we care about sports right now, and does it really matter? There's more important things going on in the world with people losing their lives to this terrible disease. Well, the United Nations has pointed out that they're concerned about COVID, the effect on mental health, the impact on social development, and this extends into our everyday activity and our inability to get our usual recreational activities in. And we also recognize there are mental health benefits of watching sports for some individuals, especially those who are unable to participate. And the absence of that ability to watch sports is a negative thing during times of isolation and lack of personal interaction. So when we look at the economic impact of professional sports, it's huge. If you look at the NFL, leads the way at almost $14 billion economic impact per year. And if you look at the NHL, they're the smallest of the big leagues. But if you notice the gray part of that bar graph does indicate that about half the revenue comes from fans in the seats. So that although they designed a bubble for the playoffs, they're probably unable to sustain that over the long term in terms of the economic factors that go into that. The prerequisite of setting this up, both locally and through the league, was that the return to sport would be done safely and have no negative impact on public health or the ability of the public to access healthcare resources. So that was kind of a ground rule with this all. Major league sports that have returned, but only two have used the bubble model, the NBA and the NHL. And the NHL and NBA kind of returned simultaneously. The NHL had a 4-phase protocol, Phase 1, self-quarantine for 14 days. Phase 2, returning to your training facility, which did not have to be in the trainings in the team city, and it was voluntary. And Phase 3 was full training camp, and Phase 4 was return to play. So I'll just go over the phases briefly. Phase 2 was again voluntary, and it was to allow players who have been isolated from COVID to safely return to training, because some of them were deconditioned as a result of their isolation. And it was designed to allow for adequate time to return to competition and proper conditioning. The overview was that there was temperature and symptom checks. They're permitted and non-permitted persons within the training facility, and there are preventative measures outside the training facility in terms of social distancing, personal perspective, PPE, cleaning and disinfection. We did a pre-participation medical examination for all players, and we've done virtual this time. And this included a more detailed cardiac screen than usual. Usually we do an EKG and only do an echocardiogram if the EKG is abnormal. In this case, we had 2 players who contracted COVID prior to the onset of the 4-phase return to sports. And they were, of course, under isolation in their home cities. But we also did a detailed cardiac screen. Has been documented in several journals that there are cardiac complications in 10 to 15% of those who contract COVID. And this includes direct viral myocardial damage, hypotension, ACE2 receptors downregulation, and arrhythmia events. So the NHL screen included physical examination, EKG, echo, and troponin if there's a history of contracting COVID-19. So we needed somebody to enforce the rules, to give the players and the league the confidence that everybody was following the regulations, and therefore each team had to hire a club facility hygiene officer, and this would be someone who would oversee and implement and ensure compliance with all aspects of Phase 2 and 3, and they would consult with the medical team who looked after the team, including the athletic therapists, equipment managers, doctors, and the club's infectious disease consultant, who was Dr. Emble, and the arena cleaning personnel. Facilities were cleaned more often. It was cleaned before reopening, thorough cleaning, and then between player usage, and then at the end of each day. So there was extensive cleaning going on at the MTS Iceplex. The Phase 3 was formal training camp. Again, at the MTS Iceplex, the goal was to safely allow players to return to club facilities for training. No more separate groups, and otherwise similar to Phase 2. There was PCR testing done 48 hours before returning to the facility, and then every other day after that. And Phase 4 was return to sports in 2 centralized hubs, Edmonton and Toronto, creation of 2 bubbles, and there was rules of how you enter the bubble. The clubs were permitted to bring a maximum of 52 persons to Phase 4, including the club's traveling party, included players, coaches, club executives, and club personnel, and travel was by private charter. So here you can see the travel restrictions and the guidelines for getting on the charter. 14 days pre-travel it started, and then some more strict isolation, 7 days pre-travel. And then on arrival, there's initial 5 days where there was testing, and people were to remain in their hotel room and minimize their social interactions other than going to the rink. So the players must remain in the bubble at all times. They had daily testing, and as I mentioned, the first 5 days was more strict. They're encouraged to have room service in their meals, and after that, there's dedicated meal and recreational areas. If they had to leave the bubble to go to an emergency department, and most of the medical care was within the facility, but so if they had a more serious injury, if they had to leave, they had to re-enter with 4 consecutive negative PCR tests over a 4-day period and quarantine in the hotel room until the testing is completed. The testing extended even to the non-testing or the non-team personnel, including the room keepers and like security guards and all sorts of other people who worked in the hotel. and they were required to have routine testing and daily temperature checks and report immediately to the proper authorities. They tried to make life in the bubble doable in terms of having restaurants that were closed down and cleaned for teams to come in and eat dinner, players' lounges and amenities, and social activities. If a team was to go golfing, they would close the actual entire course where the team could be isolated on the course. And this is a representation of the bubble where there was Rogers Place in Edmonton with the three hotels connected, and the teams divided up between basically 2 of the 3 hotels. The arena had several amenities. It's a very luxurious arena. I actually didn't go to the first part of the bubble. I was scheduled to go later if they advanced. Dr. Suiteo went and subbed in to the first part and did a great job. So dealing with injuries in the bubbles, they did have a medical staff, a local medical staff. The teams were also encouraged to send a team doctor, and on-site medical staff included primary care, orthopedics, chiropractic, emergency doctors, dental and eye, not in the bubble, x-ray in the bubble, MRI outside the bubble. And that means for an MRI, they would have to close down and scrub the MRI suite prior to the player coming. And there are remote virtual examinations with which I was part of several times. So overall success, there was 33,174 PCR tests, a cost of 90 million, no interruptions in play. So it was tremendously successful, and a Stanley Cup was awarded. The downside was, of course, the cost, the social isolation, the lack of fan interaction, and it's probably not sustainable for a regular season. But the NHL overall did a wonderful job. So they're still planning for 2021 with a January start date at the earliest. A repeat of the bubble is unlikely for regular season, and the possibilities include an NFL model where there's some fans allowed in a safe manner. It's yet to be determined, or if there's a phase-in as the vaccine becomes available. Special thanks to all these individuals who helped myself and the team set up the bubble in Winnipeg, or the training part of phase 2 and 3. And special credit to the NHL medical director, Winnie Moise, who did a masterful job. Thank you.
Oh, thanks. Thanks, Peter.
Special thanks to all these individuals who
Okay.
helped.
So Peter, yeah, there we go. So we just want to move on to our next speaker, Dr. Joan Embry. And so she's going to talk about pediatrics, considering she's a pediatrician and a specialist in PEDS ID here at U of M. And her title is Children Aren't Little Adults.
Hi, you can hear me okay?
Yeah, all
Right.
good. Thanks.
Thank you very much. I always enjoy coming to Bug Day, and I'm always honored to be asked to be a speaker. So I am a pediatrician, so I'm going to talk about children today. And all right, so basically speaking, I don't have any financial or other disclosures. And I did change the objective slightly because I'm going to talk a bit about why neonates and children seem to be affected less frequently than adults with this disease, which is good for us, and talk a bit about the acute inflammatory syndrome that has been described in children. And I realized when I was preparing for this that I really do need to let people understand the issues related to infection prevention and control measures in hospitalized infants and children, because they are different than in adults. Maybe not different, but we handle it differently. So at any rate, it's been well known that children are not as affected by COVID-19. And it's not that children can't have viral infections. This is what happens in Canada. These are hospitalized children with influenza attributed, RSV, our usual virus, and other respiratory viral infections. And as you can see, children under the age of 2 are usually highly affected by this, and then 2 to 4, and then older people over 65. just getting a little more personal these days. This is hospitalization rates, but in actual fact, disease prevalence in the community equals this as well. However, COVID-19 has been different. The number of children that have been identified as being positive, this is in Winnipeg 2 days ago, as you can see on this, is a completely different pattern. The majority of people who are affected are 20 to 30 to 40-year-olds, with some children being affected, 0 to 9, and 9 and 10 to 19. If you look at hospitalization rates across Canada and in the United States, children really only account for about 2% of the hospitalizations in both countries. Canada may be a little bit higher according to CNIST or earlier on, although that hasn't changed. So not only do they have fewer children get diseases, but they also don't need hospitalization quite as much. They need some, but not as much as we're seeing in the older adults. So the question is, what is it about children that do this? Early on in the epidemic, if you remember, the first areas that were adversely affected significantly were China. And China, with their one-child policy, actually has an unusual population distribution, and so that there are way more older people than would be seen in North America. So the question then was that an issue of exposure? Equally, the very first area in Italy that had the awful epidemic, their population were more elderly people in that community. So again, were children getting exposed? What happened early on in the epidemic across the world is that schools were closed, kids were home, they were quarantining. And so that's where that was one question very early on. Well, one thing the United States did do for us is the fact that in their policy being somewhat more open, is that they have exposed a large number of children to COVID-19 over the summer and into the fall. And they are seeing more and more children infected with the virus, but still considerably less than adults. So that it has held true in the United States that they are not as much of a problem. The other thing is that not all children are created equal, and that children less than 10 have not been found to be major drivers of transmission in schools. So something seems to happen at puberty. In households, they were not the major transmitters, even in China, in Italy, and in North America. And as you can think back on the schools when they opened up here in Manitoba, it was more the high schools that we had some problems with early on as opposed to the younger children, and I'm hoping that's going to stay true. The other thing about children is that when they do get sick, a lot of them were asymptomatic initially and picked up as investigations in households to see who else was infected, and the children were not that ill. And as we look at the larger number of children that have been identified with COVID-19, again, the children are much less likely to be severely ill. They do, however, present with fever a lot of the times. Fever is not necessarily 40 degrees centigrade. It's 38 to 39. So for children, believe it or not, that's actually a low-grade fever. Half present with cough, but most of them don't have a great deal of problems with respiratory distress. What is more common in these patients as opposed to adults is the presentation with abdominal pain and diarrhea, and a few have been admitted to hospital with query appendicitis, worried about that. There will be pneumonias requiring hospitalization, but they're rare. The more severely ill children are ones associated with underlying disease and severe congenital problems, severe neurologic disease, severe problems with GI disease tend to be what we see. They can have all the other symptoms that adults have, although finding out whether or not a 2-year-old is having difficulty because they can't taste anything or smell anything is a little bit difficult. But they can have a lot of the other symptoms. They don't tend to have the extreme fatigue, though, that you find in older people. Children the age of 10 and above tend to have essentially the same disease pattern as young adults. So there's a difference at about that time period with puberty. So a question is why? COVID-19 is similar to MERS, the Mediterranean coronavirus, in that MERS children are not affected very often with that either. And the major reservoir for that is camels, and children certainly have a lot of exposures to camels in the Middle East, but yet they don't get sick. So it's a different receptor for MERS. But the ACE receptor is the route by which the virus enters cells. And as it turns out, the receptor expression in children is somewhat suppressed. It develops over time, and by the time you reach puberty, you've got the same expression as you do in adults. So this is probably one of the major reasons why children aren't getting as infected. It's there, but it's at a smaller level. Talking to Jared Bullard, what he does tell me, though, is that when infected, the children tend to have the same PCR cycle times as adults. And a low cycle time, i.e. if you can pick it up earlier on as you're doing PCR, does indicate that there's more virus around. So they are obviously able to produce it, but the question is, why aren't they transmitting it the way they do for influenza? Now, I don't know if this is a situation or not, but in thinking through it, it doesn't make a lot of sense that the virus would change except for one itty bitty little thing. And that is, this is an enveloped virus, and the life cycle of enveloped viruses are that when they infect a cell, they enter the cell and they dissolve their membrane, they get replicated. But when they exit the cell as a new virus, they take part of the host membrane with it. So one thing that may be going on is that there may be something different in the host membrane that the virus picks up that makes it less infectious. Maybe, maybe not, or maybe it's just a fluke in testing. It's difficult to know, but there may be something going on with the virus passages through children that might make it less infectious, and be interesting to look into that. Neonates are an interesting group of patients. You have a mother and you have an infant, and certainly we've had a number of mothers who have acquired COVID-19 and have delivered their infants. It was a major problem in New York, for instance. So how does a neonate acquire COVID-19? Well, there's only so many ways. There's in utero, where you have placental transfer so that the placenta gets infected, or there's bloodborne transmission across the placenta. Interestingly enough, there's a lot of ACE2 receptors on the outside maternal side of the placenta, and studies that have been done have found COVID-19 there, so that it certainly is around. During labor and delivery, there'd be contamination by the maternal genital urinary tract or GI flora. There's not been COVID-19 really identified in cervical or vaginal secretions. However, clearly you can find it in the GI tract, and sewage surveys are done to determine whether or not there's a high prevalence in the area. So that's a possible source for a child. There is the possibility of exposure through maternal respiratory secretions as a mother cuddles her child and gets to know her child. And there's a possibility of exposure through breast milk, although it hasn't been isolated that easily from breast milk. And there is no difference in the number of children that were postnatally acquired COVID-19, potentially from their mothers, breastfeeding versus non-breastfeeding. And then the other possibility for an infant to get it is from dad or from other visitors, other kids in the family, grandparents, etc. Or, and we hope not, exposures from infected healthcare workers. The congenital infection is rare, and there's still a fair amount of controversy about its occurrence. It takes a lot to prove that. You have to show that the baby has COVID-19 at birth, so you need to have been doing the testing at that point. Perinatal infection is also rare. In the studies that have been done and the surveys have been done, maximum is maybe 10%, but even then the testing of the infants, the CT values were on a number of the infants quite high, which made people wonder whether or not it was contamination or was it true infection, but it does occur. And we've proven that in Manitoba. The infection prevention and control procedures should reduce the risk of hospital and community acquired infection, and I'll talk about that a little bit later. So,
Joanne, there's 10 minutes.
Okay.
I'm sorry, 5 minutes.
All right, thank you. I'm thinking, well, man, he's stopping me early. At any rate, what in for us in pediatrics, I'm sitting back going, great, this is really not too bad. We are not going to have to worry as much about this, other than the fact we have to be careful for ourselves and for our families, for people acquiring it from children who aren't that sick. But in the United Kingdom, and then again in New York, what was found is there was a very distinct inflammatory syndrome seen amongst children and associated with wave 1 of COVID-19. It wasn't necessarily associated with acute COVID-19 illness. It tended to occur 3 to 6 weeks afterwards. And it was similar but not identical to a syndrome we see in children called Kawasaki's disease. Although, if you did the strict criteria, depending on the source, a number of them would have met the diagnosis for Kawasaki disease. And so these kids were found with fevers, which lasted several days. They had conjunctivitis, they had mucous membrane involvement, they had odd rashes. They had some lymphadenopathy, but what was really more frightening about it is that these children had some CNS disease, they had hypotension and shock, they had cardiovascular disease, severe abdominal pain, vomiting and diarrhea. And it was in an older group of children. Kawasaki's disease tends to be in younger children, and there's a predisposition if you're Asian descent. These children were older, and very few Asian children, and this was not described in the early epidemic in China. One thing that does distinguish it slightly from Kawasaki disease is that there's thrombocytopenia versus thrombocytosis, which is the hallmark of Kawasaki's disease. And as you can see here, there are a number of abnormalities that you see. So it is a multi-system disease. What it isn't is a respiratory disease. And so there's very few children have pneumonia on x-ray with this. This is a post COVID-19 phenomenon, probably related to the immune response to the disease. So there is a national surveillance for it because it is relatively rare. And if we see this, Manitoba is taking part in this, and this gives you an idea of what the criteria are. So going on a little bit for infection control, the no visitor policy for red and orange, i.e. people who have COVID-19 or are suspected to have COVID-19, isn't viable for children. It's just not going to work. So the compromise is that we allow one parent or care provider who gets admitted with the child, rooms in with the child during the time the child is in hospital and can't leave. If there's a bathroom in the room, the parent uses that. Food is supplied. I have found out a number of people smoke, and the I'll kill for a smoke puts on a completely different risk assessment to when you say no to a parent. And the assumption is that this is a household member and so therefore exposed and potentially infected. So the PPE that the room-in parent has depends on whether or not they've been exposed before or infected. For orange, enhanced precautions end, because this is a stress on parents, no way of getting around it. If we don't find an epidemiological link, i.e. there's no contact with anybody else, and we do find an alternative diagnosis, fevers being quite common, then we will take them from orange to green. We don't always wait for a negative COVID test, but if we have it, that's reassuring. On the other hand, if there's an epi-link, or there's a concern, we will keep them in 14 days after the last potential exposure, no matter if there's a negative test at the time we see them or not. For children who are red, we've followed the same precautions that the adults have done, which is 10 days after the onset of illness in a child, or if the parent gets sick after the child and is still with the kid, 10 days after the last person has been developed symptoms, and 3 days resolution of major symptoms, so that we follow the same guidelines. For newborns, healthy infants born to red and orange mums, and there's been a lot of them, they will room in with the mother. They are separated by 6 feet in the bassinet for routine care. There is some indication that if you separate parents, then it decreases the risk to the infant, but this is the compromise we do. Mom and infant are handled with enhanced precautions. Their mom's allowed contact. breastfeeding is allowed with hand hygiene and the mom is masked. If the mom is cleared to green, restrictions are removed. But if mom was red, mom and infant self-isolate when home for 14 days after the birth. That guideline is based on best guess rather than any particular data. Infants in the NICU who are red or orange moms, if the moms change the green, restrictions are removed. Otherwise, we keep enhanced precautions for 14 days if the infant is not infected at birth. If the infant is infected at birth, then we will do enhanced precautions, and the duration of that's on a case-by-case basis, because we have an infant in the NICU, a lot of times they're premature, and we're really not sure how long they would be risk to the healthcare staff. And also, infants in the NICU, generally speaking, are intubated with a leak so that there is aerosolization in the room, or they're used CPAP, and again, those are highly aerosolizing procedures, so we tend to be cautious. Unfortunately, with the NICUs, visiting is difficult. The NICU at Health Sciences Center, technically a mom could room in with her child and be treated the same way as in the general wards, but most parents can't do that. And that does mean problems with visitation. We will work with parents for compassionate arrangements, but it's going to be on a case-by-case basis. Testing of infants. We will check infants if we know mom is positive for the possibility of congenital infection by testing as soon as possible after birth. We don't have a routine for follow-up testing, but we may change that after our first patient. But we would do repeat testing if the initial test is positive or if the infant develops signs and symptoms, because that's important to us for infection prevention and control. And I think I finished on time. I have a campaign for people to respect using the masks appropriately, and this is my little symbol. Thank you very much.
Thanks, Joan. I'll have to spread this image around a little bit, eh? Okay, all right, so moving straight along. We now have a dynamic duo. We have Taslim Savji and Jason Gotu, and they're from Analysis Works, and they are essentially, how can I put it, hospital consultants, and they do a lot of analytics where they help hospitals achieve operational efficiencies, and so they're going to their talk is called Ready, Set, Go, Operational Readiness in a Time of Uncertainty. Okay, thank you, you two.
Great, thanks very much for the intro. Can everyone hear me okay?
Yep.
Okay, thanks for that. I'll just take this opportunity to say thank you for the invite. We appreciate having the opportunity to share a fairly substantial piece of work that we did with the Health Sciences Center in the time of COVID and post-COVID. The objective of what we wanted to share with you is just, as John described, we are a company that helps healthcare organizations drive change with analytics. And so you can appreciate that there are a lot of very interesting questions and puzzles that needed to be solved during this ramp up and recovery period. So we'll just share at a very high level how we approach that and some of the big lessons learned from carrying out all of that work that hopefully other people will be able to take away from it. One of the great things that we have as consultants is we're able to support clients across the country with very similar issues, and then look for those commonalities, but also look for the local nuances. And so we had done a lot of this work out here in BC, in Alberta, had done some work in Ontario, but the Manitoba approach was different in that The numbers were relatively low compared to Ontario, but the vigilance was very high, and the desire to be ahead of the curve and proactive was very high, which was very interesting, and again, just a bit of a unique situation. This is just a bit of a visualization of what healthcare capacity looks like, and so in normal times, where we have a healthcare system that basically runs at capacity. I'm sure that many of you are abundantly aware of that. There are aspects of it that run above capacity, routinely run above capacity. Depending on who you might talk to, some would argue that there should be some wiggle room in the healthcare system for unexpected things, just unexpected day-to-day, week-to-week variation. Certainly not, once in a lifetime pandemic. But typically, in a normal pre-COVID situation, in a better kind of situation, we would have some of that wiggle room for just day-to-day, week-to-week variation. But when COVID came along, there are things that you can't turn off, like who shows up on your doorstep. But so the things that you can control end up being things like elective admissions, scheduled outpatient visits, surgeries. So obviously, Winnipeg, just like every other organization or every other metropolis in the country, focus on what they could control. And so non-urgent elective surgeries were some of the first things to be put on pause. And then we get into this period of this cautious reopening of services while maintaining a reserve capacity for medicine. And so the challenge here is that a big chunk of this original capacity has already been eaten up by this demand that we had never seen before. So the amount of wiggle room that is actually present to accommodate the ramp up is actually relatively small. So it was very much a cautious reopening of services, and a graduated one at that. While being vigilant and looking out for the wave 2 and the resurgence of the case volumes. Ultimately, the long-term goal is, how do we get things back on track? How do we get caught up again with this kind of lost ground here? What happened to those patients? Did they could some of them wait for access to care, or for some of them, did the disease pass, and so that demand isn't waiting for us when we reopen again? So we had a number of questions that we were asked to help support. Most of them were around the idea of, well, how long is it going to take to recover, to go from all the way from one end of that timeline to the other end? And what are the kind of the linchpin services from a hospitalization perspective that are really driving things? And if we do want to catch up, what are the resources that we're going to need to do that? And what's our rate limiting step here? So we do a lot of this modeling and capacity modeling to try to assess how much space do you need, be it beds or OR time or people or what have you. And the thing about modeling is that it's kind of like as a map is to the reality. A model is just a representation of the real world. It's not the real world, and it can only do so much in terms of capturing the real world. And therefore, it can only do so much in terms of its predictive ability and planning. But there's a lot that you can do if you really focus on the fundamental few factors that really do have the bigger leverage. So I'll just show you some of the visuals that we had been looking at back in the day. This shows our normal run rate of surgeries performed at Health Sciences Center. And you can see, like, one of the things that I would notice about this is that there's a normal ebb and flow, right? So there's a busy period of the spring, there's the summer slowdown period, which we see happen across the country for surgery. We have this kind of catch-up period that normally would happen in a fall period, a Christmas slowdown, and then and then typically a busy spring. So it's important to know that. It's important to know that there's normal variation that happens that is part of our normal business. But what's also interesting is if you look at the colors, the orange would represent the cases that are coming in through the emerge. These are unscheduled surgeries that are coming in that obviously show up and they need to be done. And you can see that there's some ebbs and flows, but not as much as the schedule components. So the inpatient and the outpatient schedule components, which are these two layers, which are the ones that tend to flex down and flex up as is needed for capacity planning. So then we get into this period here, which is March, and we had a pretty busy March in the grand scheme of things, considering that we had half of a productive month. But you can see that there was a very big impact, an immediate impact on access to care for surgical cases. And even for unscheduled cases. So for that 1 month, it actually did impact, beyond what we would normally expect to see for the presentations through the emerge. And absolutely, we can see there's strong evidence that there was a big restriction of access to care. And so the puzzle becomes at that time, so how is this going to ramp up? What is our ramp up plan looking like? And how long is it going to take? If we missed out on these number of cases that we were kind of expecting to see, how long is it going to take to get caught back up? And this is just one of many kind of scenario models, but in Manitoba, as well as with our other clients across the country, many were asking the question, so what do we need to do to get caught up? Because if we left it at normal capacity, like we were talking about, like in some situations, 18 months to 2 years to get caught up just from this one blip, right? And so the question then becomes, well, what more can we do to try to get ahead here?
Jason,
so
3 minutes.
Thank you. I'll move to wrap up here. But there's kind of four big takeaways from a math modeling perspective that I just wanted to share with you. So number one is when a system is already running right at capacity, a temporary disruption has a long impact. So think of it like household debt. If you are just keeping up with your bills, but then you go for 6 months without any income, it's really hard to catch up. And that's one kind of big aha of this modeling work. There's a lot of data that we absolutely needed for planning and decision making, but it's not normally tracked. So we needed to be creative and resourceful about getting that data that we needed. And some of that involved manual tracking, doing some samples and what have you, using cloud solutions. The third kind of takeaway is that when you're modeling, a model doesn't have to include everything in order to still be useful. So the art of modeling involves that balancing act of capturing detail versus usefulness. And a common mistake is that making a model more complicated makes it more accurate, which is actually often the opposite. And the closing kind of key finding here is that in our healthcare system, we have many interdependencies, but often there's only one or two rate limiting steps. So it's really important to zoom in on what are those rate limiting steps and to just model that. And then once you've cleared that factor, then you can move on to the next one. So I'll wrap up there, and thank you again for the opportunity to share this work here.
Oh, thanks, Jason. I'm sure there'll be questions, so please hang around for a little bit. And there we go. Okay, well, thanks to all the speakers so far. I'll just go back to Slido here, and so we'll go back to Peter. And it looks like, yeah, there's definitely some questions. I mean, so the first one was testing for COVID by private or public funds, and because obviously thinking of the burden of on the labs and the resources already stretched. And then I think the second question is actually well linked into that, because you had mentioned something about the costs. So who actually covered the costs for all that testing as well?
Yeah, I kind of knew that question would be coming. And actually it was in the media, and Dr. Rusin kind of addressed it. That was during the time period, as you recall, when the burden of COVID was not as great as it is right now in terms of the Manitoba population. So as I put up that slide, the objective was not to impinge on any public access to healthcare. So there was some compensation from the hockey team to allow for some private testing because we had to meet NHL standards in order to go ahead.
Okay. Good. Yeah, good that you anticipated that. All right. And then going over to Joanne, there's two top questions. Which one do you want? I think the Halloween one is probably the one that you know is going to come. So what do you, just nice open question. What do you think about Halloween and kids going out?
Well, I mean, the thing about us in pediatrics is that because we start off from we have to find a way of doing it safely. There's probably several ways of doing this safely. One, limit the areas where you go. And if you've got bubbles, go to the bubbles and get all the candies from your friends, letting them know what you want. The other thing is wearing a mask, washing your hands. The third thing is good luck with this, quarantining the candy for a day or two after you get it so you don't eat it so that you let any contamination go. If you're giving out candies, I really like those chutes that they're using other places. That keeps you at a distance, but I think ways of giving out candies that you're not face-to-face could work out. And you can have some fun with it, I think. But I think the main thing is probably going to be the clustering, that you don't go to a lot of places. I don't think the malls are the place to go to get the candies right now. I think it's keeping it in your own place. Clearly not looking like we're going to have big Halloween parties with everybody dropping in. So I think that's not going to happen this year. But that would be the way you could safely do a Halloween.
Good. I was taking notes. Okay. All right. So going back to Jason and Taslim, so you kind of put it out there that we have to do a catch-up model, but then so how do we prioritize those first patients into that catch-up model?
That's a great question, and definitely one asked by many surgeons. Taslim, would you like to field this one? I did so much talking earlier.
Sure. So prioritization it's a tough one, right? How do we decide who gets to come in first? And so there are a number of different sort of criteria that we use to try and make this fair. So there are ways to look at the data and then, use a consultative approach with surgeons to figure out, if things are life or limb, these are the cases that were happening. They have to happen. And then, moving on to, for example, oncology and cases, that require immediate sort of surgeries, those come through next, because we know that the risk of not doing them is greater than the risk of doing them, in this case, for the patients. One thing I will note, from the work we've done, at HSC, for example, there's been a lot of safety measures to try and make sure that these cases are taken care of in the safest way possible. And then for the remainder cases, as human nature will suggest, we often will feel that our patients are the most important. And it does become a game of looking at the volumes, number one, who has the most cases, and then looking at, the patients and the conditions that they have, and then looking at equality across services as well. So it's a real balancing act, and part of managing this is also, you know, coming up with standard ways of prioritization. So saying, if we look at 4 factors equally across the board, then we're going to be able to assign people accordingly. But it's a tough one, because everyone is a priority, of course, and we want to have everyone seen to, and everyone is going to be fighting for their patients. So coming up with a standardized method is the best way to do it.
Good. All right. And you guys have that all sorted out, hey?
Obviously.
I don't know if we have it all sorted out, but here's another thing. Like when people have been waiting on the sidelines, everyone's got some cases that are at risk. And so once you've cleared the obvious ones, like the oncologies and the time-sensitive ones, then you have to take the Canadian approach and give everyone a little bit, because everyone will have some patients at the top of their list that really need that access to care. And then just how you graduate that expansion becomes the very more difficult Canadian thing to do.
Okay, so going back to Peter, sorry, you're not off the hook yet. So what were the programs in place to support the players for their mental health needs, considering that they had to stay in isolation for so long?
Thanks for the question. It was a long haul, especially for the teams that went all the way to the final. That's over 2 months being in isolation. We have a pretty comprehensive medical support system, both locally and in the bubble. So we have on our consultant staff, psychology and psychiatry as needed. So we're aware that if there were any issues, we could attend to players who are having emotional or mental difficulties requiring support.
Thanks, Peter. Okay, Joanne. So do you think it's better for young children who can't distance be kept away from their grandparents who are higher risk? So basically trying to get that balance between mental health for all those involved versus that risk.
Oh,
tough question, eh?
Right. No, it's tough in one way. Mainly, I think that if you can get your family together in a bubble and you have very minimal contacts outside of the bubble, because you conveniently said young children, that provided you as a network have not had anybody from the outside, then I think being able to hug your grandkids is a major thing that you're able to do. On the other hand, it's a little more difficult if you're one of the families where there's kids in a whole bunch of different age groups and they all have their own bubbles. And so then all of a sudden your family has contacts with 100 people. That's going to be a lot more difficult to get close and comfortable with your grandparents. Then you may need to be a little bit more circumspect about that, and pick special times, and before that time everybody self-isolates. So it also depends on the background prevalence. Right now, much more of a dangerous time to be trying to do that. In the summertime, it would probably be relatively safe. So that's the best answer I can give you. Every family has to work it out for themselves. But without a doubt, as a pediatrician, we look after the care of children and the fact we're aware that we can't isolate them. As a daughter of a 95-year-old, I'm very aware of the isolation for parents. And so that I think we need to do the best we can to give them the best life as well.
Right. Very tough to always find that best solution though, yeah. Okay. So, Jason, this is kind of a loaded question, but So do you think it's possible, or is it possible in the Manitoba / Canadian healthcare system to not actually run constantly at that 90 to 100% capacity, or
That's
100% plus?
Thanks for the question. That is a tough one. I think the way things are structured right now politically, I think it's unlikely to change anytime soon in Canada. It's a depressing thought. But as we all know, healthcare is a big part of where our taxes go. And it's very difficult. That there are ways in which our healthcare system has been designed where the incentives just continually result in it always being filled up to the maximum. There's only been one province that I ever saw that got to the bottom of their surgical wait list. And that's not medicine. That's just surgery. And it was the province of Saskatchewan. What it takes is an absolute mandate, like an absolute vision from the top. We're going to make this happen. It requires a longer term commitment than just 1 year or just a couple of years, which they made. It involves a real investment. And if you put those ingredients together, then the healthcare system can respond and actually start getting to the, to the bottom of their wait list. But there's no nirvana in that they lost it again. So they got to the bottom of their wait list, and then something politically changed, and then access to care suddenly wasn't the most important political thing. So I really do think that we as citizens would need to vote differently if we ever wanted things to change, unfortunately.
Okay. Well, that's a bold statement. But, yeah. Okay. So I'll move right on. Okay, so Peter, I think you're off the hook here, and there's quite a few left for Joanne. So I actually want to move on to those. There's some clinical questions here. Can you give us the process that is going on whereby these kids are getting blood clots?
Sorry? I actually don't know why that's happening.
Okay. And I'll throw another one straight at you, sorry. So how common is inflammatory disease here in Manitoba? So we've seen quite a few cases.
Basically speaking, to date, we have not seen this particular syndrome in Manitoba related to COVID. We've been looking for it. We see Kawasaki's disease. We actually went back and looked. We see about 20 to 25 cases a year, and they come in weird clusters. So we have seen that. So we've been monitoring all the Kawasaki's diseases to make sure that we don't have any connection there. But no, we have not seen this yet, and I don't really want to see it either.
Mm-hmm. Okay, so I'm cognizant of all. Yeah, we've got time for probably 2 questions. So going back to Taslim, so what's the most common rate limiting steps you discovered in the healthcare model? As soon as you had brought that up.
Yeah, so capacity is probably one of the key areas. So, and by that I mean staff. So when we're thinking about ramping up, not only do we need OR space, but we need people to staff those safely and effectively. And not only that, but during the COVID-19 period, we know people were suffering from burnout. There's also, the psychological part of all of this. And that was kind of a key factor that we needed to consider, because if you don't have your people and they're not motivated to support on that, then you're going to get into a little bit of trouble. So we can suggest 15% increase in capacity. We can suggest 5%, but it's the people that are really going to make the difference. We can open up 10 ORs, across all the sites. That's fine. But that would be the key area for us.
Okay, yeah, and I think that was one of the statements early on today. We can have lots more ventilators, but we have to have people. So people are our most important commodity. Yeah. So, okay, well, and one last question for Joanne. Sorry, you don't get away that easy. But this is for your study potentially, so it's important. So do you test infants in the mother, if the mother was positive during any point of a pregnancy, or if she was only currently positive with symptoms just around delivery?
Okay, I think a pregnant woman would be treated exactly the same way as a non-pregnant woman if she had come in contact with COVID-19 and had symptoms, and so would be tested any time during her pregnancy. There was a period of time where they were looking for asymptomatic carriage, and so there was about a 2.5 month period where everybody who came in to deliver was offered testing, even though they were asymptomatic. And that actually had some backup, because in New York, when they had their epidemic in the first wave, 50% of pregnant women who were found to have COVID-19 at delivery became febrile afterwards, but were asymptomatic when they presented and were positive at that point. So that's where the testing comes with pregnant women. Right now, we are in a situation where if there's a clinical indication or a risk factor, then a pregnant woman would get tested when she presented in labor. So we're still at that point. We're not testing everybody at the moment. That could change, but that's where we stand right now.
Okay. Well, thanks very much, Joanne, and thanks very much to all our other speakers. Very thought-provoking, pretty diverse opinions and pieces of information there, but all part of filling in the gaps there. So thanks very much. So
great, thank you.
We will move straight on to our next 3 speakers. So no break quite yet. 1 more hour, just hang in there. So I want to move straight on to Dr. Dwayne Funk. So he's an anesthetist and intensivist here at the U of M in the teaching hospitals, and he's going to talk about the pandemic. What were those missed steps? Okay, Dwayne, over to you.
Okay, thanks, Richard. Here we go. Everyone can see my screen okay, hopefully?
Yeah,
okay.
All looking good, and we can hear you fine.
Perfect. Okay, here we go. So who am I? As Richard said, so I'm an associate professor at the U of M. I work both in the OR and the ICU at Health Science Center. Just finished up my Master of Science degree in clinical trials epidemiology. I've done some consulting work for the National Micro Lab with some Ebola experiments from an ICU capacity, and I'm the med lead for the Department of Anesthesia COVID-19 response team. So that's why I get to talk today. And I talk fast. So there's lots to come up with. So here we go. A couple of things, very big events in my life: getting married, birth of my kids, getting to play basketball at Duke University, a fantasy basketball camp, meeting Coach K, and now Bug Day. This is one of the highlights of my career so far at the U of M. So happy to be here and speak to you guys about some of the missteps. We're going to talk about some of the paradoxes that happened with COVID-19 and some of the information surrounding COVID-19. And then we'll talk about the medical response and how different healthcare systems fumbled along the way, and how actually we did really well here in Manitoba, not wanting to brag, but we did. And here we go. So the first thing is that we thought this never happened before. If you look at coronaviruses, they're large family viruses. The beta coronaviruses, the ones here in pink, they're responsible for a lot of diseases in mammals. So we're talking bats, camels, pigs, cattle, and humans. There's been several times when the disease has jumped from animals to humans. And if you look back in the late 1800s, there was this worldwide outbreak of bovine pneumonia. There were millions of animals that were culled to stop the spread of this disease. And if we look back at it, this is actually probably due to a coronavirus called OC43. Now, at the end of this cull, a few months later, all of a sudden this influenza, quote unquote, epidemic starts in Russia, spreads across the entire world, kills 1 million people. Well, as you probably know, it's very difficult to distinguish influenza or the flu from coronavirus infection. if you look at genetic studies, we can actually trace the origin of this OC43 bovine coronavirus all the way back to this epidemic. And this is probably our first recorded coronavirus pandemic that happened over 150 odd years ago now. Fast forward to 2001, there's a new coronavirus. We called it SARS-CoV-1, linked to wet markets in China. It was actually started off by this little guy here called a civet cat, made the jump into humans. This virus traveled all the way across the world, made it to Toronto, caused about 770 deaths, and had a case fatality rate of 1% to 2%. Years after that, the virus jumps again, a different coronavirus, from camels into humans. We called it MERS, Middle Eastern Respiratory Syndrome, had a case fatality rate of about 20 or 30%, so really high. And so, like I said, animals are natural hosts for coronaviruses. Bats are a significant source of the coronavirus genetic diversity, and they're a very significant host for this disease. When you have two different animals who are housed close together and who are potentially stressed, then these viruses can combine together and form recombinants. And so these recombinants create brand new viruses. And this new virus often has changes in this thing called the spike protein here. And this is the protein that allows virus to enter the cell. This is basically a little genetic fingerprint of the proteins that make up the spike protein in different animal viruses. And you can see there's a lot of color coding similarities here, but there are some subtle differences. These subtle differences are the new viruses that allow the jump from animals into potentially humans that can cause these significant pandemics that we've seen in the past. Okay, a lot of paradoxes with COVID-19. The first one is that COVID is really contagious, but it's actually not that contagious. And it sort of depends on how you define contagiousness. So two things we look at to define contagious: R naught, secondary attack rate. Dr. Rusin talked briefly about R naught. R naught is basically the number of people who, on average, one case goes on to infect. And so to calculate R naught, you basically take the number of contacts you have, you multiply it by the transmissibility of the virus, and multiply by the duration of infection, and you get a number. As you heard, R naught for COVID is around 2. That compares with HIV, influenza, Ebola virus, and the first SARS virus that we had. So it's on the lower end of contagiousness, especially when you compare it to things like chickenpox and measles, where it's got an R naught value of 10 to 12. So again, with COVID, on average, you go on to infect 2 subsequent people. Chickenpox, measles, you're looking at 10, 12, 18 people. So COVID's not that contagious when you look at R naught values. Second value you look at is for looking at contagiousness is secondary attack rate, or the SAR. So that's the number of new cases amongst contacts that you've had divided by the total of contacts you made contact with. And we use this again to determine how contagious it is. Here's an example. If you get influenza, you will pass along, the secondary attack rate for influenza is 40%. So you'll pass along influenza to around 40% of secondary contacts. So 4 to 10 people. Ebola virus, 20% of people, so a lot less than influenza. And if you look at chickenpox, chickenpox has a 90% secondary attack rate. It's an airborne virus, so if you get chickenpox, you will transmit it very readily to a susceptible population. COVID-19, secondary attack rate in close contacts of 15%. So not that high, and lower than a whole lot of other viruses that you may have heard of. The other weird thing about COVID-19 is that 20% of the primary cases are responsible for 80% of the secondary cases. We saw this with SARS-1, and it's a property that's not common with other viruses. So if you look here, this is a graph of percentage of cases that go on to transmit to 0 people, 1, 2, 3, 4, etc. So you can see the vast majority of people that get COVID do not go on to transmit it to a second or third or fourth person. But you do have this small group of about 20% of people that are responsible for 80% of cases. And this is data from Hong Kong. We saw the exact same thing in India. And so these are the super spreaders that you hear about. You know, one person, wrong place, wrong time, will go on to give this virus to a lot of people. But the vast majority of these cases don't go on to propagate secondary cases. So that's the paradox of contagiousness. It's not very transmissible, but the problem is we have numerous contacts with people every single day. If you look at the data from Manitoba and the contact tracing people, that's the Manitoba Provincial Health Epi people, they have to look at a median of 6 contacts for every positive case. And that number can reach a maximum of 44 contacts for each COVID case. Now you think about the 80 to 100 cases we've been getting the last couple of days, these people have to track down anywhere between 600 and a couple of thousand people to figure out who these secondary contacts are and tell these people to isolate. So it's a significant workload. But that's why the virus seems very contagious. It's because we have a lot of contacts in our life. Second paradox, it's really deadly, but it's actually not that deadly. And when we talk about deadly, one of the things that we look at is something called the case fatality rate and the infection fatality rate. Case fatality rate, you take the number of deaths divided by the number of cases. The problem with that number is it's artificially elevated. If you look at something that's more important, that's your infection fatality rate, number of deaths divided by number of infections. We underestimate the number of true infections in our population by anywhere from a factor of 6 to 14. So every year a death rate from COVID, you take that number and you divide it by anywhere from 6 to 14, and you'll probably get your true death rate. And again, this is entirely because we underestimate the number of true infections because a lot of people are asymptomatic with this. The recent CDC, World Health Organization estimates say that about 0.6% is the mortality rate for COVID-19. And you think about it, that's actually pretty good. That means 99.4% of people who get COVID are going to survive. And you think, well, wait a second, why don't we just let this thing rip, meet it head on, let it burn through the population? Well, the problem is 0.6% of Canada is over 200,000 people that would die if you let this thing run its course. And of course, higher your population, higher numbers of fatalities with this. So while it's not that deadly a virus, we're all susceptible to it, and 0.6% of our population is a pretty big number. You've also heard it's a bad flu, but it's not really a bad flu. Well, it turns out that when you look at the under 60 crowd, in terms of fatality of COVID-19 versus influenza, yeah, it's actually not that much different when you look at influenza fatality rates overall. However, once you get to this over 65 crowd, or if you have medical comorbidities, this virus is very serious and it is way worse than seasonal influenza. So it's a bad disease depending on who you are and how old you are. Okay, what did we do wrong then as a medical establishment when this disease first hit the world? A lot of things. The initial medical response to COVID, this is, basically the piglet response, panic, worry, catastrophe. And I'm going to pick on a few countries here because this is what really caused some problems throughout the entire world with this initial response. We admitted everybody. People wore a lot of PPE that was probably unnecessary. We intubated people early and put them on ventilators in the ICU. And we didn't send them home until they had a negative COVID test. Okay, the first problem, admit everybody.
Dwayne?
Yes?
3 minutes.
3 minutes. Okay, we admitted everybody. This was done to spread the curve of the disease. You can see here, this is a field hospital in Spain. Lots of people got admitted. They weren't on intravenous's. They weren't on oxygen. That resulted in people getting basically denied hospital care because the hospitals were backed up. These were tents in Central Park. So we admitted every single person here to the hospital when it wasn't necessary. This is an English hospital, the same thing. They didn't admit people that didn't need to be there. They did okay. Their system wasn't overwhelmed. Second thing we did, we wore way too much PPE at the start. So all this extra PPE led to shortages later on when we really needed it. And that wasn't necessary. We didn't do that here in Manitoba, and our PPE stock has remained very robust. The other thing we did that was a really big mistake from the ICU standpoint, the Italians in the New York ICUs intubated everyone if they required more than 5 liters of oxygen. There's about 100 people right now in health science that are on 5 liters of oxygen. If you intubated all of them, we would overwhelm our ICUs within an hour. So that led to a lot of people waiting for ICU that needed to actually be in the ICU, and we intubated all these people unnecessarily. This didn't happen anywhere in Canada. A lot of these Italian and New York City intensive care unit doctors abandoned 20 years of standard and rational practice in the span of 6 weeks, and this caused massive problems and caused a lot of deaths because people waiting for ICU. Another thing that happened at the start, people waited for a negative test before they discharged someone. As you heard, the PCR test that we do can remain positive for a month after infection. So there was a huge backlog of patients waiting in hospitals to be discharged who weren't infectious. Work done here by Jared Bullard and his group in a collaboration with the National Microlab, CADM, and the U of M showed that you're no longer contagious after 10 days after symptoms. This paper that was published recently was used to guide policy at the CDC, World Health, and Public Health England. So we got rid of a lot of people from the hospitals that didn't need to be there. Last thing we did, we locked things down. That was done in an effort to improve our testing capacity, improve our PPE supplies, and improve our hospital capacity. We open things up again, cases come up again. That was bound to happen. We knew that was going to happen. And the problem is these broad lockdowns, if we were to do this again, would save lives. What Dr. Roussen's doing with these targeted lockdowns to target areas that are causing these mini outbreaks that we're having in Manitoba is a lot better than broad lockdowns. As you heard, if we broadly lock things down again and again, you're going to have problems with impact of resource restriction on surgeries, chemotherapy, cancer diagnosis, et cetera, and you're probably going to cause more morbidity and mortality. So broad lockdowns don't work. Targeted lockdowns do. You're actually going to kill more people. This is data from New York showing that there was 2,000 more COVID deaths in the month of March, 2,000 excess deaths in addition to COVID deaths from people not seeking medical care. In Italy, the rate of out-of-hospital cardiac arrests and deaths goes up significantly with broad lockdowns. British Health Service says that 2 extra deaths for every 3 COVID deaths because of all these lockdowns that we did. So we need to focus on targeted lockdowns, and as Dr. Roussin says, focusing on fundamentals to keep ourselves safe and not locking down society. Why are we different? Yes, we locked down early. We improved our supply of PPE and testing and beds. We're geographically isolated, so we actually did pretty good. And we didn't panic. We maintained our usual ICU practice. That's in Manitoba and all across Canada. We maintained normal ICU practice, and that saved lives. We also quickly ramped up to more normal surgical levels to try and keep up with this backlog that was created. So we did pretty good. We've got a good ability to test, trace, and isolate. Finally, we have excellent leadership in Manitoba. We have great coordination between the National Microlab, CADM Lab, the hospitals. We have great infection prevention and control people with John Emble and Molly Blake. The Manitoba Modeling Group that models this disease has done a fantastic job of predicting where we're going to be. Aaron Nelson, who's procuring PPE for us, our contact tracing people are excellent. And finally, last minute shout out, Perry Gray, who's the Shared Health CMO. Most of you never heard of him. He has been the lead at managing the COVID response in the province of Manitoba. I can't say enough amazing things about what Perry's done to shepherd us through this crisis. I know I talked really fast and had a lot of slides, but thanks for your time and appreciate the opportunity to speak at Bug Day.
Excellent. Thanks, Dwayne. I'll slow things down a little bit now. Okay. All right. So we've talked about something nice and big picture there, and another big picture topic now. We're going to talk about COVID-19 and the economy and what lies ahead. So we are honored today to have Dr. Michael Benrock from the U of M. So Michael's an economist, but I think probably more importantly, he's actually currently the president and vice chancellor of the University of Manitoba. And so we really look forward to hearing what you have to say, Michael.
Thank you. And I hope everybody can see me and has the screen up here. So wonderful to be here. And I appreciated Dwayne, your presentation. So some of this will feed quite into that. So as you were just told, I'm an economist by trade, and so I'm happy to come and talk about economic outcomes. So as you know, COVID hit very, very hard, and the economic impacts started on the economy really early, and they hit in March 2020. In the first wave were lots of closures and shutdowns, unemployment rose, and in response to that, governments started spending money. From an economic and business standpoint, what we saw is that supply chains were very disrupted. Movement of goods, production of goods, how to get products. We all know about lack of toilet paper, but that's been followed by, lack of bicycles, lack of workout equipment. I think, and other products that you just can't get, and so real disruption. And very much like COVID, the disease itself, there's still a lot of uncertainty around the economy and how the pandemic is affecting it. And now that we go through a second wave, if that's what it is, again, a real impact. The Economist magazine spoke about the disappearance of 10% of our economy. And in fact, it's what we've seen. And so what we saw is that the global economy contracted significantly, and it's both true globally on average, but it's true across countries. It's kind of hit across all countries. And what we really observed at the beginning was that that this happened across countries. Household spending declined really significantly at first. You should all check your Visa, MasterCard's bills in March and April. There was a huge decline as everybody stopped spending, and then people started to spend again. And the real hard hit sectors have been services. And hours of work have declined across the economy, and corporate investment has really slowed down. And initially, manufacturing output stopped. And so how did the government respond to all of this? So first and foremost, through their policy tools. And government really has two policy tools. Fiscal policy, which is government spending, and monetary policy, which traditionally was interest rates policy. And so the governments came in and they lowered interest rates. Even though they were low, they've lowered interest rates again to historically low levels, near zero in most countries. But something they learned through the last economic crisis, which was the 2008 housing bubble, were the purchases of assets from corporations, from banks, from financial institutions that were failing, the purchase of bonds to put liquidity into the market so that you can get cash flowing through the market. And so they've come in there and they've done this again. And that's really helped financial markets. And so what you've seen is that cash flows back into the stock markets and they start to rise. The US Federal Reserve has said that they're going to allow inflation to rise above 2%, which is kind of new because that's been the maximum amount. And what they're basically saying is they're going to let the economy grow. It hasn't risen beyond 2%. And governments are now coming in and also taking on some of corporate debt and giving loans at very low amounts so that corporations and companies can continue to work. We're seeing this around rental support. At the fiscal policy level, they came in and tried to minimize the economic damage and assist in the recovery. So huge expansion in healthcare, but helping people overcome their losses of income. In Canada, we saw CERB and a number of other offers, subsidies of wages, seniors' income, and we've seen a big drop in hours of work. They tried to preserve incomes of private companies by providing them with loans, guarantees, deferment of payments. Some countries guaranteed private debt on a large scale. And OECD, World Bank, and the IMF all encouraged governments to continue to provide fiscal supports and not to go into a state where they try to balance budgets in the short term. And so now we're seeing a second generation as those policies evolve. So just some data that I thought would be interesting to look at. So you see Canada there about in the middle. This is the reduction of gross national product, gross domestic product in the first half of the year. And so you see that Canada there, we declined somewhere around 12%. The global average was just over 10%. But you can see that there's a wide range, but it hit everybody, and it hit everybody significantly. Household spending. So to interpret this first part here, retail sales, the green is the initial drop in the month of April. And so if you look at Canada there, but if you look at all of them, a huge decline of about 30% in Canada in April. And then the arrow and the red ball are what happened in June and July. So when this data came out, Canadian data still wasn't available. But you can see that in June, the blue triangle is in the positive, a complete rebound of the initial drop in spending in April and May to June and July. In Canada, that was a positive rebound. You can see that some countries also positively rebounded. And if you look at where the decreases in sales took place, a good way that we measure that now is to look at Google searches. And so you can see here that by the end of August 2020, events and travel, performance, dining, hotels and accommodation, and sporting events, that's live sporting events, all of those were significantly negative as those sectors were essentially shut down. And then you see home appliances, groceries, health, clothing, still in the positive as we turned our attention to that. Where did government put their support? And this is globally, and I'll come back and talk about Canada. And so the green is the direct support for workers, and healthcare. And so you can see that countries increased their support. Canada, somewhere about in the middle, where they increased around 10%. But what some countries chose to do was really to have guarantees and loans, and that's the orange. And so you can see that a number of the European countries moved in that direction. And then tax deferrals also. So trying to allow for income to continue to flow. These are all measures that we use for fiscal policy. And if you look at the largest sectoral impacts of all of this, again, you're seeing that it's generally negative across the board. But if you look at Canada, which is the orange, you can see that hotels and restaurants and arts and recreation were the sectors that were hit the hardest. And by the way, those continue to be the case today. And so what's happening kind of around the business cycle? The blue line on top, the solid one, that's where we were going pre-COVID. We would have just continued to grow at about 2 or 3 or 4% globally. The red shows you the drop that happened with COVID. So there's your 10% drop. This is on a base. And now we're beginning to recover. And now there's a couple of scenarios, and we're moving more along those green dots now, because with the second wave, it's kind of tempered the recovery that's taken place across the world. I said I would say, thank you. I said I would say something about recessions. So recessions are 2 negative quarters. So here you see in Canada, the 2 quarters, you can see where we were before, the 2 quarters leading to recession, -9 and -13%. The unemployment rate in Canada rising to a high of 13.4 and then falling to 9. And here's that same graph as we just saw before. The big drop in Canada in April, but then May, June, and July beginning to lead to a recovery, but not all the way to where it was. And where is the decline in Canada? Again, you can see that the sectors have declined, turning around in July to be much more positive. Government spending, and here you can see us moving to April, and then suddenly a big jump in government spending across Canada. And so what have we learned from all of this? Obviously that this has had a major impact, that the recoveries were starting, but when the second wave hit, it certainly dampened that recovery. And one of the things that governments become better at while we move through this was to consider the trade-off between economic and health and social factors. And so while in the first wave we had large shutdowns, in the second wave we're seeing less so. Some of the case studies, you had Sweden that didn't shut down that much, but their economy still contracted, and we saw lots of deaths and lots of cases. It kind of coincides with the last presentation. New Zealand, which completely shuts down, but you see -12%, massive GDP decline, so huge economic impact, much less on deaths and cases. And then Taiwan, which has a very different system where they traced, they use people's phones to know where you are, they contact you, minor economic impact. And so once again, what we've learned is there is some need for a balance, and blanket shutdowns are not recommended everywhere. But when they do occur, it's kind of a failure to test widely, to respond rapidly, to extensively contract trace across the country, and a failure to identify those hotspots or super spreading events and to shut those down, which is very similar to what we just heard in the past presentation. So it's been a very negative impact. It's still volatile. The economic future remains uncertain, and it really is tied to getting this disease under control. And I will stop at that point, and we'll return a little later for questions. Thank you.
Well, excellent. Thanks very much. Okay, so we'll move straight on, and then that'll definitely leave lots of time for questions at the end. Okay, so our last speaker just before the break is Sean Shaw. And so he is a lawyer practicing in the area of securities law and regulatory compliance for participants in the Canadian investment industry. So we're really delving into the economics here. And your topic is viruses are everywhere. Cyber security risk management tips from the investment industry.
Thank you very much for the introduction. And as mentioned, I'm here to chat with you about a different virus, those that relate to cybersecurity threats and risks that we all face. We'll chat about the challenges faced by registrants in the Canadian investment industry, as well as share some of the tips that we can take or steps that we can take today to protect ourselves from these types of viruses. So here's our introduction, just a brief background of what cybersecurity is, the what, the who, and the why of cybersecurity, what exactly is social engineering and how important it is to some of these threats, how we can improve our cyber hygiene, which is something that we talk about and hear about every day with respect to COVID in terms of hand washing and social distancing. And then I'll go over some brief takeaways that we can implement in our personal lives to protect ourselves. So I'm talking about a different type of virus, a virus that's really capable of destroying data and having other financial impacts to us. And one of the reasons why I put up this slide is to emphasize that the types of threats that we're talking about and that we see these days, they are sophisticated. I think gone are the days where we're going to receive an email from some individual that we've never heard of, probably royalty in a foreign country, promising us untold wealth. The only thing we have to do is just provide him or her our bank account number. Those types of threats, as funny as they do sound, the prince of some country, what we're now talking about are threats that are very sophisticated. And they're sophisticated because the people who are launching these threats, this is their job, and they're very good at their job. So here's an example of how a Russian national tried to bribe a Tesla employee with a significant amount of money to try and create some cybersecurity issues for Tesla in one of their factories. Now, in terms of this slide, timing really is everything, and the novelty does create opportunity. So here, what we're going to see is that with the change in society, with COVID and the impact of COVID, we do see that these types of threats are adapting to the changing circumstances. So now we're seeing threats that deal with that attack work from home arrangements and so on. And oftentimes, and this is what I do in my professional life, when we are training clients, we train them to identify suspicious emails. And most of these cybersecurity attacks that we will experience as individuals, they start with an email. So training and employee recognition is critical. And what is really scary is that there are firms out there that deal with testing and to see how adept their employees are at spotting these threats. So they will send fake emails, and the failure rates, in other words, the click rates that employees are falling for these scams are extremely high. So it tells us that these types of emails are working. And yesterday, as I was preparing for this, just when we thought it was safe to use video conferencing, now we have to be careful of the links that people are sending us to join meetings. So again, this is the adaptation that we're seeing and the sophistication of these threats. So the Investment Industry Regulatory Organization of Canada, that's the national securities dealer regulator. A couple of years ago, they came out and said, hold on a second, cybersecurity risk is pretty scary. It's critical to the stability. Managing this issue is critical to the stability of our registrants. We think that it could also impact the integrity of capital markets, and really it deals with investor protection issues. So what this tells me is that this type of issue is an existential threat. And the fact that it's relevant to registrants in the Canadian investment industry, it should be no different to us in our personal lives or any other regulated industry, healthcare, pharmaceuticals, and so on. So they came out and said, we really think we need to manage this, and principally because registrants in the industry are going to be in possession of data. They're also going to be in close proximity to currency of clients. So what exactly are we protecting? Well, for a health authority, it's patient data, and we're protecting it from breaches, corruption, and destruction, and really any other piece of critical infrastructure that might or could be used to hold an organization hostage. And really, ultimately, what this points to is the reputation of an organization. Clients are not going to be very happy if they can't trust that the data that we possess or the funds that we possess are not safe. And for us at the personal level, we're really protecting our personal information as well as our financial accounts. and really who are we protecting who are we trying to protect ourselves from? Going through a threat analysis, it will help us understand who we have to be careful of, who we have to worry about. And this will promote and help an organization to develop its cybersecurity initiatives to protect itself. And really, in terms of what the threats are, we're talking about external threats, which are your traditional hackers, internal threats, which, as I mentioned, are employees. So these are employees who either are unwilling or unable to be trained properly to recognize these threats. And of course, there are organizational or system weaknesses that creates these issues. So we've got the what and we've got the who. What about the why? Well, we've got significant reputational, commercial, and economic risk here. In regulated industries, we've got regulatory and enforcement risk. And of course, we want our organizations to continue to survive during pandemics and during threats like this. So there's business interruption risk. And for us at the personal level, it's risk of identity theft. So I mentioned social engineering earlier on. What exactly is social engineering? Well, it's the acquisition of information through ordinary human interactions for criminal or malicious purposes. And really what it is getting us to do things that we would never ordinarily do. And that is the essence of the emails, these fake or suspicious emails that we will see. So if someone were to walk up to you on the street and say, give me your bank account number, you would never in a million years do that. And yet, when we get these emails and they look and feel like an email that we've received a million times before from Apple or from CRA or from our bank, we don't do enough due diligence to examine that it may be suspicious or fraudulent. And what this tells us is that we have significant confirmation bias issues. So as practitioners in medicine, you will go through a client interview and you will do that to gain and obtain facts about that particular client. And from that, you will land on a conclusion. Well, you try to avoid certain confirmation bias. And what I see on a day-to-day basis is you have individuals who will see a fake email, they'll recognize it as a fake email, and yet they will still click on the link that they know that they should never click on. So that's sort of the background on social engineering. I'll go over some case studies that we've come across in the industry. So here, just to illustrate the types of risk that we all face. So here we have a brokerage team that is notified by their client that the client's traveling, so nothing suspicious there. Purpose of the trip is to have some fun and maybe buy some real estate. During the client's absence, an email is received by an assistant, and the client is saying, hey, I need money to buy real estate. So far, so good. The firm has a policy that says that if we get an email from someone, pick up the phone and call them to confirm those instructions. Client is sent a letter of direction, which is basically a document that says, please confirm what you want us to do. And it's signed, and then the funds are wired. So you know where I'm going with this. What really happened? Well, client's home computer was compromised. So the registrant in this case did nothing wrong except that they acted on that email. So the client signature on the letter of direction, totally authentic. The client had stored their digital signature on their computer. No verbal confirmation was obtained from the client. The wire amount is not a small number in the 7 figures. And of course, when the client is reached, they say, no, it wasn't me. So that's a very common thing that happens in the investment industry. Not the failure, but the fact that these suspicious emails come all the time. So another fact pattern here that might be more familiar to us: client receives an email confirmation from their mobile provider, welcome to online billing. That's strange. I've been with this mobile provider for 20 years. Client acts on it. So the client is vigilant, calls technical support saying, what's this account about? The fraud department says, yeah, we've got a new account on here. Client says, no, that wasn't me. What really happened? Well, someone used the online functionality tool of the mobile company to add this new account. They had a driver's license. They had a social insurance number. The driver's license was valid, so was the SIN number. Driver's license was issued in a different province, so clearly it was stolen. The client resides in a different province to the driver's license. So what really happened here? Client's identity was likely compromised earlier, many years in the past. Credit bureaus like Equifax and TransUnion are contacted to flag the identity as being compromised. Social insurance number is reported stolen. I've got a link there in case you do come across this on how to protect your social insurance number. And it gets better from here for this particular client. Then they find out that my account with CRA was unlawfully accessed. And they only know that because they got an email saying, hey, somebody just accessed your CRA, my account, wasn't them. multiple attempts to access the client profile, both electronic and voice. They all fail because the client has added additional authentication features to the account. And CRA comes back and says, yeah, this is 100% an attempted CERB fraud. So all of that is to lead us to this, which is how do we improve our cyber hygiene? We hear about hand washing and PPE and that sort of stuff. It's no different for these types of risks. I've got a couple links there up on the screen that are from Canada's Cyber Intelligence Agency. They are excellent, and I recommend that people read them. So now there's some just highlights here. Anytime you have a computer or a phone, keep your apps and software current. That way all of the bug patches will be valid. Always, 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 if you can, use multi-factor authentication, which is going to require a password and then a code to be entered. The code will be sent to your mobile phone. If you're doing that, make sure that your mobile phone number can't be ported from your mobile provider. And I get this all the time. If you're going to listen to anything that I say in these 15 minutes, never, ever, ever use public Wi-Fi, ever. We have lots of data on our phone plans. Don't ever use public Wi-Fi. Understand the risks. Keep track of your devices. Don't leave your laptop in your car. Don't leave your cell phone on a table in a restaurant. That's how these things get stolen. Again, it's sort of laughable, but use different passwords and use strong passwords all the time. Don't use 1, 2, 3, 4, 5, 6, 7, 8, 9. That is actually one of the most commonly used passwords. And we talked about this earlier about opening emails. When you do open emails, carefully evaluate the links that are in the emails. And if you're saying to yourself, feeling, well, why would I click on this? It's probably not something you should click on. So do some due diligence about those emails. When you are traveling, in particular in certain jurisdictions around the world, be very, very careful. Oftentimes hotel rooms are searched, and business centers, the place where you go to use a laptop, they are often monitored. When you get a free USB device, throw it in the garbage. If you go to a conference and get a freebie, it's a USB device, do not use it. And avoid using your USB key in any foreign computer. And of course, only use charging equipment you brought with you, and don't plug into a charging port in the wall or in the desk. So just some takeaways. Always use due diligence. When you're getting an email, if it's too good to be true, it probably is. Look at the email, examine the email, no different than you would do anything else. Act on your hunches. If you're concerned, contact somebody, contact CRA, contact your bank, contact your credit card company, and ask them to put additional security features on your account. And remember, in novel situations, these hackers are it's an opportunity for these hackers. They will create the opportunity to try and get something from you. And of course, resist confirmation bias and consider social engineering efforts. And remember that if we've seen a similar email, we can't be complacent on it. And that really is the entire presentation. Thank you very much.
Oh, well, thanks, Sean. I'm way more scared about that than the true corona, I'm afraid.
And I've accomplished my task.
Yes, good. Okay, good. Well, thanks to the three of you. I see we definitely have some questions, and we've got a full 15 minutes, so let's fire away. So first one, I believe, is to Dwayne. Let's see. Yeah, okay. So does the R0 and the transmissibility data take into account the asymptomatic cases? Because we had heard that maybe even as high as 30% earlier on today.
Yeah, thanks, Richard. Yeah, so I can answer a couple of those at once. So yeah, the R0 does take into account asymptomatic cases. That was based on some of the early data that we had with pretty robust contact tracing in families. There's also a second R0 question about secondary spread numbers in comparison. And does that R0 value that I said, does that reflect public health measures that were in place prior to this number? So actually, if you look at the public health measures in place, what those are all intended to do is to drop that R0 value. Every little thing that we do, washing our hands, staying far apart, keeping our groups small, that will reduce the R0 value. And once that R0 value gets to below 1, then the virus can no longer sustain itself. That means that for every 1 infection, you're infecting less people. So R0, the value for this virus is 2. Everything that we do to try and reduce the transmission of it is going to drop that number. Once we get to a R0 less than 1, you'll see those outbreaks going away. And that's why it was so effective when you shut down society. We're not doing anything, not going anywhere. When you are washing your hands. R0 drops to below 1. The initial spike kind of goes down quite rapidly.
Yeah, I saw some data out of Manitoba Health that showed that it did drop below 1, but we have to always remember that it's not zero. People are still transmitting, and that's why it takes takes some time. Yeah. Okay. All right. Good. So, Dr. Benrock, so has the government implemented any programs to repurpose some workers impacted by job losses for healthcare support where resources are needed? So repurposing people from somewhere else into healthcare.
I don't know the answer to that kind of on kind of from healthcare workers, but I do know that here in Manitoba, the government is looking at repurposing healthcare professionals. So there was just a call out in the last day or two for people who have retired, people who have worked in the healthcare to come back. Red River College is doing some work around training to be able to take the swabs, and they've asked for second-year nursing students and above of all kinds, other people who respiratory students and others such as that who have asked to come back and to help support the effort. So I think that they're turning their attention to that. And just as an aside, in education, the schools have come to universities and said, we've made classes smaller. It's a little bit more intensive. Can we have some of your current people who are training to be teachers to come in and help with some of the work a little bit earlier than they would? So I think these things are starting to come up as we see that we have to, increase the amount of people that we have working in some of our sectors.
Yeah, exactly. It's not just about healthcare, it's also about some of the other factors in society. Yeah, great. Excellent answer. So, okay, over to Sean. Yeah, I definitely wanted to ask this. You brought it up. So how do we protect our mobile phone from being ported? And I mean, maybe you need to describe what ported is as well.
That's a great question, and there have been many news reports of this in the media as of late. And really, what porting means is that your mobile number is moved from one provider to another, and it can be moved. At least historically, what has happened is that it can be moved with a simple phone call. And so what you can do to prevent that from happening is contact your mobile phone provider now. And they've taken great steps, at least the mobile provider that I deal with, to make this very, very difficult, so that you can, in the past, could have called them and said, look, under no circumstances are you to port that number from, say, one provider to a different provider unless you speak with me. So it's harder to do it now, but it has happened in the past, and that's why I mentioned it, because I did read it in a news report probably within the last 6 months, and that creates issues if your identity has been compromised and they are able to have your mobile number and they do happen to have your banking password. They can then log into an account, and then if you have two-factor authentication initiated, a code will be sent to your mobile number, which they have. So that's the reason why you want to protect against your phone number from being ported.
Okay. Good. Well, hopefully that I know what I'm doing now. Okay. All right. Going back to Dwayne. So, this is a good question. So if significant long-term complications emerge from the mild, moderate COVID-19 cases, for example, cardiac issues, could this change the public health approach? And do they need to try and take that into consideration somehow?
There's excellent questions there, and that's a good one. I think the public health response has to be focused on protecting as many people as possible, because, we do know that, going in, again, if you're older, if you're diabetic, if you're obese, those are the risk factors for getting bad COVID. So protecting those people is certainly important. But yeah, it's a good question. If there are complications in people that we can't predict coming forward, that's a big problem. And then the reality there would be then let's just do our best that we can to protect everybody by these broad societal measures until a vaccine becomes available. So it's an excellent question. I think, we, even if there are those long-term complications, our basic public health approach that we're doing right now has probably the ability to bear the most fruit. And, keeping yourself safe, and, especially if you're at high risk for bad disease.
Okay, Dr. Benrock, can you give us 3 key points required to form a strong economic foundation for recovery from COVID economic impacts here in Canada?
Oh, okay.
Biggie, hey, just
$1 million
a whole hour lecture there.
$1 million question that we're all thinking about. I think first and foremost, government is going to have to remain active during the COVID pandemic. So the key here is that if businesses and the economy suffers too much during the pandemic, it will significantly restrict the ability of the economy to recover. And we started to see recovery, and you see how quickly businesses can get back up and running. And then we get this second wave that hits us. And so if government pulls out too quickly, that's going to be really, really damaging to the economy. So I think that's point number one. I think point number two is that, we've got to think about how we can get people back to work post COVID and the kinds of jobs that are going to be available at the time. And it's going to require some adjustments to take place, because I think a lot of the service industries that we have probably will take a long time to recover, especially around transport and travel. And so we're going to have to be ready to be able to do that. And I think that this is where institutions of higher education can play a really important role to help people upskill or reskill. But I think one of the things that government can do is really help to connect institutions with industry. And then I think that we're going to have to support the private sector to grow. And in order to do that, we're going to have to keep interest rates low for a little while and not worry too much about paying off the deficit in the short term afterwards. If you think the last time we kind of accumulated these kind of deficits was after World War II. And we paid them off over a long period of time. And as long as we can continue to manage that, we try to keep interest rates low to allow businesses to have relatively cheap money to be able to invest. I think the one factor that we have to really watch is inflation. And if inflation stays moderate to low, we can continue to do that in a longer period to try to fuel the economy to come back post-COVID.
Oh, thank you. It's more than economics 101 in 3 minutes. Okay. All right. So, Sean, I've actually kind of got 2 questions. Are you able to share your screen again quickly, please? I'm not sure. So that'll be the green button right at the bottom. If you hover down at the bottom.
Just 1 second.
Yeah, because there's been a few requests for those websites that you flipped through. So if you could go back to those cyber attack websites, that would be great. And then I'll ask you your question while people write those down.
So does that help?
Yeah, and you flip to the slide that had all the links to the cyber attack stuff. Yeah. Towards the end. There we go. Yeah, that's perfect. Great. So just leave it there. Yeah, thanks. So anyway, the actual question I want to ask you, and I kind of question it myself. And so why can't we use these public Wi-Fi's if you aren't accessing sensitive information while on the public Wi-Fi? And then also maybe can you is the U of M shared Wi-Fi that we all have here at Brody, is that public?
I think the answer to that question is the easiest way to manage risk surrounding public Wi-Fi is to be very careful when you use public Wi-Fi. If you need to use it for some reason, then feel free to use it. I wouldn't be conducting financial transactions on public Wi-Fi. And I'll get to I can't really comment on the U of M site or the Wi-Fi available at the hospital. But generally speaking, the risk is are you using a Wi-Fi network that is what it says it is? So if you walk into a Starbucks in wherever it is, not to pick on Starbucks or any other vendor that offers free Wi-Fi, are you actually on their Wi-Fi network? Or has someone come along and established an identical network called Starbucks or called McDonald's or called whatever? And are you logging into that? The other very common use of Wi-Fi is in airports. And that, again, extremely high risk behavior to engage in. It's especially because it's so unnecessary. When we have data plans that allow us to roam outside of the country, there really isn't any reason to be concerned about the use of public Wi-Fi. If you are going to do that, then I would restrict it to just, maybe I'll stream something from Netflix or something like that. In terms of the local network that you're probably using now, I'm certain that it's secured by the U of M or the other organization that's established it. I have a high degree of confidence of that.
Okay, excellent. Thanks. So then, that's a great description as to what is that public versus semi-private, essentially.
That's right. And if you can identify that this is in fact the Starbucks Wi-Fi that they're offering, then there's less risk. But making sure that it is the key.
Yeah, excellent. Great. Okay, yeah, we've still got a few minutes. So going back to Dwayne, did you comment, or can you compare the mortality rate of the COVID-19, like the 0.6%, to the death rate of the usual annual flu, please?
Yeah, there was a slide I had there before, but basically when you look at the under 60 crowd, certainly the under 50 crowd, the mortality rates are roughly similar. It's still a little bit more for COVID, but not significantly more. It's when you get to that above 65 crowd that the death rate for influenza and COVID differ markedly. COVID's very, very deadly once you're over the age of 60, 65. Under the age of 50, it's still there. It's not bad, and it probably compares reasonably well with influenza, probably a little bit more than flu, but it's a little bit, it's not that much more. It's only when you're above 65 that it becomes a really big problem.
Okay, thank you. And so, Michael, can you expect a K-shaped economic recovery for Manitoba? And not all of us read The Economist, so you might actually have to explain what that is.
So a K-shape would mean that, what I showed there in the diagram was a V shape. Actually, V kind of falling off, not quite recovering. Usually we get a V. If you think of a V, that's usually what we have in a recession. It might be a U, so might have the bottom be a little longer than a V, but that's what we usually observe. A K is when we really have two parts of the economy heading in different directions. So you have a portion of the economy, so you think of the drop is the bar, and then heading in two different directions. One part that's recovering, and one part that's really suffering. I think when you look at those diagrams, I think what you see is the beginning of a K, which is that parts of the economy have recovered, and certain parts are really suffering. And so hospitality, sports, industries are really suffering. And I think that that other parts are beginning to recover. And so I think we're already starting to see that, some without the government closing them down. So, the bottom part of the K, or the downward pointing part, certainly anything that gets shut down, almost goes to zero. If you think of beverage rooms, although we aren't doing that now, but you think of casinos, it goes from whatever you had to zero. Restaurants would be a little less because you can still have takeout, but other sectors have that. And then we see some sectors continuing to grow and to move forward. So I think we start to see that kind of bimodal distribution, and we're seeing that to some extent, partly because of COVID itself and how we're responding, and then a lot of it because of the shutdowns which are occurring.
Okay, right. And obviously would be different in different provinces as well, depending on what the primary industries are and that sort of stuff.
Yeah, I mean, I think one of the things we saw is that, I've been fortunate enough to be able to speak to a lot of CEOs and presidents in the last few months as part of my position here. And one of the things that I'm observing is that those companies that took this seriously right from the beginning and said, what we're going to do is make it a really safe environment for our employees. It's going to cost us a lot, but we are going to do that. I spoke to an alumni who's in China and actually manufactures coffee makers. And she said that they got into making their own masks themselves because it was cheaper. They instituted plexiglass between the workers, and they've had 2 cases since the start of COVID. Those manufacturing firms have continued to function. The workers feel safe. The product is flowing. And those companies have really done well. And they got on it and they invested. It cost them all millions of dollars, but if they got on there really quickly, and then we see other ones, and maybe it's a little easier in companies that have dry production runs as opposed to some of the food services where it seemed to have spread, but it spread in other parts. It spread back in where people were living in the cramped quarters. So those that have invested have been able to continue to prosper during COVID.
Mm-hmm. Well, thanks very much for that. So I would like to just squeeze an extra minute out of the break because Sean, I have to admit I've done this. So the question is simply opening the fraudulent email putting you at risk? And isn't it only when you click or follow that link that's on the email? And how many times have we? I know this is one that I shouldn't open, but I won't click the link.
Yes, no, you're absolutely right. It's best oftentimes in your email browser. You can hover, you can have a view of the email contents without opening it. If you do open it, typically, I can't speak universally, but typically it's not an issue. It's usually not necessary to open it. You can see from your view box or your read box that the email is suspicious. But yes, it's the links that you want to avoid. And usually you see an email from Apple saying, hey, thanks for the purchase. We've just charged your account $99.22. Click here for further details. And you think, well, that's strange. I didn't order anything. I didn't do anything to get this. So, okay, I'll click on that link and check it out. That's usually what happens. But it's getting us to do something that we wouldn't ordinarily do. That is the issue here. So exercising some caution, some diligence in looking at what the link is, hovering over the link to see if it's going to some bizarre site. That's the message.
Well, thanks very much to the three of you. Nice and diverse and pieces of the big picture that we really do need. And we appreciate all the time and effort that you put in. Thank you. And so for all those that need a break, sorry, I took 2 minutes away. We will start at 3. It will be the last hour. It's the final frontier. It's going to be focused mostly on mental health and violence and relationships. So kind of that softer part, but it's still really, really important to understand some of those pieces as to how COVID-19 is affecting that. So we'll be back at just before 3 and carry on from there. Thanks very much. Well, good afternoon, everybody. Welcome back. Hopefully everyone managed to have a quick stretch, bathroom break, whatnot. So we have our last hour of talks here on the Bug Day 2020, talking about COVID-19 and the pandemic. Our first topic coming up, as you can see, coping with COVID-19 and using virtual mental health and substance use care tools. And we have Dr. Jatinder Sareen. He's the department head of psychiatry here at the U of M, and also the provincial specialty lead for mental health and addictions for Shared Health. And thanks very much, Jatinder, for coming and presenting to us. Over to you.
Thank you so much. It's a pleasure to be here. I really want to thank the Bug Day Planning Committee and Dr. Emble for inviting me to speak. So a couple of questions for the audience to think about. Which of the following is not recommended as a strategy for coping with COVID-19 pandemic? Develop a routine, stay informed, but limit the news related to COVID-19, cannabis use, physical exercise, mindfulness-based relaxation like yoga. Manitobans have access to the following free online cognitive behavior therapy focused on the pandemic-related anxiety. And those are the 5 options for you guys to think about. And finally, the third question is, computer-assisted cognitive behavior therapy is less effective than in-person cognitive behavior therapy for major depression. True or false? So by the end of this presentation, you should have the answers to those questions. The key learning objectives are to learn mental health and substance use consequences of COVID-19 pandemic for the public and healthcare professionals, to learn self-help strategies to manage the pandemic as a health care professional, to learn the optimal ways to access mental health and substance use care, including online programming. My disclosure is that I'm a consultant to UpToDate, and I've written the chapter for epidemiology of post-traumatic stress disorder. So Health Canada posted these important areas to think about when we're in the middle of a crisis, and I think we are in this ongoing crisis, that many of us are going to feel a sense of loss of control, being socially excluded, fear of actually getting COVID-19 virus. Very importantly, worrying about losing your job or work and finances, and fear of being apart from loved ones, and helplessness and boredom. A survey of healthcare providers that was done in Ontario that showed that a significant number of healthcare providers are quite stressed related to the COVID pandemic. And these are some of the common things that they're worried about: fear of infecting others, fear of falling ill. So what are some self-help strategies that are available to you? And there are a number of different strategies that are available. I mean, there's so much information out there, but this is actually a pretty helpful resource that was put together by the NCAA that talks about things that you can do to manage the pandemic. The first is really creating a structured, dedicated space, work environment that at home that includes pattern of self-care, creating a routine that is really, really important, even if you're working from home, ensuring that you have structured breaks. Activity, I think we all know that sitting for long periods of time is not a helpful way to manage, but we are often now in Zoom meetings all day, so ensuring that you're having enough exercise is extremely important. Time management, it's really, really important to make sure that you're managing your time and you're not overworking or underworking. And accessibility, ensuring that you have access to your family and friends through virtual means, and really utilize as best as possible all the virtual tools that are available now. Resources, ensuring that you actually have a plan as far as if things do happen, if somebody does get COVID in the family, it's better to have those kind of plans in place and then implement them. And also it's really important to note that Shared Health does have specific guidance and tools that have been developed, and they are available on the website. Stay informed, but limit the news about COVID-19. Some of the unhelpful strategies that are that we do notice are occurring already in Manitoba and other jurisdictions is an increase in alcohol and drug use. We really need to ensure that people are not self-medicating the anxiety and mood symptoms with alcohol and drugs. It certainly does create a negative vicious cycle, and it's really, really important to minimize that, because it does increase the risk of substance use and addictions. There are low-risk guidelines if you are using substances that are available publicly. So these are some of the things to monitor. The frequency in contact. There are the low-risk guidelines around alcohol use and cannabis use. And of course, avoid stockpiling alcohol, cannabis, and other substances. And if you are having difficulties or your family's noticing the pattern, please do reach out for help around substance use. These are sometimes, this slide really shows the low-risk guidelines for alcohol use. So it's important to note that 19% of Canadians use higher than the recommended guidelines around alcohol use. So more than 15 drinks in a week for men, and no more than 3 drinks in a day. And I think women, there are lower amounts that should be utilized. Cannabis use negatively impacts young people. I think, this is right from the Health Canada website, that it's really, really important for people to be aware that youth have a developing brain and up to 25, and the earlier and regular use of cannabis is associated with negative mental health outcomes. So it is important to be aware of that as cannabis is legalized. The last area is to learn the optimal ways to access mental health and substance use care, including online programs. I think many of you should be aware, but Ability CBT is an internet-based CBT program that you can access from any device and any time. This professional program helps address anxiety symptoms related to the unique challenging aspects of the pandemic. This is free for all Manitobans, and it's internet CBT guided by a professional, and it has been shown that internet CBT with therapist assistance is equally effective as in-person CBT for depression and anxiety. So this is a resource that is available and should be utilized. There are lots and lots of mental health apps, and we've chosen a few here to underscore that are free, except for MoodKit, but they're quite useful as far as helping people learn some of the key skills that can help them manage a person's anxiety or depression. Mindshift is an app that's was developed by anxietycanada.com. It's utilized a lot as far as managing different components of anxiety, sleep, depression. MoodKit is also a very good app. CBTI focuses on insomnia, and Calm is also if people are stressed. We've added some of these important links. And the Manitoba Addiction Helpline is also there for people to be aware of. We really suggest kind of a stepped care model for managing if you are feeling distressed. I think one of the most important prevention tools that we have are social support. So reaching out to your family and friends if you are struggling, and ensuring that you are getting the support that you need. The next step would be if you are having significant sleep difficulties or having difficulty with sustained lack of enjoyment of activities, that you reach out to your family physician. If you are and the family physician can help you navigate the system and help to get care. There are each of your areas as far as insurance. Ensure that you're aware of the mental health care available through your employer or union. And then there's also the, if you are in a crisis, please reach out and get care, whether it's through the crisis line or coming to the, if you're in Winnipeg, the Crisis Response Center. So the COVID pandemic has substantial negative mental health and substance use impacts on the public and health care professionals. There are many self-help tools for managing the stress associated with the COVID-19 pandemic, and help is available, and reach out if you do need it. So which of the following is not recommended as a strategy for coping with COVID-19 pandemic? So number 3, cannabis use is the correct answer. Manitobans have access to the online CBT focused specifically on pandemic-related anxiety, and that's Ability CBT. And computer-assisted cognitive behavior therapy is less effective than in-person CBT for major depression, and that's false. Thank you for your attention, and I look forward to questions and feedback.
Well, thanks, Jatinder. I'm sure there'll be lots of questions there, definitely around the apps and for primary care support and that sort of stuff. So good. Okay, so excellent topic coming up next. How to manage relationships in COVID-19 pandemic. So we have Mona Friedenberg now, and so she's a family therapist and practices here in Winnipeg. Hi there, Mona. And so, yeah, let's hear what you have to say.
Hello there. It is so. It's good.
Yes, go ahead. Thank you very much.
Hi, everyone. It is so great to be a part of this day. I'm going to be talking about relationships and the pandemic. Wait a second here. First of all, we're going to talk about the factors that influence breakdown of relationships in a pandemic. And then we're going to talk about strategies for preserving existing relationships in a pandemic. And we'll wrap up talking about strategies for creating new relationships in a pandemic. So, the factors that influence breakdown of relationships in a pandemic. The first one that I want to talk about is isolation. Now, surely we have to do everything that has been recommended to stay safe in our pandemic situation. But we have to be very careful when it comes to our relationships, because the truth is we need to feel close to one another. And the metaphor of the bubble is a really good one, but it also works against our relationships. So be mindful of that. Lots of people talk and say things like, they feel lonely. They're not certain that they have someone close to them in their social bubble. Sometimes people worry about not being in a social bubble at all and feeling completely alone. So isolation, we have to make certain that we're not feeling isolated from the people that we're closest to, and particularly the person that we're in an intimate relationship with. The second point that I want to talk about is that there has been greater emphasis on devices and screen times. And that is working against our relationships in pandemic. So be very careful. It's natural, I suppose, that we turn to information and we turn to different ways to get the stress off of us, but it's working against, at times, our relationships. The third point that I want to talk about is media and social media influences. So if we're always engaged in media and social media influences, that can pull us away from each other at a time when we need to feel close. Our circles have shrunk, and certainly when it comes to intimate relationships, we are looking to be seen and heard by one another. So watch that we're not too pulled in to media, or that we're not overly influenced by social media. Spending too much time, for instance, can really work against our relationships. The next point that I want to talk about is an interesting one. This idea that we're focusing on protecting one another. And that can be good, and it's really necessary in pandemic, but it's not a good thing, and it's not helpful when we're too focused on protecting versus engaging with one another. So when I talk with people, as I do all day and throughout the days and the weeks and the months, I'm most intrigued by the fact that the people, the couples, the people in intimate relationships that have been best at engaging with one another through this are doing the best. So pay attention to that. The next thing that I think has influenced breakdown of relationships in pandemic are the changes. And this is an obvious one. We all know that we've been expected to make change after change after change. And there's something about the human animal. We just don't like that. We don't respond well to it. We prefer for things to be predictable. We want to know and have certainty about certain things, and we just can't. Since this started 7 months ago, we've been exposed to change after change, particularly in our home environments. For many people, homes have become gyms and offices, schools, play zones. This is most notable for people who are raising children, of course, but teens, young adults living at home, but the changes, and they potentially can influence breakdown of relationship in pandemic. So be careful of that. The next thing I want to mention is this, another obvious one, but still, the increased pressure on couples to meet all of one another's needs. It's probably obvious, but I'll still say it. We do know, of course, that the easiest couple to be in during pandemic would be when both parties are introverts. That's a natural couple to do well during the times of pandemic because they treasure their time with each other, and getting a legit way to shut the world out works very well for them. They tend to be homebodies. They tend to enjoy the things and have many, many routines with one another. So couples where one is an extrovert and one is an introvert, that's tricky. It's very, very tricky because, of course, the introvert may be experiencing great joy at the fact that their extroverted partner can't go out and about the way they usually do, but it can be very difficult for the couple to navigate. And extroverts, people who usually keep very, very socially busy, have felt it the most, perhaps. So increased pressure on couples to meet each other's needs based on our different personalities, our different needs pre-pandemic, that can be tricky. The next thing, added responsibilities for families. See a lot of this, hear a lot of it. People are amazing. The stories that I hear of the ways that we've reached out to each other, supported each other. But it's been difficult for families in terms of responsibilities. Things like cooperative grocery shopping for 4 families instead of your own, helping neighbors, and so forth. The elderly, people that we think shouldn't be out and about, can add responsibilities onto families. So the next point that I want to mention, a factor that would potentially influence breakdown of relationships in pandemic, are the occurrences of non-pandemic crises. Because the truth is, life has continued, and that's, again, pretty reasonable, pretty matter of fact. But things like mental health, many people suffer from mental health issues and have episodic periods in their life where they need more support, more care, and that has nothing to do with pandemic and could creep up. Medical crisis, the stories that I've heard, of course, routinely of medical crisis, situations that are, I guess reasonably normal, like heart events, stroke, occurrences of new or pre-existing cancers, like the people that had chronic pain issues and couldn't get surgeries, like hip replacements, people who had injuries right before pandemic and couldn't get repair, like knee injury. And these things really, really take a toll on relationships during the pandemic. Then I want to talk about the prevalence of addiction and addictive type activities. Certainly, we turn often to addiction or addictive type activities to cope when times are tough. I have often joked that I felt like the non-Catholic priest throughout this period, because as soon as I start sessions, people would overwhelmingly tell me, as if they needed to just get it off their chest, that they were drinking more and consuming a great deal more sugar. I think this is reasonable and normal, but we have to watch at times for some people, as long as it's in balance, and we have to watch how it affects our relationships. If I'm turning into an addictive substance to cope, I'm not turning into my partner. And that that isn't ideal. So be careful, watch out for those things. Then the last thing I want to mention here are the struggles to manage extreme emotions. I'm sure we all can pick up on that. We just have to turn the news on these days or listen to social media. People's emotions are exaggerated. They're big. The grocery store events that I've had described to me or that I've experienced myself, we're getting angrier quicker, we're getting sadder quicker. We are worrying to, I was going to say to death, but we worry a lot. Anxiety, anxiousness, lots and lots of evidence that it's increased, and it affects our relationships, our intimate relationships. So that's noteworthy. Okay, so the next thing I want to talk about will be ways to preserve our existing relationships. And there are many ways to preserve. And by the way, I should note that many people have done perfectly well during pandemic in their relationships. In fact, lots of people would say that they've done better. Having said that, many are in crisis too. So number one, prioritize connection times. It's really important. Plan, schedule, do virtual and non-virtual, Zoom coffees, all the different things. Be creative, make adaptations to your pre-pandemic rituals and activities, and stay mindful, both of each other and the people around you. It draws us closer and it keeps everything richer. The next point I want to make is don't allow politeness to supersede honesty. We need each other. We desperately need each other to make it through pandemic in our couples and in all of our intimate relationships. So if you see someone is struggling with mental health, cognitive disorientation, increased alcohol intake, mention it. We need to be seen. Many people are feeling invisible and not seen these days. We need to be seen, and don't be afraid to point that out. It's the right thing to do. Practice kindness and relationship intelligence. This is basic, but it's really ginormous. Talk regularly, listen well, and be kind. I'm going to say that again. Talk regularly, listen well, and be kind to one another. It goes far, and it really makes a difference, of course, in our relationships. In my experience, we all talk a lot and perhaps very well. We're not such good listeners. So make a point and think about that. Next, I'd say make ordinary events special. Send a random delivery treat, even if you're in the other room from your partner. It's a super, super sweet, super, super kind and fun thing to do. Again, the stories that people have told me, I'm ever marveling at people's creativity. Celebrate the occasions, the birthdays, the anniversaries, the graduations. Sure, it can't be the same, but it can be special, and it is special. And I know that people do this and have throughout. Don't lose the momentum, because we're kind of course, in another heavy period. Don't lose your momentum. Explore new or trending social media possibilities together. House party, the latest online things, etc. The next point that I want to make, I say a lot during my regular day. Put your devices away. Put your devices away. Have daily screens off time. Screens off time, really important for couples. Create home sanctuary. Again, protect certain areas of your home. No device zones. For sure, beds and dining room tables would be my thought. I know most people would laugh at that or think that's excessive, but be protective. And smile more often, guys. Just because we're in a pandemic doesn't mean we have to be so serious or stern or unapproachable looking. I know it can be intense, but with all the mask wearing, practice eye smiling. And I do think eye smiling is a thing. I believe it with my heart, even though some people debate that. Be warm, think warm thoughts. We're going to get through this together. And when we talk about our couples and our intimate relationships, we need that from each other. My last point here, choose to step aside of fear-based thinking. It isolates us and it hurts our relationships. Choose to step aside of fear-based thinking. Okay, so the last thing I want to talk about is the fact that we can create new relationships in pandemic. For people who happen to be alone and single, don't lose hope. Stay open-minded and positive. Find ways to engage around you, in your building, in your neighborhood, in your community. They're out there. Again, I can tell you if I got to talk for a very long time, I could tell you story after story after story of people that have connected during pandemic and met new people and made powerful new connections. So don't think if we're heading into another tough period, don't think that that you have to be alone if you're not in a relationship. Be open-minded and positive. Even if you're not a dating site type of person, explore them. Work on them, creating new profiles on them, see what's out there so you can think of yourself as that kind of person. Challenge yourself with new hobbies and activities. People are interested in interesting people, and there's so much to learn, right? Challenge yourself. Reach out to the people that you know well and stay socially comfortable and socially active. That's really an important point, a really important point. Like I mentioned, I'm sure like's been mentioned a few times already today, anxiousness, anxiety is high. And even people that never had anxiety before are feeling more anxiousness. If we hide away all the time, we will lose our social comfort level, our socially active, socially comfortable level will become socially distant, or we'll fear that we've lost skills. Practice talking, practice being, even if it can't be in person. And then find and initiate socially distant activities that are in person versus virtual. Again, we're heading into winter or late fall, but get outside, walk, do things. Us Winnipeggers, we're a tough lot, Manitobans. We have warm clothing, bundle up and find ways to be with people. Okay, so we can't do questions. Hi,
Mona. So we will do some questions. I really appreciate that talk. If you can hang on, and I'm sure we'll have some more questions after the next speakers.
Thank you.
Excellent, thanks. Great talk. Very, very encouraging. Unfortunately, our next talk is kind of on the opposite side, but I think it's really, really important to have both sides of the story. And so I'd like to welcome two speakers. Shane Weppruck and Vivian Smith, they are both detectives here with the Winnipeg Police Services, and they are going to speak about the pandemic and violence. So over to you two.
Okay, you can hear me now, okay?
Yes, yeah, we can see you and hear you.
Okay. Okay. Everything.
Very much.
Okay, I think we're good to go. Just let me know when you're ready for me.
Yep, go right ahead. Thanks.
Okay, first and foremost, I'd just like to introduce myself. I'm Detective Sergeant Shane Weppruck. I'm the Domestic Violence Intervention Coordinator for the Winnipeg Police Service. And joining me today is Detective Vivian Smith, who is an investigator with our Sex Crimes Unit with the Winnipeg Police Service. Before we get going, I would just like to really extend a huge thank you to Dr. Emble and all the facilitators that are putting on this training day. I think it's fantastic, and I feel really privileged to be a part of this. So just a little bit about myself, first and foremost, to start things off, Domestic Violence Intervention Coordinator. I get asked quite often, what does that entail? So I've completed 14 years with the Winnipeg Police Service, currently in my 15th year. I've spent 3 years as an investigator with our domestic violence unit here in downtown Winnipeg. Part of my mandate is providing training, advice, and direction, not only to Winnipeg Police Service members, but also to outside agencies such as yourself and training days such as this. I liaise with outside agencies on a regular basis, including shelters, and really provide that information back to not only investigators within our domestic violence units, but also relay that message to the frontline members who are on the street taking these calls for service. A large part of what I do as well is being involved with domestic violence pilot projects and policy writing, which is something that I'm currently involved with right now as well. I'm a representative on several multi-agency domestic violence committees, really passing that information on to our investigators and our frontline members to give them a flavor with respect to what's happening within the community and really highlight some of the amazing work that is being done in Winnipeg. So Detective Vivian Smith with our Sex Crimes Unit, as I mentioned before, she's currently in her second year with Winnipeg Police Service Sex Crimes Unit. Prior to that, she'd spent a year as an investigator with the Domestic Violence Unit in the North End, which is Division 13. It's important to note that the Sex Crimes Unit investigate all recent domestic-related sexual assaults. So I felt it was only prudent to have Vivian join me here today, especially to address any questions that might arise in relation to sexual assault investigations. Okay, so just to get into the nuts and bolts of what I really want to cover in our short time together today, there's a number of things that I want to address. First and foremost, I want you to leave here today understanding how domestic violence incidents are investigated and how they really differ from other cases that we investigate. I want to really highlight some of the changes that the Winnipeg Police Service made in order to accommodate for the pandemic and the current state that we're experiencing. In addition to that, highlight some of the proactive steps that the Winnipeg Police Service took to really spread the message out there that help is always available for anyone who needs assistance when experiencing domestic violence. So in order to understand the procedure followed when investigating a domestic incident, it's critical that we define what domestic violence really is, because the reason for that, in the context of a domestic violence situation, there's specific policy which must be followed by our investigating members, and I will get into that in just a few moments. But it's violence, threats of violence, or other acts of a criminal nature that may include elements of emotional and psychological abuse committed against a person by that person's spouse, common law spouse, boyfriend, girlfriend, or other intimate partner, past or present. So in the context of a domestic situation, that past or present is very, very critical, because a couple could have terminated their relationship for some time, and then if violence occurs after the fact, it's still considered to be domestic violence, okay? And these relationships also include same-sex relationships, which is important to note as well. So the reason why the definition of domestic violence is important is because when it comes to the context of a domestic situation, there is a policy in place called a mandatory arrest policy. So, or a mandatory arrest procedure, pardon me. Typically in a classroom situation, I would, at this point, I would ask people to raise their hands if anyone in the room has heard of a term called zero tolerance. And I can tell you that typically in my experience, several hands would go up. Well, I can tell you that in Winnipeg, we do not have a zero tolerance policy. Rather, our procedure is dictated by the Criminal Code of Canada. And basically what it states is that when there are reasonable grounds to believe that an offense has been committed in the context of domestic violence, police are obligated to arrest with or without the cooperation of the victim. So this policy recognizes the cycle of violence and removes the burden from the victim with respect to laying a charge. It is important to note that the burden of proof here is reasonable grounds, not beyond reasonable doubt, which is the burden of proof required for a conviction in court. So just to further explain the difference, I'm just going to provide a hypothetical example for you. So say, for example, that an assault occurs in a parking lot, say after leaving an establishment or a mall or a sporting event or something of that nature. If the incident was not domestic related and the victim does not wish to pursue charges, well, police are obligated to adhere to that victim's wishes and no criminal investigation is sought. Now, obviously, depending on the nature of the assault, that could change the scope of things, but I'm speaking hypothetically of like a simple assault, like a fight, for instance, okay? Now, that's obviously different in the context of a domestic incident, because if it's identified to be domestic violence, police are obligated to pursue that investigation. So domestic assault is certainly not a charge that you're going to find anywhere in the criminal code. And these are just some examples with respect to the charges that can be laid in relation to a domestic incident. Again, so we have assault, and assault can range anything from a simple assault, which, like I say, it could be a slap or something, or a fight, something like that, more like physical force. And it could be all the way up to an aggravated assault, which is the potential to cause grievous bodily harm or permanently maim somebody. Okay. We have charges of a sexual assault. Now, sexual assaults do happen in the context of domestic violence. And as I indicated before, our sex crimes unit investigate those incidents. Utter threats and criminal harassment are other common charges that are laid. And again, these are just some of the common charges, that there are others as well. It's important to note that there was a Supreme Court of Canada decision that was laid in 2011, which states that consent must be ongoing. So what that means is that in the context of a sexual encounter, it can certainly start out as being consensual. However, that consent may be revoked at any time. And anything that happens after that consent is revoked is deemed to be sexual assault. When COVID first arrived on scene, there was a number of quick steps that had to be taken by the Winnipeg Police Service to ensure the safety of our sworn police members, our civilian staff, and in addition to the citizens that we serve and protect on a daily basis. These safety concerns were made in accordance with Manitoba health regulations. And just to highlight some of the changes that we went through, first and foremost, health-related questions were asked to those contacting our communications center, which will assist with risk assessment in relation to COVID. Okay, so those health-related questions that information would be asked to someone calling in to our communications center to report a crime. And that information then in turn was provided to our frontline members that were attending that call for service. Now, these are just some additional questions that were asked, but in addition to all the normal questions that would be asked upon a person when they were entering a call. Now, our frontline members were also trained to recognize symptoms and to screen people as well with health-related questions when they arrived on scene. Members were advised to make efforts to socially distance themselves when possible. Now, for example, that might be conducting an interview in a parking lot or in a hallway, and really just try to avoid having those conversations in confined spaces if at all possible. Members were issued personal protective equipment and are continually being provided messaging regarding its use. Restorative justice involves programming where people who are arrested complete programming within the community, provided that that particular incident meets criteria. When participants complete their programming, the charges are then diverted and they end up not having a criminal record as a result. The Winnipeg Police Service is committed to the restorative justice program, and some changes were required to ensure its continued success throughout the pandemic. Now, prior to COVID, any person who was referred to restorative justice received a 3-month court date, as opposed to what's normally provided, which is 6 weeks. So this 3-month court date was in place to allow for programming to occur. Because some programming takes place in group settings, that just simply was not permissible due to the regulations that were in place due to the pandemic. So the process had to be changed. And what ended up happening was the court dates were extended by an additional 3 months. So anyone now who's being referred to restorative justice is released on a 6-month court date to allow for that programming to occur. So this change in process was comprehensive. However, with the collaboration of the Crown's Office and Restorative Justice Center, the change was quickly implemented, and the restorative justice program really hasn't missed a beat throughout the pandemic. And it continues to be extremely successful. As the pandemic wore on, now there were concerns brought forward due to people being isolated within the home. These concerns were shared by the Winnipeg Police Service, as the reality is that home just is not safe for everyone. Domestic violence abusers use power, control, and fear to maintain control over their victims. A concern was that this mandated isolation could potentially enable an abuser. So in response to these concerns, the Winnipeg Police Service took proactive measures to assist those who may be suffering in silence while broadcasting the message that help is always available. On April 29, 2020, the Winnipeg Police Service launched a domestic violence site that is devoted to domestic violence. The vision for this website was to provide a central access point for anyone living with abuse, or potentially for someone who is seeking for information on behalf of a loved one who's living with this abuse. Information to the legal aspects of domestic violence, in addition to information regarding making application for protection orders, is all included on our website. In addition to that, though, the website provides access to resources and supports, including hyperlinks to those respective resources and supports that will take them directly to their website. I think this is critical because as we know that no two domestic violence situations are the same, and this way people can really navigate the website and find what resources that they relate to and find what they're comfortable with tapping into as far as resources go. This website was promoted with the assistance of mainstream media who were of huge assistance in broadcasting this message and really promoting our website. And it was also showcased through our social media within the Winnipeg Police Service. This is an example of a Facebook post that was put on the Winnipeg Police Service Facebook page on April 29th, just promoting the website and the information that's contained within it, okay? This is an example of another post that was put up on July the 7th. Really, as I stated earlier, recognizing when home is no longer safe. We recognize that home might not be the safest place for some people, but we really wanted to get a conversation started and keep that conversation going that, you know what, there's always help available. And as a service, we're certainly prepared to take those steps with that person, recognizing that, you know what, the first steps really are the hardest.
Hi, Shane. Just to let you know, there's 3 minutes left.
Okay, perfect. Another big portion of what we did in partnership with shelters, lines of communication were kept open to keep up to date with operating practices. It was learned that shelters were not only open, but were following protocols to ensure the safety of people requiring their services. Now, this information was passed on to the frontline members to assist with the investigation and provide comfort to those who may need to use a shelter. Some people indicated they were more inclined to stay in an abusive home because they were more fearful of the virus. Now, officers were able to address those concerns and pass that on to the people that they were assisting. I recall one particular case where a shelter was able to accommodate a large family as part of safety planning and ensure their safety. So our partnership with the shelters is absolutely huge, and I can't state enough how great that partnership has been. So November, we're almost on the end of November, and November is Domestic Violence Awareness Month, and the Winnipeg Police Service will continue to broadcast the message that help is available. Members of our community relations unit will be in the community spreading this awareness. Our work here is never done. Domestic violence is a community issue that has a ripple effect throughout society as a whole. The goal is to start the conversation that nobody should have to live with domestic violence and that help is always available. So this is just a sneak peek of what's to come. This is a public service announcement that will be broadcast in November, and it was published here at the Winnipeg Police Service.
The first step is the hardest. We can take it together because no one should suffer domestic or partner violence alone.
So the aim there is to really just get that conversation going. As I stated before, domestic violence is a community issue. It affects every corner of our city, and it's something that we can't solve as a service alone. We need the community's assistance to do that. And in closing, I would really just like to say thank you. Thank you for this opportunity to showcase some of the work that we've done. Thank you for providing this training. And most of all, I really just want to thank you for all that you folks are doing in the community. You do a great job. You do some really tough work, and it doesn't go unnoticed. So thank you, thank you, thank you.
Well, thank you, Shane. That's a very, very heavy topic. But I also like to thank the other speakers. This is a completely different way of finishing the day, but I think it's very, very important component to dealing with pandemic. I mean, it's something that often is just pushed to the side, and it's really, really good to see all these supports and ideas and new programs that are being put in place. Okay, so we definitely have some questions, actually quite a lot of questions, so that's good. And we have a full 15 minutes. So I'll start with Jatinder. So on Slido, our first one is, so the Ability CBT app does not actually have anyone interacting with the client. So how can they personalize that treatment and care? Oh, you're going to put your, you're unmute still, yeah.
So the Ability CBT app is both has an online component as well as therapist assistance. So there is a combination of both working through the material at your own pace, but there's also a therapist that's providing support.
Okay. All right. And is it like you able to pick up that therapist that provides support like within 24 hours? I mean, they can't be sitting by the phone all day.
Yeah, I mean, it is a national network of therapists, so there is a process. It's not an urgent emergent service. It is a service that's more of an outpatient. But the idea is that if somebody's struggling with the online material, that they're actually getting support with that. And that's what's been shown, is that the computer-based therapies, if you just kind of say, go use a computer, people don't necessarily utilize them that well. But if you have some therapist assistance, the person can stay on task and get support and individualize.
Okay, excellent. All right, well, thank you. And now, Myrna, we've got a few questions here. This is a good one, and actually it could potentially link in with our last speakers as well. So how important is it to set boundaries from others, especially family, and if they are COVID deniers? And so how does one actually do this? And then just PS, I can hear your smile in your voice and not just the eyes.
That's a great question. Yeah, boundaries are very important. And especially if the people like extended family see things differently than you do. So this is a time, I mean, I think it's always time, but this is a time in our history and in our lives where we have to learn how to make important boundaries and stick by them. And since I talked about protecting relationships, preserving relationships, intimate relationships, I think that when we, for instance, set aside a time just for us, we need to honor it no matter what other person may call upon us in terms of extended family.
Mm-hmm.
Okay. So how do we do it? I guess it's clear communication, right? And not backing down from how we set it up.
Yeah. Okay. Which isn't easy.
Which isn't at all easy,
Yeah, especially if it's especially if there's flashpoints. But
yep.
Okay. So over to Shane. So what can children / teens who are at home in negative situations do when they cannot leave and no longer have safe haven from school or friends, etc.? And I know I came across this quite a lot in practice when schools had actually shut down. Can either of you come up with something?
Hi there. Can you hear me?
Yes.
Okay. So, yeah, I mean, that question, I think, falls more so in the realm of our child abuse unit, but I can tell you that in my experience, I know that certainly has been a concern that's come up. I've heard it. I work in the same division as child abuse. You know what? Without speaking out of turn, I would suggest that, most children have access to whether it's some sort of social media. I know that I'm going to speak from my present situation at home. My son is having conversations with his friends through different messaging apps and things like that. And I would certainly encourage them to seek help that way and to try and reach out to somebody that they trust, or somebody that they can help them with gaining that assistance. That would be the first thing that I could suggest off the top of my head. But again, that really falls into the expertise of child abuse. Are we froze up?
Richard, you're on mute.
Oh, sorry. On mute again. All right. Okay. Well, thanks, Shane. Yeah, obviously apps and that private communication is super important, but then we also heard a person earlier on about cybersecurity. So it's always tough as parents. I definitely see that.
Absolutely, most definitely is.
So continuing in the children's realm, and sorry, Jatinder, I appreciate that you're not a child psychiatrist, but there's a question here. So are there any apps or resources that you would recommend specifically for children and youth who are feeling stressed during the pandemic?
Yeah, I mean, I think the Ability CBT app is, 16 and older can utilize that. The apps that we've put as far as Mindshift and some of the other apps that are there, Calm in the Storm, those really are generalizable to kids. But I think, so there are, and then if you look up on the apps, there are specific ones that may be for youth, but the ones that I showed have utility across adults and youth. I don't know if others, Myrna, if you have any other additional thoughts on that.
Myrna, any other? Yeah, there we go.
Thinking resources for kids. I'm sorry, yeah, I didn't come prepared. I'm not in my office today. I'm working at home, and I apologize. I don't have a list. There's books that I often recommend for children in terms of anxiousness and anxiety, but in terms of social media or apps, there are good ones out there. But sorry, off the top of my head, I don't have anything to add to that.
All right. Okay. So actually, this would probably be for both Myrna and Jatinder. How can one cope with this mental exhaustion that has translated into physical exhaustion, and just with this ongoing, it just never lets up, the news and bad news and good news, bad news, or all the things that are happening in this pandemic. And I'd actually open this up to all of you.
Yeah, and I think some of the comments that Myrna made were really, really important. And I think what I suggested was really trying to limit the amount of information overload that people are getting. I think being away from the devices is an important, issue that we all struggle with. We're all connected to our phones and our devices. And I think, as Myrna was saying, that we're not really, we don't like change. As humans, we're not wanting change. And this is really an uncertain time where we are having to deal with regular change. So what we really highly recommend is really sleep is the most important restorative thing to do. We're so trying to ensure that we're getting lots of sleep, doing lots and lots of exercise, and being with nature as much as possible. So those would be some of my comments, but maybe I'll turn it over to Myrna.
Yeah, Myrna.
Yes, and things to add onto that too, like touching each other, hand holding, cuddling, like just unplugging. So when people are really, really exhausted, to follow with the device piece and all the overflow of information and emotional content to info, often I'll just suggest to people that they literally take a Friday night to a Sunday morning off, that the couple or the family park all devices, the purpose to not watch news, do things like, if the weather's not great, binge watch some Netflix or some Prime Video, something that's soft and funny, like to get belly laughs going, just do basics like make, soup from scratch or bake cookies from scratch, like just ordinary grounding things to bring us far away from what's going on around us, and to give a mental and emotional and spiritual break, which we all need these days.
Yeah.
And I think if those things aren't working, it is possible that somebody could be suffering with a depression or anxiety if they are bouncing back from some of the strategies. So if they're having, difficulties with sleep that are ongoing for more than a couple of weeks, if they're not able to enjoy things, that's not just 1 day or 2 days, but ongoing, then it is important to reach out to your primary care doc and get an assessment to make sure that you're not depressed, right? I mean, this is an extremely stressful time, and things can happen. And it's really, really important to note that there are lots of good, effective treatments available for depression and anxiety. People, family docs are very good at being able to assess and help people recover.
Okay, good. And Mona, anything?
Yes, I was just going to say, absolutely, absolutely. Don't be afraid to reach out for help. This is not it's been 7 months, I guess, over. Like, we all are feeling it. And if in fact you're alone and none of the ordinary things are helping to lift your sense of complete and utter exhaustion or panic or whatever it is, go talk to someone, reach out for help, for sure. For sure.
Yeah, excellent. All right. So I do see there's 2 questions here for Shane. They're kind of the same. So it's just about numbers. So with the pandemic, how much more of an increase has the law enforcement seen or experienced kind of those anonymous reporting by people compared to pre-pandemic? And can you kind of give us a percentage of that increase in domestic violence? If I'm making the assumption it has actually increased.
Hi there. So when it comes to statistics, our statistics are highly unreliable. And the reason for that is because right now, we're caught in the middle of a pandemic. So I know that this has been brought up before, where people are wanting to know what the trends are. Unfortunately, I'd be speaking out of turn to even comment on what the trends are and how the pandemic has affected what's going on, because reality is we're very much still in the middle of a pandemic. Now, as far as percentages of increases and things of that nature, I don't have those numbers. What I can tell you is that our numbers are actually published on our public website, if you want to go there and find them. So if you were to go to winnipeg.ca/police, and you go under the crime maps call for service tab, you can actually enter in under service type disturbances /danger, and then under the event type family or domestic trouble, and really isolate those incidents, and it'll give you a 10-week period of the numbers that are published on our public website. And I can tell you, when I'm looking at them, I really don't see a noticeable increase or decrease in those numbers. So to really comment on what effect the pandemic has had over the numbers of calls for service we're seeing, I just don't think it would be fair for me to really comment on that. I'd be speaking out of turn because, as I stated before, we're very much in the middle of this. In fact, we're seeing some of the highest case counts now that what we've seen in the 7 months. And I think it's going to take a long time until we can really interpret what all of this means and how the effects, what the effects really truly are. I think that we're going to hear stories when this is over, and some of the stuff that's going to come out. And as I can tell you from my personal experience, I really hate the thought of anyone really suffering in silence at home who needs help, which is why as a service, we've been taking all of these proactive measures to really broadcast that message and get the message out there that help is available. And there are several ways to make that report. Whether that's telling a friend. I can tell you that I was involved in an investigation not that long ago where it was actually reported by a third party because that particular person didn't feel safe making the report themselves. So that investigation was forwarded on to a domestic violence unit who followed it up because it was highly sensitive to try and safety plan and ensure the safety of everybody that was involved in this particular case. So unfortunately, I don't have those exact numbers because they're just not available yet. If that makes sense.
Yep. No. That's good. I understand statistics can sometimes be very, very difficult to actually track the numbers down. Yeah.
Right, and I can certainly appreciate that people want to know that, but again, when you're looking at statistics, you got to really ensure that you're looking at them through the correct lens and you're interpreting them the proper way. The last thing I would want to do, like I say, because we're really caught up in the middle of this right now, to offer some sort of a theory, because that's really at the end of the day all that it would be. It would be a theory that I would have, and I don't think that would be fair for me to mention anything like that. I want to provide the most accurate information, if that makes sense.
For sure. Well, thanks very much.
More than welcome.
So I do want to indulge you guys. Just one last question, and I think we haven't quite touched on it yet, but and this is actually one of Myrna's questions, but anyone can answer it. So what do you recommend for those who live alone, no real strong family connections, and then they live rural Manitoba? And we've talked a lot about urban, but what about rural? Jatinder, any ideas?
Yeah, I mean, I think the good thing now is that we have things like Facebook, FaceTime, and all these kind of virtual apps. I think, if the pandemic had hit 20 years ago, for example, in the 1990s, we would be a lot more isolated. And I think, it is extremely important to utilize as many of those tools as possible to reach out and talk to people and telephone and create routines around that. Because I think, we know that many of us have family members that are in different provinces and different countries, and we can't go out and hug them. And so it is really, really important to make that regular effort. Our family's created a Zoom call every Saturday where we have family members from India, North America gathering, and I think we need to create those regular structures so that people are feeling connected.
Excellent. And Myrna, anything to add?
So certainly we're in all of this. I'm most concerned about the people that live alone and that are socially isolated. And if you're rural, that would certainly add more to it. So I definitely agree with the comments that Jatinder made about the benefits of social media and the tools out there. So that's wonderful. I would point out that someone living rural probably does have more skills than the average person around getting their needs met. So that's awesome. Focus on that a bit. Likely, they would also probably need just a little bit less than somebody that's never had to make a go of it on their own. So very powerful things like a regular Zoom date, a connector date with other people could make a world of difference, like a weekly or a scheduled event with friends from different towns or from, Winnipeg, whatever it would be. That could probably make a big difference for someone like that.
Well, I really appreciate, we just 5 minutes over, but all things considering, I think it's been a fantastic day. So much information. Thanks very much to our speakers, our last speakers. And thanks very much to everyone that has hung in there. It's when it's face to face in an auditorium, 7 hours is tough. And this essentially is, we've been online for close to 8 hours, and I really appreciate for everyone. I've seen some of the numbers have stayed high, so that's really good, even though we had a really some heavy discussions here at the end. They stayed up, and that's important. So appreciate it. The speakers. I really would like a big call out to John and all his hard work that he did behind the scenes here to get this up and running. As usual, Bug Day is always such an amazing experience and definitely a success. And actually, the people that probably need the greatest thanks, Lenore Chipman and Anna and Amanda and Dory, these are all our coordinators that are sitting in the background managing. You don't actually realize it might be Zoom, but there's a lot of stuff that happens in the back, and I really want to say a big thank you to all the support and for the hard work they did in preparing this. I'm sure some of the speakers can attest to the amount of emails that they got in preparation for this. So thanks very much, everybody. And this was all done on YouTube, and I believe in about a week, the actual link will be available. It'll be posted on the CPD webpage. And so, as I said in the beginning, if you want to go through everything again and binge watch a little Bug Day, you'll get it. Okay, so thanks very much.
I just wanted to make a note that the YouTube link will be searchable in about a week or so. They don't have to go to the CPD website. They just search Bug Day 24th annual Bug Day and they'll find it.
Okay, good. Thanks, Lenore. Excellent. Okay. Thank you, everyone. Bye.